Allergy and Asthma Treatment Center, a unit of NCD Immunomedicare Private Limited, is a pioneer institute in Eastern India in treating allergy and asthma. It was originally conceived and conceptualized by Center under the able stewardship of Dr. Arijit Das. Allergy and Asthma Treatment Center, a unit of NCD Immunomedicare Private Limited, is a pioneer institute in Eastern India in treating allergy and asthma. It was originally conceived and conceptualized by late Professor Dr. Sachin Chaudhary and late Brigadier Dr. Nirendra Chandra Das. Since 1980, Allergy and Asthma Treatment Center, under the able stewardship of Dr. Arijit Das, along with 10 eminent doctors, has been striving hard to attain a scientific and rational approach to the diagnosis and treatment of allergic and atopic disorders, becoming an acclaimed and trusted name in the industry. Patients do come from far-flung places, not only from the different districts of West Bengal, but also from neighboring states and Bangladesh. We have our own diagnostic center where we have very high quality diagnostic instruments for both in vivo and in vitro tests and different types of lung function tests. The instruments are one of the best in the field of our specialization and are procured mainly from Germany, UK, Switzerland, USA and other countries. For allergy tests, we have both in vivo and in vitro facilities like skin prick test or SPT, which is being accepted as gold standard by WHO. In vitro, we have serum allergy profile tests, etc. We do some special allergy disorder related tests like Aspergillus IgG and IgE, eosinophilic catanic protein or ECP, human IgG4, Protea QS64, so on and so forth. We have a gamut of products for lung function tests like pulmonary function test or PFT, bronchial provocation test or BPT, fractional exhaled nitric oxide or FeNO, impulse oscillometry or IOS, diffusing capacity of lungs for carbon monoxide or DLCO. Allergy and Asthma Treatment Center also provides a unique and systematic approved method of treatment of allergic disorders in the form of allergen immunotherapy. Allergy and Asthma Treatment Center also provides a range of licensed immunotherapeutic vaccines administered by trained allergists along with a team of trained technicians. This is one of the most outstanding and cost-effective treatment procedures provided by Allergy and Asthma Treatment Center for allergic disorders. Subcutaneous immunotherapy or SCIT is the most commonly used and most effective form of allergen immunotherapy, which is being provided by Allergy and Asthma Treatment Center. Allergy and Asthma Treatment Center, a unit of NCD Immunomedicare Private Limited, is a pioneer institute in Eastern India in treating allergy and asthma. It was originally conceived and conceptualized by late Professor Dr. Sachin Chaudhary and late Brigadier Dr. Nirendra Chandra Das. Since 1980, Allergy and Asthma Treatment Center, under the able stewardship of Dr. Arijit Das, along with 10 eminent doctors, has been striving hard to attain a scientific and rational approach to the diagnosis and treatment of allergic and atopic disorders, becoming an acclaimed and trusted name in the industry. Patients to come from far-flung places, not only from the different districts of West Bengal, but also from neighboring states and Bangladesh. We have our own diagnostic center where we have very high quality diagnostic instruments for both in vivo and in vitro tests and different types of lung function tests. The instruments are one of the best in the field of our specialization and are procured mainly from Germany, UK, Switzerland, USA and other countries. For allergy tests, we have both in vivo and in vitro facilities like skin prick test or SPT, which is being accepted as gold standard by WHO. In vitro, we have serum allergy profile tests, etc. We do some special allergy disorder related tests like Aspergillus IgG and IgE, eosinophilic cationic protein or ECP, Hem and IgG4, Protea QS64, so on and so forth. We have a gamut of products for lung function tests like pulmonary function test or PFT, bronchial provocation test or BPT, fractional exhale nitric oxide or FeNO, impulse oscillometry or IOS, diffusing capacity of lungs for carbon monoxide or DLCO. Allergy and Asthma Treatment Center also provides a unique and systematic approved method of treatment of allergic disorders in the form of allergen immunotherapy. Allergy and Asthma Treatment Center also provides a range of licensed immunotherapeutic vaccines administered by trained allergists along with a team of trained technicians. This is one of the most outstanding and cost-effective treatment procedures provided by Allergy and Asthma Treatment Center for allergic disorders. Subcutaneous immunotherapy or SCIT is the most commonly used and most effective form of allergen immunotherapy, which is being provided by Allergy and Asthma Treatment Center. Allergy and Asthma Treatment Center, a unit of NCD Immunomedicare Private Limited, is a pioneer institute in Eastern India in treating allergy and asthma. It was originally conceived and conceptualized by late Professor Dr. Sachin Chaudhary and late Brigadier Dr. Nirendra Chandra Das. Since 1980, Allergy and Asthma Treatment Center, under the able stewardship of Dr. Arijit Das, along with 10 eminent doctors, has been striving hard to attain a scientific and rational approach to the diagnosis and treatment of allergic and atopic disorders, becoming an acclaimed and trusted name in the industry. Patients to come from far-flung places, not only from the different districts of West Bengal, but also from neighboring states and Bangladesh. We have our own diagnostic center where we have very high quality diagnostic instruments for both in vivo and in vitro tests and different types of lung function tests. The instruments are one of the best in the field of our specialization and are procured mainly from Germany, UK, Switzerland, USA and other countries. For allergy tests, we have both in vivo and in vitro facilities like skin prick test or SPT, which is being accepted as gold standard by WHO. In vitro, we have serum allergy profile tests, etc. We do some special allergy disorder related tests like Aspergillus IgG and IgE, eosinophilic cationic protein or ECP, human IgG4, Protea QS64, so on and so forth. We have a gamut of products for lung function tests like pulmonary function test or PFT, bronchial provocation test or BPT, fractional exhaled nitric oxide or FeNO, impulse oscillometry or IOS, diffusing capacity of lungs for carbon monoxide or DLCO. Allergy and Asthma Treatment Center also provides a unique and systematic approved method of treatment of allergic disorders in the form of allergen immunotherapy. Allergy and Asthma Treatment Center also provides a range of licensed immunotherapeutic vaccines administered by trained allergists along with a team of trained technicians. This is one of the most outstanding and cost-effective treatment procedures provided by Allergy and Asthma Treatment Center for allergic disorders. Subcutaneous immunotherapy or SCIT is the most commonly used and most effective form of allergen immunotherapy, which is being provided by Allergy and Asthma Treatment Center. Center under the able stewardship of Dr. Arijit Das, along with 10 eminent doctors, has been striving hard to attain acclaimed and trusted name in the industry. Patients to come from far-flung places, not only from the different districts of West Bengal, but also from neighboring states and Bangladesh. We have our own diagnostic center where we have very high quality diagnostic instruments for both in vivo and in vitro tests and different types of lung function tests. The instruments are one of the best in the field of our specialization and are procured mainly from Germany, UK, Switzerland, USA and other countries. For allergy tests, we have both in vivo and in vitro facilities like skin prick test or SPT, which is being accepted as gold standard by WHO. In vitro, we have serum allergy profile tests, etc. We do some special allergy disorder related tests like Aspergillus IgG and IgE, eosinophilic cationic protein or ECP, human IgG4, Protea QS64, so on and so forth. We have a gamut of products for lung function tests like pulmonary function test or PFT, bronchial provocation test or BPT, fractional exhaled nitric oxide or FeNO, impulse oscillometry or IOS, diffusing capacity of lungs for carbon monoxide or DLCO. Allergy and Asthma Treatment Center also provides a unique and systematic approved method of treatment of allergic disorders in the form of allergen immunotherapy. Allergy and Asthma Treatment Center also provides a range of licensed immunotherapeutic vaccines administered by trained allergists along with a team of trained technicians. This is one of the most outstanding and cost-effective treatment procedures provided by Allergy and Asthma Treatment Center for allergic disorders. Subcutaneous immunotherapy or SCIT is the most commonly used and most effective form of allergen immunotherapy, which is being provided by Allergy and Asthma Treatment Allergy and Asthma Treatment Center, a unit of NCD Immunomedicare Private Limited, is a pioneer institute in Eastern India in treating allergy and asthma. It was originally conceived and conceptualized by late Professor Dr. Sachin Chaudhary and late Brigadier Dr. Nirendra Chandra Das. Since 1980, Allergy and Asthma Treatment Center, under the able stewardship of Dr. Arijit Das, along with 10 eminent doctors, has been striving hard to attain a scientific and rational approach to the diagnosis and treatment of allergic and atopic disorders, becoming an acclaimed and trusted name in the industry. Patients to come from far-flung places, not only from the different districts of West Bengal, but also from neighboring states and Bangladesh. We have our own diagnostic center where we have very high quality diagnostic instruments for both in vivo and in vitro tests and different types of lung function tests. The instruments are one of the best in the field of our specialization and are procured mainly from Germany, UK, Switzerland, USA and other countries. For allergy tests, we have both in vivo and in vitro facilities like skin prick test or SPT, which is being accepted as gold standard by WHO. In vitro, we have serum allergy profile tests, etc. We do some special allergy disorder related tests like Aspergillus IgG and IgE, eosinophilic cationic protein or ECP, human IgG4, Protea QS64, so on and so forth. We have a gamut of products for lung function tests like pulmonary function test or PFT, bronchial provocation test or BPT, fractional exhaled nitric oxide or FeNO, impulse oscillometry or IOS, diffusing capacity of lungs for carbon monoxide or DLCO. Allergy and Asthma Treatment Center also provides a unique and systematic approved method of treatment of allergic disorders in the form of allergen immunotherapy. Allergy and Asthma Treatment Center also provides a range of licensed immunotherapeutic vaccines administered by trained allergists along with a team of trained technicians. This is one of the most outstanding and cost-effective treatment procedures provided by Allergy and Asthma Treatment Center for allergic disorders. Subcutaneous immunotherapy or SCIT is the most commonly used and most effective form of allergen immunotherapy, which is being provided by Allergy and Asthma Treatment Center. Allergy and Asthma Treatment Center, a unit of NCD Immunomedicare Private Limited, is a pioneer institute in Eastern India in treating allergy and asthma. It was originally conceived and conceptualized by late Professor Dr. Sachin Chaudhary and late Brigadier Dr. Nirendra Chandra Das. Since 1980, Allergy and Asthma Treatment Center, under the able stewardship of Dr. Arijit Das, along with 10 eminent doctors, has been striving hard to attain a scientific and rational approach to the diagnosis and treatment of allergic and atopic disorders, becoming an acclaimed and trusted name in the industry. Patients to come from far-flung places, not only from the different districts of West Bengal, but also from neighboring states and Bangladesh. We have our own diagnostic center where we have very high quality diagnostic instruments for both in vivo and in vitro tests and different types of lung function tests. The instruments are one of the best in the field of our specialization and are procured mainly from Germany, UK, Switzerland, USA and other
হ্যালো, হ্যাঁ
হ্যালো।
হ্যাঁ কৌশিক, শোনা যাচ্ছে?
হ্যাঁ,
গুড
আমার
মর্নিং।
কথা শুনতে পাচ্ছো? গুড মর্নিং, গুড মর্নিং।
হ্যাঁ হ্যাঁ হ্যাঁ, শোনা যাচ্ছে।
উদা স্যার, গুড মর্নিং।
গুড মর্নিং, গুড মর্নিং।
একবার শেয়ার স্ক্রিন করে দেখে নিচ্ছি। হ্যাঁ,
হুম, দেখে নাও।
দেখা যাচ্ছে? স্লাইড দেখা যাচ্ছে?
স্লাইড ভিউতে দেখা, তুমি স্লাইড ভিউ করে নাও।
দেখা যাচ্ছে?
না, হ্যাঁ এবারে হয়েছে, ঠিক আছে ঠিক আছে। হুম,
দেখা যাচ্ছে তো?
ঠিক আছে।
ওকে ওকে।
To another hall only.
Good morning, sir. Hello.
গুড মর্নিং।
Good morning, sir. Good morning, madam.
গুড মর্নিং শাম্বো।
হ্যাঁ স্যার, ভালো আছেন স্যার?
তোমাকে অনেকদিন পরে দেখছি, খুব ভালো লাগছে। ছাত্র অবস্থায় দেখেছি, খুব ভালোভাবে প্রোগ্রাম করো।
এখনো স্যার আমরা ছাত্র অবস্থাতেই রয়েছি স্যার আপনাদের কাছে।
এ ডক্টর ইজ এ স্টুডেন্ট টিল টু দ্য লাস্ট ডে। সবাই, আমিও ছাত্র, এই জন্যই তো শুনছি তোমাদের। ঠিক আছে, তোমার সব স্পিকাররা এসে গেছে?
হ্যাঁ স্যার, আমি দেখে নিচ্ছি স্যার। অরিজিৎ, তুমি শুনতে পাচ্ছ? অরিজিৎ, হ্যালো।
Yes, sir. I can hear you. বলুন।
মডারেটর ডক্টর জয়েন করেছেন?
Yes, sir. Yes, sir. I'm here. I'm here, sir. Good morning.
So you have to introduce our honorable chairpersons first.
Yes. Yes,
And I think Kaushik is there also. Kaushik will project the CV slides for our chairpersons and speakers.
sure. Sure.
And we will start accordingly. Okay. So,
Yeah,
so,
yeah.
so I think 5 minutes left.
All right. Thank you. We'll do that, sir.
Ushida, please project the CV slides.
Kaushik, the hall এতেও তোমার CV slide project করতে হবে।
গুড মর্নিং অরূপ স্যার।
ও নন্দিনী, তুমি তো রয়েছো, আমি এত বুঝতে পারি না গো। তুমি অনেক কিছু করছো, এখন তোমার সঙ্গে আমি থাকলে ভালো হতো। সেই মনে পড়ে কত ছোটবেলায় কি দৌড়ঝাঁপ। খুব ভালো তুমি করছো, আমি খবর পাচ্ছি। করো, এখন আর
Thank you,
লিখতে
sir.
ভাল লাগে না, নইলে তোমায় অনেক লেখা পাঠিয়ে দিতাম। আমি খুব
Sir.
125 খানা ইন্ডেক্স লিখেছি তোমায় পাঠিয়ে, তুমি লেখো, আমার ভালো লাগে। খুব ভালো, সবাই
Thank
ভালো
you,
আছো?
sir.
ওকে
হ্যাঁ ঠিক আছে।
ওকে।
Good morning, Dr. Somasdar. Can you hear me?
We can hear you.
Yeah. Sir, till we have 4 minutes left for 10 o'clock. So can we
Okay.
wait or we'll start?
I think we should wait.
We should
Let's,
wait for 5 minutes.
For 4
Yeah.
minutes. We must be in time.
Yes, sir. Yes, sir. Yes, sir. Okay.
Good morning, respected faculties and our delegates, dear delegates. So we are extremely happy to organize this ALLERCON 2021, and as a member of this team ALLERCON 2021, I welcome you all in this August occasion. And this year the theme of ALLERCON is allergy in COVID times. So we have different sessions. So may I request Dr. Abhinav to kindly conduct from your end this session. There are lots of academic, very highly academic contents for today's program. So may I request Dr. Abhinav to take care, and we will start now.
Good morning, everyone. Good morning to all the participants and
Good
our
morning.
esteemed speakers and chairperson. Myself, Dr. Abhinav Keshwani. Thank you, sir, for having me here. So I would like to thank you, everyone, for being here. And we would now take this up. I would like to take this opportunity to introduce our esteemed chairperson for this session today, Professor Arup Kumar Kundu, sir. So, sir is the visiting faculty and consultant rheumatologist at IQ City Medical College, West Bengal. Sir is academician, clinician, teacher, researcher, author, and orator. Sir has done contributed chapters in 16 national and 5 international books on medicine. Sir is the author of 5 bestseller books on clinical medicine. Sir is the member of Indian member International Advisory Panel, Kumar and Clark's Medicine Book. Sir is the chairperson of Indian Rheumatology Association West Bengal chapter. Sir has multiple papers and publications, and sir has almost 118 scientific papers in Index Journal. Sir, it is a pleasure to have you today with us for this session. Thank you so much for being here, sir. Thank you so much. So, and we also have one more chairperson for this session, Dr. Udas Chandra Ghosh, sir. I would like to introduce Dr. Udas Chandra Ghosh, sir. And I would like to take this upon. Can we have the slide, please? Sir is a professor of Department of Medicine, Medical College and Hospital, Kolkata. Sir is a fellow of Indian College of Physicians. Sir is also a recipient of WHO Fellowship in Critical Care. Sir is the Vice Chairman of API West Bengal branch and East Zone member of API Central Body. So with this, I would like to welcome sir, and it is an honor to have you here for this session as a chairperson. Now I hand it over to you, sir, for introducing our speaker and taking us through this session, sir. Over to you, sir. Thank you.
Can I start?
Yes, sir, please.
Okay, it's just 10 o'clock, 10:02. So today we have got in ALLERCON, we have got in the first session at Dr. Brigadier N.C. Das Hall, sharply at 10 a.m. We have got 3 speakers. First is Dr. Kaushik Basu. Hello.
Sir, I'm just intervening. One more chairperson is there, so I'm requesting Kaushik da, please give the CV slide of the second chairperson. I'm very sorry.
No. There is no other except me and Dr. Udas Ghosh. You have read it?
Yes.
Yeah, I have already introduced, sir.
Okay.
Yes, introduced.
Thank you.
But we are now seeing the smiling face of Dr. Udas Ghosh. Very good.
Yeah, that's
Thank you.
Thank you.
Now, we have got, without wasting time, first speaker is Dr. Kaushik Basu, and his topic is revisiting the role of immunity in allergic disorders. And second is Dr. Shoibal Moitro, who will speak on adaptive immunity, the key players and therapeutic implication. Last one is Dr. Nandini Chatterjee, who will speak about immunoglobulin, a brief overview. Just one thing I must tell you, it is a big topic. The conference will continue for 1.5 days. It's a very big one where repeatedly the speakers will tell about allergy, autoimmunity, etc. Allergy in one sense is the immune system response to a foreign substance, and immunity, what I have realized, is the protection or exemption from something which may be penalty by the traffic police, which may be an infection or which may be a toxin. So without wasting time, I will make the speakers to memorize that the theme is allergy in COVID times. So they must speak about a few sentences in their topic. What is the relation of their speech with the COVID times phenomenon? So may I ask the first speaker, Dr. Kaushik Basu.
Arupda, just 1 minute. Good morning to everybody. First of all, I must convey my sincere thanks to the organizer of the ALLERCON to invite me as a chairperson. Let me introduce a few words about the Kaushik. I know everybody knows Kaushik, but really he is an energetic, dynamic faculty in our department, Department of Medicine, Medical College, Kolkata. But he has posted as an assistant professor of Department of Rheumatology in Medical College, but we have still, it is yet to open this Department of Rheumatology. We are trying to do these things. Now he is rather taking care of rheumatology unit. Really, he is an asset in our department. Let's start, Kaushik. Please start your program.
Thank you, sir. Hope I am audible. Thank you, respected chairpersons, for this kind introduction. And I thank the organizers for inviting me to speak on this rather intricate topic as this figure would depict. While going through this topic, what I realized was number one, that you cannot take off innate immunity among the other pieces of the jigsaw puzzle called allergic immune response out and speak on it separately. So when things are happening together, we have to see as the bird sees it from above it. As the phenomena happen, we have to see it as a whole and then pick out which part of it is from innate immunity, which part is from adaptive immunity, and maybe therapeutic targets, whenever they come across, can be divided according to whether they target innate and adaptive. But when we are looking to the process overall, the process of allergy, hypersensitivity, we cannot separate innate immunity, adaptive immunity. So uh, frequently we'll come across many crossroads where they interrupt, and I'll try to stop or pause and pick up the cells of immunity and processes of innate immunity where we can intervene. Secondly, what I had realized is that in the last 5 years or so, I have not followed allergy hypersensitivity quite closely, and it has moved on. Medicine is such a field that even if you do not follow a single field for a couple of years, you feel that maybe time has moved on. I'll try to be quite simple, but to start with, let us understand the process of allergic airway disease, the prototype disease that I've taken, since this is the mostly the conference that will be attended by chest physicians. Whenever an allergen comes to the contact of the respiratory epithelium, if there is a breach, or even if there is no breach, or it might be picked up by the dendritic cells and it processes the allergen, and then there is migration towards the regional lymph node where they are presented to the naive T cells. Now, this is very important thing, that what are the factors why there is allergic reaction, rather which is mostly Th2 type of reaction, not a Th1, or rather a sepsis like reaction, and what mediates it? Is there a role of the dendritic cell? Now, within the regional lymph node, first of all, there is a characteristic of the allergen that can determine it. Number one, size, charge. Number two is whether there is protease activity of the allergen or not. That is the whether it is allergen specific, that determines the allergy. Number two, there is some role of dendritic cells, which is inherently the part of innate immunity. How it presents, we have seen frequently in our school days. We have all been naughty sometimes, but how your friend uh, presents it to your teacher, uh, your naughtiness, which your teacher hasn't seen actively, determines the outcome, whether you are bashed by your teacher or maybe a brief scolding. So this mediation by dendritic cells is important, and it presents to the naive T cells via the MHC class 2 molecule receptor, and the T cell receptor in presence of interleukin 4. This milieu is important. In the presence of specific milieu where there is excess of interleukin 4. Now, what makes this milieu? I'll come slightly later. Now, this might be determined again by a few molecules of innate immunity, like the toll-like receptors, which I'll touch upon a little bit later. Now, this has been efficiently presented, the allergen, to the naive T cell, which itself changes to a Th type 2 cell, and then with the help of CD40, which is present in the B cell, there are other ligands like CD80 or CD86, which amplifies the response. Now the B cell starts producing IgE, immunoglobulin type E. Now, the main type of immunoglobulin produced usually by the B cell is type G, among it the G1. Now, what makes specifically it to produce immunoglobulin G is a enigma again. Now, this IgE, which is specific for this type of allergen, is produced in huge quantities. But initially, during the sensitization, there is also allergen non-specific IgG, which is produced in the mast cell, which induces some conformational changes in the mast cell, and it has a host of repertoires inside it, and it is ready. That is, the powerhouse is ready. Only we need a matchstick to be lighted. Now, this is the sensitization stage. A little bit detailed upon how this IgE production is done by the B cell. 2 to 3 things that I would like to point out is that, number one, the role of CD40 ligand in the Th type 2 cells, which is again, this setup is facilitated by the CD80, CD86 binding, which is helped by the allergen. So the allergen has its own property which can drive the dendritic cell, which can lead the formation of Th2 type of T cell from naive T cells, and again production of IgE. Now, what I was briefly touching upon is that the toll-like receptors, which are present in most of the immune cells in the cell surface, these are part of the innate immunity that can actually identify the pattern. Now, we do not know whether some cell is at fault or not, but the pattern looks bad. It might be a bacteria, it might be a fungus. So there are specific toll-like receptors from 1 to 9 in human being and other 4 in mice, which is dropped in human beings for some reason during evolution, which can sense maybe a few senses, the single-stranded RNA, single-stranded DNA, the double-stranded DNA. These are viral sensing TLRs. There may be fungal sensing TLRs and bacteria sensing TLRs. It has been seen that TLR2 deficiency promotes IgE and inhibits IgG1 class switching following ovalbumin sensitization. So that was the question. That was a juncture where things might go. That was a junction where the train might go towards either allergy or towards sepsis type of response. So one point we have identified where the TLR2 is important. Number 2 is that I was talking about the dendritic cells that has its own property that can either drive the whole process towards the allergic reaction or towards the sepsis-like reactions. And it has been seen that there are a few methods by which we can change the dendritic cell response, like the pan-immunosuppressant corticosteroid. It inhibits all type of immune cells, including the dendritic cells. It inhibits the DC cell maturation. Omalizumab, the IgE antagonist, causes downregulation of the Fc epsilon receptor 1. Now, we have the stromal lipoprotein, which and we have the receptor against it, which can be inhibited. And there have been experiments where this inhibition have been seen in either in mice or in monkey, and it has been seen that it causes less of dendritic cell maturation, and dendritic cells can be inhibited. So these are the things which can come in future, and it will stop the allergic reaction at its onset. But like the sensitization level, it will be able to stop it. Now, the genome-wide association studies have given us deep knowledge in many fields, including the study of allergy and inflammation. There has been single nucleotide polypeptide mutations in the TLR4 gene, and it was seen this increases the risk factor for asthma. TLR4 mediated allergic reaction develops only by intranasal sensitization, but not by subcutaneous or intraperitoneal sensitization. This has to be studied a bit more. Tailor-mediated reactions influence the dose of immune stimulatory components as well as the route of administration and the timing of exposure. Now, manipulating this TH1 TH2 balance or Treg function by administering TLR agonist may be promising for the treatment of allergic disease. One modality that might come out from here. The CLR, another type of innate immune interaction. The C-type lectin receptors, which might be dectin-1, dectin-2, and Minkel, they recognize fungal elements, and a few recognize the mycobacterial, or even lectin-2 has been implicated in allergic inflammation to house dust mites, very common. And it has been shown that these might give rise to allergic inflammation. Now, from the first part, where we have seen that there is sensitization of the immune system towards the allergen, and the mast cell has been readied, but there is no inflammation. During that sensitization, there is no bronchoconstriction, there is no systemic effect. Now the mast cell is ready. Mast cell is an essential portion from the innate immunity, and it is ready. And in the early phase of airway inflammation, there is a repeat exposure to this allergen. Again, the dendritic cell might take it, or if there is a breach in the epithelium, the allergen might sneak in by itself. And the mast cell now it has the repertoire of identifying the allergen in itself. That is, the IgE enabled mast cell gets hold of the allergen straight away. And this is the matchstick that I was talking about. And it has histamine, it has a host of cytokines in it, and releases a host of cytokines into the system, and which causes vasodilation, which causes bronchoconstriction. There are a host of neuropeptides that is involved that increases the mucus secretion. There will be other cytokines which pave the pathway for chronic inflammation of the airways, like TNF alpha, like interleukin 8, leukotrienes, and they cause further leukocyte recruitment and also increase the vascular permeability. So this is the early phase of airway inflammation, where the cytokines are there, the systemic effects are there, but the permanent changes like the bronchial airway hyperreactivity or hypertrophy is not yet there. Now, coming towards the late changes, now we see that what are the difference? The mast cell again catches hold of the allergen, and all other things are same, but more cells come into play, like the eosinophils, the basophils, the Th17 response now come into play, and there is more of epithelial damage caused by matrix metalloproteinase elastasis. So there is more of mucosal damage that might increase the influx of allergens on one hand. There is increased mucus production, and there are other cells involved, like the Th17 cells. Now there is damage. If there is damage, there has to be a repair. So the airway smooth muscles are increasing in their diameter, and this causes a further more bronchoconstriction in each response when there is release of histamines from the mast cell. So this is the late response. And finally, this is the chronic response. In it, we see that the mast cell, which was at the center stage till this time, has been still in the center stage, but by this time, three things has occurred. Number one is that there is airway smooth muscle hyperplasia, number one, and another thing is that this epithelial mesenchymal tropic unit has been formed with the help of cytokines and other inflammatory mediators, that even it carries on the inflammation even without a new allergen. So this goes on and on in a positive feedback pathway. So we see that innate immune responses start the whole things, With the help of adaptive immune response, it amplifies, and this makes it an automatic feature that after some time, when there is chronic changes, even without a new allergen, the patient still suffers from bronchospasm and so on. Now, this is something that we need to see, that where to apply this knowledge so that we can stop allergic reactions in its inception. If we can drive the train from pro-allergic to pro-T regulatory cell type, how we can do that? And now this concept, this is a paper published in August 2021, the effects of trained innate immunity on T cell responses. Now, this is another thing, enigma, that I was talking about. Does only interleukin 4 milieu determine what sort of response will it have? Yes, it has definitely a big role, but we are not sure whether it is the only thing that is determinant on that. The allergen properties is there, the dendritic cell properties is there, and it has been indeed seen that when we are giving BCG, the T cell down-regulate trained immunity, and it protects against a host of other infections. Now, this property of BCG vaccination was initially used, and there has been a host of papers who have published that maybe BCG vaccination, additional with BCG vaccination, might confer some protection against COVID. The papers were from 2020 March, mostly March till August 2020. After that, somehow the number of papers that has been publishing the role of BCG vaccination has gone down, maybe with the advent of other drugs. Also, we see that there has been a few other ligands like FHT, which are training the cells to anti-inflammatory training, and we see that it can cause protection against allergic encephalitis. So then this is the silver lining, that if we train the T cells on how to respond to various stimuli, and we can give that stimuli maybe in different doses and see, this is a new concept, so studies will follow. We can see that maybe the T cell, subsequent T cell response can be changed. Thank you.
Thank you, Dr. Kaushik. Now, Dr. Udash, we will ask for the questions if there is any at the end of the session. Dr. Udash Ghosh will call upon Dr. Shoibal Mitra.
Yes, Kaushik, really, we are happy that you have discussed about the details of the innate immunity and how it instructs the adaptive immunity. And that Dr. Kundu has already mentioned that we will discuss the question answer at the end of this session. And now after innate immunity, now the adaptive immunity. This is the acquired immunity, and that will be discussed by our another speaker, Dr. Soibal Moitra. And it is the adaptive immunity, the key players and the therapeutic implications. Arupda, would you introduce Soibal?
No.
Okay,
they will place the slide and you declare.
You read it out. See, he is an adjunct professor and senior consultant at Division of Allergy and Immunology, Apollo Multispecialty Hospital, Kolkata. Though he is now working in Kolkata, but he is basically based from the Delhi, and he did his MBBS, graduateship from Maulana Azad, and did his postgraduate from the VP Institute of the Chest. Yeah. So really, he's a senior consultant of the allergy, immunology, pulmonology, and also immunology. So now I request our next speaker, Dr. Soibal Moitro, to start his lecture. Dr. Moitro, please.
Thank you, chairpersons. First of all, I would like to welcome all in this year's National Conference on the Allergy and the Immunology. So my talk is basically an extension of what Dr. Basu has just spoken. So it is basically the same chain and the thread is the same, only the pulse are different. But it always, both the innate immune system and the adaptive immune system, they act in tandem and also together to bring about the desired immune response or the undesired response in the disease states that we see in our patients. So basically, it is actually the part or the story or the what is the biological information from the allergen or the antigen, which is being carried by different pathways to the immune effector cells. One of the immune effector cells that we just learned is where the mast cells, which are involved in the type 1 hypersensitivity reactions. And in between comes the innate immune system, immunity, and adaptive immunity. We have also learned how the innate immunity or innate immune system actually orchestrates the functioning of the adaptive immune system. So immunity is basically referred to the resistance exhibited by the host towards injury, which can be caused by multifarious external things or maybe some internal proteins like microorganisms, their products, and many other things. It could be an innate, it could be an acquired. Acquired we also call the adaptive. And the acquired immunity could be an active, which could be because of some natural infection or some artificial infections like the vaccination, or it could be passive, which also could be natural and artificial. This is the big picture which we have just seen, that how when a microbe comes in contact with our system, it is first as handled by the innate immune system. And the innate immune system consists of the multiple cellular elements that we have seen, like the epithelial barriers, the phagocytes, and NK cells, and there may be proteins and the complements, and there are physical barriers like the mucosa and the other elements of the mucosa. Now, this is then followed up. If they're able to handle the microbe, it's fine. If not, then the information is passed on to the next level of the immune mechanism bodies, which are mainly the T cells and the B cells, which carry it forward. And they developed either a cell-mediated immunity or a humoral immunity to actually tackle that microbe or the microorganisms. So some basic differences between the innate and the adaptive, which we all know, it's just reiteration of the same fact. The innate immunity, they're primitive and they're broad. Okay, so but adaptive is a highly specific, and which is mainly the specificity comes from the T and the B cell receptors. And how they become specific, that is through the generation of the diversity, which is an important and part of how the specificity is gendered or engendered among our immune cells. If we talk about the kinetics, that is how fast innate immunity is really fast when it comes in contact with the microbes, then they start defending us. But adaptive immunity, it is slow process. It takes days and weeks, or maybe at times maybe longer to develop that immune system. And this is highly regulated. Adaptive immunity is regulated by multiple regulatory mechanisms, which actually tightly control the functioning of the various cells of the adaptive immune system. And there is an amplification mechanism in the adaptive immune system. We'll see what is primary response and what is secondary response. Such type of amplification mechanism is not in the innate immune system. And obviously, discrimination of self and non-self is an important and characteristic of the adaptive immune system, which we don't find in the innate immune system. And the duration of the adaptive is long, could be months, years, maybe the lifelong, but the innate immune system is a short term, because there is no memory in the innate immune system, which is there in the adaptive immune system. So with this, we come directly to the adaptive immunity. So why the adaptive immunity comes? Like why do we need the acquired immunity? Can't the innate immune system handle everything? There are some shortcomings in the innate immunity that we just talked about. One is they're non-specific. they have similar pattern of responses for all the pathogens. No matter what type of pathogens they encounter, they have some, in the pathogens will be having some patterns, and to recognize those patterns, innate immune cells, they have pattern recognition receptors, and they recognize those patterns and they mount the similar type of the immune reaction, the response to all those microorganisms or any external antigens and allergens. And these patterns which they recognize, the innate immune system, these are highly conserved patterns throughout the evolution of any biological system in the earth. So this is the important thing. They're poorly regulated. They have poor control mechanisms, which are poor, in some cases they're lacking. But nowadays we are coming to unearth several control mechanisms of the innate immune system also. But by and large, our control mechanisms are more prominent in the adaptive immune systems. There is poor amplification. The response magnitude is same for all the insults, whether it is a pollens or whether it is a bacteria response of the innate immune system is more or less the same. There is no self-discrimination. They can harm to self results for lack of specificity. There is no self and non-self discriminatory characteristic of the innate immunity, the short duration, and they have no memory. So to actually complement the shortcomings of the innate immunity, the specific or the adaptive immunity comes into functions. As I've said, the adaptive immunity is primarily, it is being done by, or it is being orchestrated by the lymphocytes, which are either a T cell or it could be a B cell. And we know that all these lymphocytes comes from the pluripotent stem cells of the bone marrow. So what is an antigen? It's a foreign molecule which elicits a response by the lymphocytes. It could be a virus, bacteria, fungus, protozoa, parasitic worms, or it could be this could be also an allergen. Allergen is a type of antigen which produces a type 1 hypersensitivity reactions. Like it could be a pollen grains, it could be an animal danders, it could be the house dust mite proteins and things like that. And what we have to recognize them and to counteract them, there's antibodies, which are the antigen binding immunoglobulins, which are produced by the B cells. And there are antigen receptors, and the receptors are present both on the membranes of the B and the T cell, who actually first identifies as these antigens, and then they generate specific responses to them. Now, there's some principles of the adaptive immune responses. Principles, and all the adaptive immune responses are guided by this as primary principles. First is specific recognition of the individual antigens for the immune cells via antigen receptors, which is very important. And this specificity is actually an important characteristic of the adaptive immune responses. These days, many patients come to me and they ask that, sir, can I take the COVID-19 vaccine and the influenza vaccine at the same time? Or do I need to space them out? Okay, so this is actually, they want to understand or they want to know that whether the response to one allergen or to one antigen, or not an allergen, an antigen, would be actually in some way be influenced by the response to the another antigen. Adaptive immune system is highly specific. They will generate a specific immune response to one antigen, and they will generate specific immune response to another antigen. And both are actually mutually exclusive. And this mutual exclusivity of the responses, actually, it makes an important characteristic of the adaptive immune system. So they can go ahead and have both the vaccines together. Why we don't give together in the same time? Because of some other clinical issues, like they can be having some pain on the injection site. They usually develop fevers and all those things. So we just want to space it for the ease of the patient, but not from the immune system's point of view. Then there's a clonal selection and expansion occurring after the antigenic recognition, which is the primary immunity or the primary immune response, and leading to the generation of the effector T cells and the B cells. And later, the exposure to the same antigen, it causes a secondary response, or we also call a memory response, where there is much rapid proliferation of the memory cells, leading to an exaggerated or a heightened response to the same antigen to which they were exposed before. So what are types of the adaptive immunity? We have primarily two types. It is cell-mediated immunity and we have humoral immunity. Cell-mediated immunity is by the T cells, which can be the T, and in T cells we have the effector T cells, which causes the direct lysis of the target or infected cells, else, or it could be production of the cytokines that activate the infected cells to kill the pathogens. The humoral immunity, which is mediated by antibodies, which are produced by the B cells, and these antibodies that lead on to the neutralization or the inactivation of the pathogens by various mechanisms, which are actually mediated by the antibodies. It could be several other types of the hypersensitivity reactions, or it could be various other antibody dependent mechanism of the neutralization of the antigens. So though we see that there's a division of labor between the T cells and the B cells, but they are highly cooperative. They work together and in unison. The T cells mediate the cellular immunity through the control of the intracellular pathogens and the control of the tumors. And the B cells mediate humoral immunity through the control of the extracellular pathogens. They can mediate the allergy and the hypersensitivity. But now we know that one of the important concept of the allergy, which is changing, that there's the allergen and there is the effector molecule that is a mast cell, and to take the biological information from the allergen to the mast cell, IgE is one of the player, maybe an important player, but not the whole soul players. So there are other players which can actually carry this as information to the mast cells. And in this, the role of the other molecules and the other cells is coming. Now we are finding the roles of the IgG also. It is coming in actually carrying this biological information to the mast cells and causing the activation and degranulation of the mast cells. So in T and B cells, they cooperate for effective immunity. So T cell help may be needed for the B cell activation, and B cells may present the antigens to the T cells. We know that one of the important antigen presenting cells, what are those? They are the macrophages, they're the dendritic cells, and also the B cells. B cells are also antigen presenting cells. They present the antigen along with the MHC molecules to the T cells. So both the T cells actually, they coordinate the activity of the B cells, and B cells coordinate activity of the T cell, what we call it TB crosstalks. So these are T and B cell crosstalks. In this, the humoral immune response denotes the immunologic response that are mediated by the antibodies. If we see a neonates, the neonates rely heavily on the maternal immunoglobulin G, because only the maternal immunoglobulin G, they can pass the placenta, and on immunoglobulin A, which is transferred through the colostrum or the breast milk. So after infancy, the child's immunoglobulin gradually increases as levels of the maternal antibody starts waning, and it almost goes up by 9 months of age. And the antibodies are produced when B cells encounter the antigen, and they respond by undergoing activation, proliferation, and differentiation. There are two important differences among the T and the B cells. We see that B cells, when they are actually released from the bone marrow, they're matured B cells. Only in contact with the antigen and also T cells, they undergo the activation, proliferation, differentiation in the lymph nodes. But the T cells, when they're released from the bone marrow, they're actually immature T cells. The maturation of the T cells, they occur in the thymus, and then they get matured, and then they carry on their functions. So the B cell antigens are further classified as thymic independent and the thymic dependent antigens. Thymic dependent antigens need the help of the T cells also. Thymic independent antigens have several other pathways of the B cell maturation. So the thymic dependent B cell antigens, they require the T cell to help to generate the antibodies. And this is by and large the major pathway of the B cell maturation. So these B cells, they require multiple signals to become activated. and differentiate into the memory or the plasma cells. It is not that it's only the T cell which is giving some signals to the B cells causing maturation. As we have seen in the previous talk, it is a milieu which is important. The milieu consists of the cytokine milieu in which the signals are being passed. Along with that, there is also other information which is transmitted by the cell surface bound receptors, and there are co-receptors which actually causes the activation, differentiation of the B cells. It differentiates into either a antibody producing the plasma cells or the memory cells. If these activating signals are not received, the B cells may respond with energy to that antigen. And these are all the controlling mechanisms which are tightly controlled to bring about the response. So this is not that quite non-specific, and this is not uncontrolled one as is innate, but it is a tightly controlled mechanisms. And the germinal centers are the areas in the secondary lymphoid tissues where the humoral immune response to the thymic-dependent antigens is refined. So if we talk about the plasma cells and the memory B cells, they are found within these germinal centers. They provide long-lasting immunity and enable rapid recall immunologic responses upon subsequent antigen exposures. So even when the individual are exposed to that antigen, they can mount a good or a robust response against that antigen. Now it is different to how long this memory lasts. So as we're talking about the COVID vaccination these days, we are all actually talking about that how long will the primary immunization and which has given us, or maybe the natural infection protection will last, how long. So usually that needs to be seen, that whether it's 6 months or 1 year or lifelong. So this is a thing which is of nowadays we're actually studying this and needing to know, because it differs from the different infections. So this is the immunity which the human acquires during the lifetime. So this we call it adaptive or the acquired immunity. And as you have seen, it could be an active or it could be passive. Now, how do we actually tailor the response via an adaptive immunity? Now, if we talk about the active adaptive immunity, it involves the active functioning of the host immune apparatus. They either synthesize the antibodies or they produce the immunologically reactive cells and thus develop into a humoral and the cellular responses. But they usually require a latent period during the requires for its activation, where it needs to identify the antigen, understand it, process the information, and then mount the response to it. There's a negative phase is a time period in which there is a reduced measurable immunity. So antigen combines with the pre-existing antibodies and lowers its circulation, which is also safe. And secondary response is an individual previously exposed, again gets re-exposed and develops a more robust immune response. They are associated with the immunological memory, is more effective and enhances better protection than the passive one. So it could be a natural. How the natural, we know it's natural active immunity could be because of the natural infection, and that is for different infection, the immunity lasts for different periods. Like large majority of adults, active immunity against the polio virus, we say it lasts for almost lifetime. The lifelong immunity, such as in chicken pox, the measles, influenza, it's wanes off. We need an every yearly vaccination. Or common cold is also the same as that influenza. And there is a term which we call premunition. Premunition is an immunity to reinfection. It lasts long till the disease remains active. That means till the disease is active in a particular individual, there is an immunity to the reinfection, as we see in case of typhoid. But this premunition is, as we now know, this is an important concept which is actually tailoring the responses to that particular antigen in the following phases. What are the artificial ways of active immunity? The artificial are the vaccination. Is the most important artificial way which we actually produce the active immunity in an individual. The vaccines, which could be anything. Now we have various platforms of the vaccines. We have newer platforms. Earlier we used the traditional platforms that are heat-killed organisms or the inactivated organisms. Now we have different newer platforms like the vector platforms, the plasmid platforms. So, but they need a booster dosing. the repeated dose of the vaccines for the primary vaccination, they actually prolong the immunity, and this can be given in the various forms as I was talking. So these are the primary and the secondary antibody responses to the vaccines. You see that in the primary response, initially there is a first antigen exposure, there's a latent period, then there is a production of the primary antibodies, the IgM, which increases and then slowly starts decreasing. And there is also a production of the IgG sometime later, which also increases and it reduces. Now, when there's a second exposure to the same antigen, what we see is that is number one, that it is majorly IgG, it is not IgM. Second thing, the response is much rapid. That is, there is no latent period as we see over here. And third thing is the antibody titers are much higher. So actually secondary immune response differentiates in three characteristics. One is the amount of the antibodies produced, type of the antibody produced, and rapidity in which the antibodies are produced. And this gives a faster response to that, actually the infecting microorganisms. Passive immunity can be natural. Now to talk about passive immunity, most important natural passive immunity is the transplacental transfer of the antibodies for the mother to the babies, and some of the IgA antibodies is transmitted through the breast, mainly colostrum, to the neonates. These are the two major ways of the natural passive immunity. So human fetus is able to synthesize IgM from 20th week of life, but overall immunological capacity is quite weak. And some part of the immunological independence develops only after 3 months. Till then, the maternal antibody is the passive immunity. So you see that the breastfeeding is also quite important. Giving the colostrum is very important, and it is a very important, scientifically a important practice which should be followed in all the communities, because it gives some IgA and some protective antibodies to the babies. So what we see in the infants, in the fetal period, there is a maternal IgG it mainly contributes to the protection of the fetus. After the birth, what happens is the maternal antibody titer, it just varies, but still at the 12 months, there's a 60% of the adult IgG level, it remains. Then in the neonate, in the neonatal phase, as this IgM production increases, and they get also the IgA, they start producing some, they get through the maternal, from the mother through the breastfeeding. And these are 75% of the adult IgM level reaches in the 12 months of age in the babies. So this is how, so in the initial phases, it's basically the maternal antibodies which gives the majority of the protection to the neonate. So this transplacental transport of the antibodies, it is actually an active process, not a passive process, because the antibody concentration in fetal blood is much higher than that in the mother's blood. So this is not a passive transfer, it is actually an active transfer by various active modalities of the transfer of the antibodies through the placenta into the fetal circulation. And this active immunization of mother during the pregnancy, it helps to improve the quality of the passive immunity in the infants, like routine administration of tetanus toxoid during the pregnancy is a practice in our country. What are the various artificial ways of the passive immunity? This is given either as a prophylaxis or a therapy. In the prophylaxis, it is indicated for immediate and temporary protection, because we have seen that the acquired immune response requires some time or a latent period to develop the response. If the condition is that serious and the patient needs an immediate protection, then we give the preformed antibodies is directly or the anti-sera, which we called, to, like as we see in cases as of a severe dog bite, or maybe in various other of these injuries. So where we need the immediate and temporary protection, but like the suppression of the active immunity is injurious, we should remember, and it is only for a very short time response. They do not carry the long-term responses. And our agents, we use a hyperimmune sera, which is obviously animal or the human origin, and horse sera, convalescent sera, or we can give the pooled human gamma globulins. as we these days we are giving the intravenous immunoglobulin injections for the various dead diseases. So if we talk about the specific resistance of the immunity, which because of some threat from the external proteins or external substance, it could be innate or it could be acquired. This is just actually flow diagram is only reiterating the facts which you have just listened. Produced by the prior exposure to antibody, prior exposure or the antibody production. This is the acquired immunity. It could be an active, it could be a passive. Active could be naturally occurred immunity, or it could be induced active immunity by vaccination, and passive could be in natural, like in the mother's milk or through the transplacental transfer, or it could be induced, those actually given from outside the antibodies in some special situations where the immediate treatment is imperative to save a patient's life. So this is the same thing, how it goes, invading microorganisms, initially the innate immune system, then the external defenses, then internal defenses, then it leads on, comes, if they cannot handle it, then it goes on to the acquired, which could be humoral and the cell-mediated type. And this is how it goes hand in hand to bring about the desired effect, and in some cases in hypersensitivity, the undesired effect in the specific in the individual. It was when this terminology of this allergy, it was coined by the von Pirquet. The von Pirquet actually said that the altered status of an individual when they comes in contact with some external substance is actually allergy. This allergy, it could be either beneficial, that is production of the antibodies protecting against the disease, which he coined as immunity, or it could be harmful, that is, it is leading on to some deleterious reactions, which he called the hypersensitivity. So that means the von Pirquet's concept of allergy was something different. Now we call allergy, which is almost synonymous with what we say is a hypersensitivity. And when we talk about allergy, we think it is a harmful mechanism. But that was not the concept with which this terminology allergy was coined by the Austrian and pediatrician, that is a von Pirquet, more than 100 years ago. So thank you. And I think we'll be happy to answer the questions. Really.
Thank you, Dr. Shoibal. It's a very lucid description. It's a beautiful part of the lecture. Okay, questions will be taken care of at the fact end. Now we are at for the last speaker, Dr. Nandini Chatterjee. May I have the slide, please? Yeah. This is Dr. Shoibal Moitra slide. Just a minute. Sure. Just one thing about Nandini. I know her personally. She is an asset, in one word, for an organization, for an institution. Now she is the associate editor of JIMA and acting as a senior professor in our prestigious institute, IPGMER. At Bengal Physician Journal, she is the editor. Okay, she is a teacher for last 17 years, academic minded, nice doctor. So Nandini, we are ready to listen from you about the immunoglobulin, a brief overview.
Thank you. Thank you, sir.
Really, Arubda, I say one word, not asset, as indispensable. And he is as a state, he is a editor of Bengal Medical Physician Journal. As a national, he is a associate editor of JIMA. Not only that, he is also rather a co-editor of a international McMaster textbook of South Indian edition of the McMaster textbook. Really, he is indispensable in our API, and both from the state and also the nation. Thank you.
That's why I told for an organization.
Congratulations, Nandini, for your achievement. You start.
Thank you, sir. I'll be sharing my screen now. Is it visible, my slide?
Yes, yes. Visible.
Okay. Thank you.
Ma'am, before you start, can I make one announcement?
Yes,
Yes.
definitely.
So can I ask the delegates and faculties to put their name, because it is only showing the faculty.
Is my name there? I put it off.
Okay, your name
Okay.
is there. You continue.
Okay. Okay, I will be starting now. I am honored to be able to speak in this ALLERCON 2021 on a very complicated topic, and it has been very difficult for me to grasp it, and I will try my best to present it in a simplified manner. My previous two speakers have beautifully elucidated the immune system, which consists of the innate and adaptive immunity. The innate immunity, as we all know, is non-specific. It is a preformed immunity which gives immediate protection against invading microbes. Its another important function is activating the acquired immune system. The adaptive immunity, on the other hand, is very specific for a particular antigen, and it can act against millions of diverse antigens. However, the most important function of the adaptive immunity is to give rise to memory cells, which react rapidly when the body is challenged by foreign antigens in the future. Now, my topic today is immunoglobulins, which are produced, as we know, by activated B cells. And in this act, it is helped by two other important cell types, the C cell, the T cell, and the antigen presenting cell, which are the macrophages or dendritic cells. This process also takes the help of various interleukins. So what are immunoglobulins? Immunoglobulins, which are also called antibodies, they are glycoproteins. And these glycoproteins are produced by activated B cells, which are also known as plasma cells. 20% of plasma proteins are constituted by immunoglobulins, and these immunoglobulins are of 5 classes. The 5 classes are also called isotypes. They may be IgG, IgM, IgE, IgA, and IgD. Now, an immunoglobulin is a glycoprotein which has a Y-shaped structure composed of light and heavy polypeptide chains. Now, the heavy polypeptide chain is almost double the molecular weight of a light chain, and both these chains have a variable amino acid part as well as a constant part, or a constant region and a variable region. Now, these are actually 3-dimensional folded repeated amino acid sequences. There are 2 types of light chains in our body, the kappa and lambda variety. So all immunoglobulins are having either a kappa type of light chain or a lambda type of light chain. The heavy chains, on the other hand, are 5 types, each distinct for one class of immunoglobulin. So the amino acid differences between the constant region of these heavy chains determines which immunoglobulin class it will belong to. Of these immunoglobulins, we should also remember that only the IgM variety and the IgA variety are multimers. And these multimeric structures are joined together by a chain called the J chain. Now, after the structure of the immunoglobulin, I would like to describe a little about how the immunoglobulins are produced from the B cells. The process requires activation of B cells. Now, activation of B cells involves the T cells and as well as the antigen presenting cell. So when an invading pathogen is encountered, the macrophage binds the antigen along with complexes called the MAC protein complex. The type 2 variety, if it is bound to the antigen, then it will go and next bind to a helper T cell. On interaction of the helper T cell with the macrophage, there will be release of interleukins. And the most important interleukins here are the interleukin 2, 4, and 5. These together lead to proliferation of both the T cell and the B cells, and also the differentiation of the B cells. It is please to mute the other participants, please. Thank you. So this activation of B cells also involves a process called co-stimulation, which is very, very important. The co-stimulation occurs via interaction between the CD28 located on a T cell with the B7 or CD8T of the B cell. This interaction leads to formation of interleukin 2, which is a prime component of proliferation of the T cells. Another very important co-stimulatory interaction is between CD40 ligand and CD40. This interaction leads to the phenomenon of class switch. Now we need to know a little what is class switch. Now the B cell, when it is activated, initially it produces IgM antibodies in response to exposure to the antigen. But later, antibodies which are specific for the same antigen but of different classes like IgG, IgE, or IgA are produced. So there is a switching of immunoglobulin classes that are produced, and this process occurs due to some gene rearrangements. Interleukin 4 and 5 are necessary for bringing about this class switch. Sometimes B cells may be activated without the help of T cells. Here, certain bacterial polysaccharides may directly activate a B cell, but the problem is that as the T cells are not involved, we don't get interleukins 4 and 5. And in the absence of these two interleukins, there will be no class switching. So in these cases, only IgM antibody will be produced and not IgG or any other class for that matter. Now, as my previous speakers have already described, that immune responses, there is first the primary response and followed by the secondary response. When the body first encounters an antigen, a small clone of B cells are produced, which give rise to antibodies. However, there is a lag period of 7 to 10 days. The first antibody to appear is the IgM, and then the others follow. Next, if this antigen challenges the individual months or years later, then there will be another response, which is the secondary response. In this case, the memory cells which had been developed in the primary response react extremely fast, and they give rise to effective and larger amounts of antibodies. Now, in this secondary response, it is seen that it is the IgG molecule which is more prominent, and it has a very high affinity for the antigens. Now, to describe the immunoglobulins a little individually, the IgM molecule, as I said, is the main immunoglobulin of the primary response, and it acts as a monomer antigen binding receptor on the surface of the B cells. In the serum, the IgM circulates as a pentamer, the picture I had shown before, and the advantage of this pentameric structure is that there are 10 antigen binding sites, and therefore this IgM molecule has a very high binding power or avidity for the antigen. The IgG, on the other hand, takes upper hand in the secondary response, and its functions are multifarious. They neutralize the bacterial toxins and viruses, they activate the complement system, and they also help in opsonization. That is, they make the bacteria tastier or attractive to the phagocytosis process. One very important characteristic of IgG is that it has the ability to cross the placenta, and the maternal antibodies, which are very important initial protection for the newborn child, persist in the circulation, and that is IgG derived from the mother. IgE is, on the other hand, is a very special immunoglobulin which takes part in allergic processes. It mediates the anaphylactic or immediate hypersensitivity when it binds to mast cells and basophils, and there acts as a receptor for the allergens. When IgE molecules are cross-linked by allergens, there is release of large amount of mediators leading to anaphylaxis. Also, it is to be remembered that IgE is an important defense, or is the only defense against the parasites. The IgA type of immunoglobulin remains in the body fluids and secretions, and it prevents the microorganisms from binding to mucous surfaces where the secretions are present. It is also secreted in breast milk in the colostrum. The IgD functions as an antigen receptor. It is present in very small amounts, and it has no known antibody function. Now, going back to the structure of the immunoglobulin, if you remember, I said there was a variable region and a constant region. The variable region is the main antigen binding area, whereas the constant region carries out other functions of the immunoglobulins, like acting as receptors, complement activation, passing through the placenta, etc. Now, how do antibodies sort of damage or prevent the antigen? They bind to the antigen and cause neutralization. Now, this process of neutralization means that the immunoglobulin is blocking the key sites of attachment of that microbe to the host cell, and it prevents cell entry and subsequent replication. Immunoglobulins also activate the complement cascade, and the complement cascade, once activated, forms the membrane attack complex, which will produce small holes on the walls of the various microbes. Third is the process of opsonization, or tagging of cells, so that the macrophages or other phagocytes are attracted and they come and phagocytose the antigen. Another way of damaging is the antibody-dependent cellular cytotoxicity. Now, in case of worms, which are too large to be phagocytosed, IgE specific for worm proteins go and bind to the surface of eosinophils, and the eosinophils release certain enzymes which can kill the worms. Another type of ADCC is IgG, which binds to virus-infected cells and then they are recognized by macrophages and killed. So now I have sort of described the basic physiology regarding the immunoglobulins, their structure, types, and basic functions. Now I want to speak a little bit on clinical illustrations and the diagnostic, therapeutic, and preventive aspects of immunoglobulins. Now, I just wanted to illustrate one small case. A 35-year-old lady presents to the gynecologist for menorrhagia for the last 3 months. On examination, she had mild anemia, but otherwise examination contributory. Now, the physician, he ordered a hemoglobin TC-DC ESR, blood biochemistry, and an abdominal imaging. The problem is that these investigations were all normal except the hemoglobin to be a little less than normal. The lady was put on 3 months of hormone therapy, but the problem recurred. Now she presents to us with gum bleeding and easy bruisability. So we go for the complete hemogram, and where we find that she has a very low platelet count, just 17,000 per cubic millimeter. We also go for a workup for thrombocytopenia. However, we do not find any other abnormalities. She was provisionally diagnosed to be having immune thrombocytopenia, put on steroids, and she improved. So immune thrombocytopenia is a disease which belongs to the class of autoimmune diseases, where the body has lost its tolerance for its own tissue antigens. Autoreactive T cells, they become very important here and lead to the activation of B cells and production of autoantibodies, which destroy the tissues of the person's own body. There are many autoimmune disorders. I have named just a few, like SLE or rheumatoid arthritis or myasthenia gravis. Sometimes antibodies formed due to certain infections may start cross-reacting with normal body tissues, which happens in case of rheumatic fever or Guillain-Barré syndrome. Now, after this, I would also like to say some things about the diagnostic utility of immunoglobulins. Routinely, we are nowadays doing serology for viral, bacterial, parasitic infections, and we are looking for IgM, IgG levels and antigens for that matter. Autoantibody profiles are being done, ANF, RA factor, anti-CCP antibodies. In hematological malignancies, before giving therapy, routinely now cell surface markers are done by immunohistochemistry, and that involves immunoglobulins. Sometimes in primary immunodeficiency diseases too, we go for quantitative immunoglobulin assays. Here, one very important thing is not written, that is when we are doing blood grouping. So that is also, we are utilizing the antibodies for determining a person's blood group. Now comes the preventive correlate. Now, the first thing is active immunity, which can be achieved artificially by giving some component of a pathogen into the body, and antibodies are produced. Now, in the COVID times, the only thing that is on our minds is the COVID vaccines. So many types are being, so many platforms are being utilized. You can have the inactivated virus vaccine or a viral vector vaccine, RNA, DNA vaccine, even subunit vaccines. The basic physiology is that we are utilizing the method of active immunity. Side by side, we should also know about passive immunity. That is what we are making laboratory form preformed antibodies, and we are putting it into the person's body so that immediate protection can be achieved against certain diseases, as we know, rabies, hepatitis, or antitoxins to diphtheria and tetanus. Physiologic passive immunity, I have already mentioned, is the mother to fetus protection by passing on IgG through placenta or IgA through breastfeeding. Sometimes we may also utilize passive and active immunity together, like preformed antibodies given plus a vaccine for prolonged immunity, like in case of tetanus or rabies. Now we come to therapy. How therapeutically immunoglobulins are being used. Well, for autoimmune diseases, immunoglobulins are always being used in GV syndrome, in ITP, in CIDP, myasthenic crisis. Monoclonal antibodies is another very important branch of modern medicine, where in the laboratory we are producing antibodies from a single clone of cells. I must stress upon the fact that when our body is producing an immune reaction, this is a polyclonal reaction. But monoclonal antibodies, which is seen in case of multiple myeloma, is also that being used in the lab to produce immunoglobulins, which are used extensively in diagnostic and therapeutic indications for cancers, connective tissue disorders, even infections, as we know, like in COVID too. Now, the monoclonal antibody cocktail that is being used for COVID infection, mild to moderate COVID patients who are having high risk of becoming severe, we are using this Casirivimab and Imdevimab together. The cocktail is given by infusion, and what they are doing is that they are preventing the entry of the virus into the host cell. It is preventing membrane fusion and stopping, or at least sort of retarding replication. So the severity and hospitalization rates are seen to be lesser than the other groups. So to summarize, immunoglobulins are produced by activated B cells. They are glycoproteins, have 5 classes, and they are offering very specific immunity against a wide variety of antigens. They are also causing inflammation and, in a deranged immune system, autoimmunity. In modern times, immunoglobulins are also having diagnostic, therapeutic, and preventive utilities. Thank you.
Thank you, Nandini. Dr. Chatterjee, it is a very lucid one, and really everybody has realized what you want to say. So all are in time. I'm thankful to all the speakers. So now the question and answer session. I have seen there is no question in the chat box. So anybody can ask any question to any speaker. As a chairperson, I am a privileged person. My first question, I start to roll the ball. My first question to Dr. Shoibal. As the theme of the today's seminar is allergy in COVID times, and you talked about adaptive immunity, do you think we require the third dose or booster dose of COVID in India at the present time, because UK, USA has virtually completed the third dose, and the Israel? What do you think about it?
Yes, thank you. So first of all, I would like to say that third dose, the initial 2 doses of the vaccine which we received, these are called the priming doses. And
Yes.
definitely we will need a booster dose, that is a third dose, and that could be after the third dose, there could be subsequent dosages that we do not know yet, but we'll definitely need a third dose, which will act as a booster dose, and that will help to enhance the immune response, have a long-lasting memory, and that will give a protection which will last for a considerable time. So we will be needing a third dose of the vaccine in our country also. But as you all know, that our country is a population of 1.3
Yes,
billion
there is the
people.
problem.
So that is the dynamics and economics of the vaccination of the mass us. That is the main issue. But definitely we'll need a third dose.
Thank you, Dr. Moitra. So you think it is needed? So any question from anybody to any speaker, everybody is allowed.
Nandini, may I ask you one question? That
Yes,
you have mentioned about the formation of antibodies after infection or after vaccine. So, in relation to COVID, what is the factor? You have mentioned that there are different types of vaccines, and there is a different, rather severity of infection in the, in the state or in country. So, how the immunity will develop? What are the pathophysiological changes and factors? What are the factors in the vaccine and what are the factors in the severity to form the immunity and how they protect themselves? So can you elaborate the few things?
okay. Thank you for the question. Actually, the various vaccines that are being developed or are being given, each utilizes a different type of mechanism. Basically, various parts of the virus are being utilized to act as antigen, or a whole virus is being utilized to it is being inactivated and the whole virus is entering the body and immune reaction or antibodies are produced. The process by which the whole virus is being utilized is somewhat similar to what is happening when the person is getting infected. However, the other types of vaccines where for example, when we are utilizing a viral vector, we are putting a part of the spike protein inside the adenovirus, and that adenovirus is also kind of inactivated and we are introducing into it. So that enters our B cells and antibodies are being produced against that coronavirus. However, the thing is that their protection, the protection which is being offered by the vaccine is not absolute, because as we are seeing, actually the breakthrough infections are acting. So the vaccine will be able to produce antibodies which may not be totally neutralizing, but may give a partial neutralizing power, so that the entry of the viruses into the cell can be blocked to some degree, and the person, even if he suffers from a breakthrough infection, may not go into the severest complication of the disease.
And about the natural infection, among the severity and the immunity, is there any correlation? If the patient is severely involved, as he developed much more immunity than the pathophysiological factors.
Okay. You mean that the antibody response to a severe infection
versus mild infection?
Mild infection. Well, this is controversial, and I actually do not know whether it needs to be seen and followed up. It is not known that whether a person who is having a mild infection is not having immunity enough. There are many contrasting views about this, and I would also like to ask the other panelists if they have any opinion to share about this.
Yeah, I would like to say something.
Yeah.
Yes. So in COVID, what we see is that the severity of the disease is actually depends not only on the viral load, but also mainly because of the host response to the
Immune
virus.
response.
Okay.
Correct.
So if you see that the immune response is very high, what we usually call, if there is lots of cytokines being released into the system, what we call cytokine storm, or if it is a heightened immune response, the inflammatory response, which is actually bringing about the various pathologic findings, pathologic conditions leading to severe disease. So it's not only the viral load, but mainly also because of the host immune response. So that means even if a viral load is small, if the patient's immune response is very high, heightened to it, that person can go into a very severe disease. Though there is a connection between the viral load and also on the severity of reaction, but we should understand that when these viruses enters our cell system, they uses our cellular machinery to replicate, and the fast with which they replicate, the numbers will increase and they will just spread to the other cells, and then how the body responds to that, it depends on severity. So usually this is not related that milder infection will lead to weaker immunity. A severe infection will lead on to a stronger immunity. That is not a tenable thing, but stronger immunity can be because of the mild infection also. But we need to understand and know in the time to come that how we are progressing, how the severe disease patients are faring over a time, and how the milder disease patients are faring over the time. For the next 1 or 2 years, we'll come to know about it.
Thank you, Dr. Moitro. We have got a very little time, and my last question for 1 minute answer to Dr. Kaushik Basu. Kaushik, you are a rheumatologist. Do you think first question, lupus patients are more susceptible to corona infection? And number 2, is it very safe to give biological agents in this time of pandemic? Just give a little telegraphic answer. Dr. Kaushik. Oh, Kaushik probably left. I don't know.
He probably left.
Oh, probably left for the hospital. Okay. No problem. As there is no question, I think so. And we are at the fag end. It is a nice program. We are now more knowledgeable by speech of Shoibal, Kaushik, and Nandini. So, Dr. Udas, you just conclude.
Okay, thank you, the speakers, mainly Dr. Basu, Dr. Moitro, and Dr. Chatterjee, and also the organizers, Shambho and other team. And also our special thanks and regards to our senior Arubda. Without your help, it is not possible.
No, same to you.
Okay, then now we conclude our session. Thank you.
Thank you all. Thank you all.
Thank you.
Okay.
Thank you.
Bye.
Thank you. Bye.
Thank you so
So
much, sir.
over to the organizer.
Thank you so much. So now I would like to invite our chairperson for the next session, that is Dr. Sambhu Samrat Samazdar. Sir is, sir is well known for his accomplishments, but I would just like to highlight a few points here. He's a
Thank you, Dr.
certified.
Obhinav. I think we are running short of time, so we can this question. So can you please change this slide so that we can see the next topic? And the next topic is the importance of adherence in allergy practice. And I think adherence is always a very important issue regarding every practices. So for this topic, we are really privileged to have a wonderful speaker, and she is a clinical pharmacologist, postdoctoral trainee in DM Clinical Pharmacology at School of Tropical Medicine. Also got gold medal in MD Pharmacology. So may I request Dr. Shreyoshi Dasgupta, so please present this important topic about the adherence issues in allergy practice. Over to Dr. Dasgupta.
Thank you, Dr. Samazdar, for your kind introduction. And at the very outset, I would also like to extend my gratitude to the Allergy and Asthma Research Center, Kolkata, for providing me with this opportunity. So Before I begin, let me just confirm whether my screen is visible and whether I'm audible or not. I have just started my screen share. Is it visible?
Yeah, it's visible.
Thank you so much. So I shall be speaking on the importance of adherence in allergy practice. So during the course of this short presentation, I will be touching upon the salient features of adherence, why it is important in allergy practice, and how to measure it and how to mitigate or how to improve adherence in different patient categories. So to begin with, what is adherence? So when we think of treating a patient, the first thing which comes to our mind is when we are treating a patient, we directly think about the outcomes that about improving the patient outcomes. What we tend to forget or tend to neglect is the fact that between treatment and outcome, there is one important parameter, that is adherence. So until and unless a patient is adherent to the therapy provided to him or her, we cannot guarantee or we cannot expect the proper outcomes to occur. Now, by adherence, we do not only mean adherence to medication, that is adherence to taking the pills or taking the drugs as prescribed. Adherence encompasses the whole gamut of therapy, which includes both pharmacological, non-pharmacological measures, as well as the techniques that they are using when they are using devices, which is especially important in the case of allergy practice. Now, the WHO has defined adherence as the extent to which a person's behavior, that is taking medication, following a diet, and or executing lifestyle changes, correspond with agreed recommendations from a healthcare provider. So as you see, adherence is not only about taking medications, it includes things like following diet, prescribed diet, or abstaining from certain things, even executing lifestyle changes as required. So all of these comes under the purview of adherence. Now, there is another related term that is most often used when we are talking about patient outcomes, that is compliance. Now, there is a subtle difference between compliance and adherence. Now, compliance requires the patient's agreement to the recommendations, but adherence is more of a shared opinion making. That is, it will depend on the patient's preferences, not just what is prescribed by the physician, but it is a shared communication between, while taking into account the patient's cultural background, the patient's preferences, etc. So it is not just, adherence is more of a dynamic process, whereas compliance is where we just expect that the patient will follow whatever we have prescribed. Now, when do we consider adherence to be ideal? So ideally, adherence should be, adherence is considered to be ideal when almost 95% of the prescribed regimen is followed, but more than 80% is also generally considered as acceptable. Now, the spectrum of adherence, it can start from non-adherence, that is total, when the patient totally does not follow the prescribed therapy at all, that is non-adherence. Initial non-adherence is when there is an initial hesitancy in starting the regimen, but with due course of time, the patient starts following the regimen as prescribed. Partial non-adherence is when some of the prescribed therapy is adhered to, whereas the rest are not followed. Persistence is when a subject or when a patient continues taking a medication as prescribed, and adherence is total compliance with all the aspects of therapy which has been prescribed. Now, why are we talking about adherence? So when we look at the statistics, the non-adherence among patients suffering from chronic diseases is almost 50%. That is, around half the patients who are suffering from chronic diseases do not adhere to the therapy that has been prescribed to them. And in different studies, in one of the studies which was conducted in the United States of America, which studied around 195,000 prescriptions, they found that non-adherence to allergy medications overall was around 28.7%, which is a huge number. And almost more than one-fourth of the prescribed drugs are not adhered to. And in case of newly prescribed drug, it increased to up to 30.9%. Similarly, there was another study which looked into the non-adherence in, that is primary non-adherence, that is non-adherence to the first prescription for cough, cold, or allergy, where they found around 30% of non-adherence. On the other hand, in a study which looked into the seafood allergy in children, it found that around almost 89% of parents implemented a safe diet, but then over half of them followed a more stringent elimination than what was recommended. So you see, adherence can be of both, it has both sides. That is, on the one hand, we have almost negligible adherence. On the other hand, we have over-compliance. So we need to balance between the two. So this is another study which looked into non-adherence to antihistamines. This was done in Poland. So here you see they have categorized the non-adherence to individual antihistamines. So as you see on this table, certain adherence to certain drugs is relatively more. Like for example, non-adherence to certain drugs is relatively more. For example, in the case of cetirizine, levocetirizine, you see it's almost around 30%, 33%. Whereas in the case of drugs like fexofenadine, desloratadine, relatively lower percentage of non-adherence is seen. So we do not have adequate data regarding non-adherence in India, and I urge the people who are attending this conference, those who are associated with this, to think of generating data regarding non-adherence and allergy practice with respect to our country. Now, when we look at non-adherence in asthma, so here you see estimated adherence to asthma medications varies from anywhere between 30 to 70%. And it has been seen that more than 35% of patients fill less than half of the prescribed medications. That is, most of the patients, they do not comply with all of the medications that have been prescribed. So they just take up one or two medications and they follow them while they ignore the rest of the medications. So that has to be looked into when a clinician is, when the patient is coming to the clinician for follow-up to assess the adherence. And the recent GINA guidelines also emphasize on assessing adherence before escalation of the therapy. So when it comes to oral steroids, non-adherence is almost up to 45%. These have been taken from studies which have been published in established journals. So what are the consequences of non-adherence? So we have seen what is the magnitude of non-adherence in allergy. So what happens if the patients are non-adherent to their therapy? So it has a huge financial cost. As you see in the US, it has been estimated that medication non-adherence costs between 100 billion to almost 300 billion US dollars per year. And it accounts for almost 50% of treatment failure and almost 125,000 preventable deaths per year. So a lot of economic benefits and a lot of human resources can be saved if we can just emphasize on adherence when we are assessing our patients and when we are looking after our patients. And almost 33 to 69% of hospital admissions are due to non-adherence. So as you see, good adherence can reduce adverse events as well as mortality. Non-adherence to inhaled corticosteroids has been found to be responsible for almost 24% of asthma exacerbations and poor outcomes. So almost 1/4 of the exacerbations can easily be prevented if the patients are more adherent to their therapy. And the estimated cost of only respiratory disease non-adherence is almost $35,000 per patient per year, which comes to around 26 lakhs if you can convert it into Indian rupees. So this is a table which shows, which gives us the description of hospital stay and cost generated for hospitalization. So you see, according to the degree of adherence. So they have categorized according to less than 75% severe non-adherence and more than 75% is moderate non-adherence. So when the subjects are almost less than 75% non-adherent, then the hospital stay averages for around 15 days. Whereas if it is more than 75% non-adherent, it averages to around 11 days. And cost of hospitalization, you see almost there is double the cost of hospitalization in case of severe non-adherence. So why do our patients become non-adherent to the therapy? What are the barriers to treatment adherence? So there can be different factors, a multifactorial causality for treatment non-adherence. So even socioeconomic factors, they can be patient-related factors, therapy-related factors, condition-related factors, and even healthcare team and system-related factors. So we will be looking into this in a brief fashion. Before that, let us see what are the predictors of non-adherence. So by looking at the patient or while history taking, we can get some clues as to which patients maybe are more likely to become non-adherent. So what are those? Low literacy or limited language proficiency in the subject, in the patients. If the patients are suffering from depression, from concomitant psychiatric disease or substance abuse. So these can be more important if they're looking at elderly patients or adolescents who are suffering from allergy or asthma. Lower cognitive function or cognitive impairment, again, this is important in the case of the elderly. Forgetfulness, anger, social psychological stress or anxiety, lack of insight into the illness when they do not realize the condition that they are suffering from or what are the consequences of not taking the medications as prescribed. Lack of belief in benefit of treatment and incorrect administration. So in allergy practice, there are several techniques, devices that are being used here. As you see in this picture, this shows us the correct technique of using intranasal sprays in allergic rhinitis. So if the patient is not aware of the correct technique, or if the patient is not able to implement or able to practice this technique properly, that will lead to, the symptoms will not be relieved and the subject will gradually get off the medication or will not continue with the medication any longer. So it is important to not only to educate the patient regarding the correct technique, but also ask the patient to demonstrate it in front of you so that you can assess the errors and then you can rectify them and the patient can benefit from the treatment. So some other predictors of non-adherence are if the patient believes that the medications are not important or are harmful. So when we are prescribing the medications, it is better if we can take some amount of time to explain what is the reason for which we are prescribing each of the medications and how the subject is going to benefit from each of those, so that the patient knows why that particular drug is being prescribed to him or her. Complexity of the medication regimen. As you see on the right side, here you have an example of the local nasal immunotherapy administration schedule, where it is more or less a complex schedule where you will have different vials being taken for different durations for different times, and then you will have a maintenance phase also. So for a regular patient or an average patient, it might be difficult to stick to this kind of a regimen unless you have regular points during your therapy at which you are emphasizing on the adherence, where you are asking the patient to come for regular follow-ups, etc. So if the patient is tired of taking the medications, if the medication regimen is inconvenient, if the subject has fear of side effects of medication, cost of medication, barriers to access or to the medication or to care, inadequate follow-up, discharge planning, or missed appointments. Now, how do we assess adherence? How do we measure whether the patient has been adherent or not? So there can be both direct as well as indirect methods of assessment. So direct is by direct observation or by measurement of biological markers. In the case of allergy and asthma, there is a possibility that we can measure the amount of drug present in the blood, but this is an invasive method, not regularly done, except for research if required. Indirect methods are the methods which are more commonly used. So you can have behavioral or physiological markers assessment, self-reporting by the means of surveys or interviews, by different scales. We also have dedicated scales for assessment of asthma therapy, secondary data collection from refill data, claims data, etc. And electronic monitoring, which is becoming the go-to method for assessment nowadays, where you have self-monitoring devices or electronic devices with sensors attached to them, which can relay the information of when the patient has been taking the medications into an app-based system, which can then help us to assess the adherence. So what are the provider strategies? How can a clinician improve the adherence? So the thing to remember here is that it is a simple regimen, that is SIMPLE. S, to simplify the regimen. I, to impart knowledge about the condition and the medications being used. M, modify patient beliefs and human behavior. P, provide communication and trust. L, leave the bias, and E, evaluate adherence. So simplifying the regimen. So I'm just giving an examples of some of the ways in which a prescriber can communicate with the patient while simplifying the regimen. So it is important to let the patient decide, to give the patient options which are available to him or her, and then decide if cost or convenience is more important to the patient. So if there are two different medications, for example, the prescriber may say you need two different medications to control your condition. So the combination product will likely cost more, and he can prescribe two different pills or one pill, which is a combination product. Which option would suit you best? Next, match pill taking to activities of daily living. For example, in order for this medication to work effectively, you will need to take this medication twice a day. So can you take it at breakfast and dinner to help you remember, or is there a more convenient time? So better communication, improved communication between the prescriber and the patient can help improve adherence also. So imparting knowledge, involving family members during during initiation of therapy as well as during follow-up, especially in the case of adolescents, elderly, to help optimize adherence by addressing cost. If cost is the factor which is preventing the patient from being adherent to therapy, then you can explore other options which are more cost effective. Allow the patient to repeat back instructions. This is what I was telling about the inhaler technique or the technique for intranasal spray. You can ask the patient to demonstrate the technique in front of you so that you can assess the technique better. Reinforce verbal instructions with written information. So you can provide written leaflets, even illustrative examples, diagrams, short stories, especially in case of children, which will make it more interesting and which will help them in integrating the knowledge about their condition. Modifying beliefs. So ensure that the patient knows the risks by asking them whether they know what are the kind of risks that they will be facing, what is the consequences of their stopping the medication. Identify perceived barriers, whether they have any fears or concerns about the medication that has been prescribed to them. Providing communication, give feedback to the patient. If the patient reports to you with some adverse effect or maybe any query regarding the therapy, address them with empathy so that the patient feels secure in relaying to you his beliefs or his thoughts. Watch for patient acceptance and involve the patient in decision making. So shared decision making is very important while to address non-adherence. Leaving the bias, relate to the patient's demography. So if the patient comes from a different state or from a different part of the country, try and speak to the patient in a language which the patient is more conversant with. Try to understand whether the patient understands your language. Say, for example, if somebody is coming from the Northeast and we are talking to that patient in Bengali, it might not be comprehensive to that patient. So just ask whether the person is more comfortable in a different language and take extra time to overcome cultural barriers. So there might be religious or cultural beliefs which might be preventing them from following the therapy. So just try and find out whether some of those factors are affecting the adherence. And last is evaluating adherence. So ask direct questions, whether the patient sometimes forgets to take the medications, and ask about adherence often. At each visit, just assess adherence once. Now, do you find yourself not as careful about taking your medications? Recognize lack of receptivity. For example, whether the patient stops taking the medication if he or she feels better, and identify adherence barriers. Sometimes when you feel worse, do you stop taking your medications? So if the patient feels that the drug is not working, is that a reason why the patient is not taking the medications? So next is, after we have measured, after we have assessed adherence, how do we overcome non-adherence? So there are different innovative ways in which adherence is being tackled, non-adherence is being tackled. So there are pill boxes, blister packs, etc., behavioral prompts, as I have said. There can be external reminders, for example, a phone alarm or a medication log that the subject or the family members can maintain. And there are certain newer approaches also to improving adherence. For example, pharmacy incentive programs, which are a web-based or app-based programs which can improve engagement and encourage immunizations. In-home telemonitoring, which utilizes remote patient monitoring programs, especially for high-risk patients. Innovative medication packaging, which involves modern technology, so that when the patient opens the package, you get a prompt that the particular drug, pill has been consumed. Even interactive gamification solutions, where especially, this can be helpful in the case of adolescents, where they tap into the psychological aspects of game mechanics. So if the subject has been adherent to the therapy, probably he gets more points, or he gets into a higher level in the game. So those kind of approaches can be thought about while trying to tackle non-adherence. So here you see an example of the first smart device, that is Adhero, which was launched by Lupin. So what this does, this is a connected smart device for metered dose inhalers, and it provides direct information. This is an app-based information about when the patient is taking the inhalers, so that information is relayed directly to the app, from where we can measure the adherence. And this on the right is an example of a cartoon-based and illustrative patient education material, which can be provided to the patients, maybe in vernacular languages also, showing different situations where adherence to medication will help them in improving their quality of life. So to summarize, medication taking behavior is an extremely complex and individualized system, and it requires multifactorial strategies to improve adherence. And improved adherence directly translates to improved patient outcomes and also reduces economic costs. But then data regarding adherence is relatively less come across in the developing countries, especially for important subgroups like adolescents or children or marginal populations. And it is urgently required, or it is of urgent need to generate the data in our country. So billions of dollars are spent on developing new drugs, and only a fraction of that cost can help patients to adhere to their medication, and that will have a significant impact on healthcare system and health of the population as a whole. So these are my references. To conclude, I would like to say that the most expensive pill is that which is not taken or taken inappropriately. So clinicians or the service providers, healthcare providers should always emphasize on adherence while implementing their therapy. Thank you.
Thank you, sir. Thank you, Madam Dr. Shreyoshi Dasgupta, for this beautiful presentation. So actually, the word adherence, it contains, I think, 2E while we are writing. Yes, 1E, of course, you had given the emphasis on education. Education is one of the most important part of the having a good adherence to any therapeutics. Another E also, if we consider empathy, the discussion with our patient, if it becomes in an empathetic way, it always ensure adherence. And while talking about allergic disease, it is not only the adherence to drugs, it is also important to adherence to different lifestyle modifications, and also some allergen avoidance issues. So this is a very important and subject while talking about allergy. And I am really thankful for your wonderful deliberation. So I think we can move forward to our next talk. And we are really honored to have Professor Apurva Mukherjee as chairperson. And I think that has joined. Apurva sir. Sir, there is some technical issues from Apurva Mukherjee sir's end due to some joining issues. I think he will be joined soon, but we are also very honored to have a well-known figure in the field of medicine in India, and he is also an international figure, we must say, must acknowledge that. Professor Jyotirmoy Pal, who had agreed to talk on this very important topic on vaccines. And may I request Dr. Jyotirmoy Pal sir to proceed. He's a consultant physician. He's the professor of Department of General Medicine in Archikor Medical College. So over to you, sir.
Thank you, Dr. Shambho. একটু বেশি বলে ফেলেছো। যাই হোক, Anyhow, the topic is given by the organizer, the revisiting role of vaccine and adult immunization. Really, when I prepared the slide yesterday, initially I thought what type of topic is given to me. There is a more advocacy, but really I was happy when I finished the PPT for today's presentation. That why adult immunization not so popular not only in India, globally, and needs a relook, or the government or the organizations or the physician should have a second look, or revisit the role of adult immunization. If we see the history of the mankind, it is interviewing with the history of the infectious disease. The fall of Roman emperor was basically due to the plague, and dark age of Europe started after the Black Death. That is the massive death after after the plague, and people started losing faith on the state and start believing on the supernatural forces. The Spanish colony is established in Latin America because the Spanish people have taken the smallpox virus, against whom they were to some extent immune. But Latin American people, particularly Peru, Bolivia, that area was totally and not immune, no immunity against the smallpox. And the soldiers and the common people died due to the smallpox. And the Spanish easily captured the Latin America and made their colony. So in last 2000 years, infectious disease governed the history of the mankind. But mankind is the best survived in the art. So we fighted against the infection by several weapons. One was germ theory, advanced by the Louis Pasteur. Then the sanitation, sterilization, cleanliness, which was advocated in the work of the Florence Nightingale, and advent of the antibody by Alexander Fleming. And very importantly, the vaccine. Vaccine saved one of the finest and miracle discovery in the field of medical science, who saved the millions of lives across the globe. What is vaccine? Vaccine is a biological byproduct that is used to safely induce an immune response that confers protection against the infection or disease on subsequent exposure to a pathogen. So vaccinology starts its journey with the discovery of the smallpox vaccine by 1796 by Edward Jenner, and it get another momentum almost after 100 years when the Louis Pasteur in 1885, sorry, it is not 1985, 1885 discovered the rabies vaccine in Paris. After that, so many vaccines was discovered, like the polio vaccine, then cholera vaccine, plague vaccine, typhoid vaccine, and 1927 the BCG vaccine. The vaccine, one part is the discovery, another part is the distribution. With the establishment of WHO and allied organizations like UNICEF, UNESCO, the organization came like a blessing to the globe, because this organization helped to reach the vaccine to the poor of the poorest countries of the world, and save millions of lives, not only the children, also for the adults, from occurring from the different tropical and infectious diseases. How was pre-independent India? I read a editorial from the JIMA, but the frustrated editor has written that only 10% of the Indian came under the medical care. So much frustrating condition. He has written that among all death, child means less than 10 years, was about 48%. Almost 2 lakhs pregnant women death per year. Between 1932 to 41, death from cholera was 1,44,000. Death from smallpox, death from plague, and active TB case was almost 2.5 million. But this was the tip of the iceberg, because that time reporting system was not good. In spite of this, the editor mentioned that these all diseases was preventable, but British government done nothing to prevent Indian from this catastrophic outcome. In 1946, in one editorial, the editor has written, in this unfortunate country, we have never had public health system in the sense in which they are undwelling in West. We have a few hospital and dispensary, one for the taluka. Considering the vastness of the population, we have no facility for the curative and preventive side of the disease. No country in the world is medically so badly served as India because government never considered the health of the people as its first and foremost concern and its national wealth as much as it considered law and order and the police and military to be. British government given more importance on the military services and the police for the law and order, but never looked upon the health of the Indian because at that time it was a colonial India. So people of the India banked more on the god and goddesses. The Ulai Chandi temple still you can see in the Belgachia. Ulai Chandi for the cure from the save from the cholera, or Mashitola for to save from the smallpox. People rather than depending on the medical system started depending more on the god and goddesses. So situation slightly changed when the British government directly taken care of the India from the company. So if after 1857, Sipai mutiny, but unfortunately, India faced pandemic or epidemic one after one. So British government brought an epidemic act in 1896 and established school of tropical medicine for research. But still, colonial government basic motto was this act, and whatever research and whatever facility they have done was basically only to protect their people and prevent spread from India to England. First structured effort or sincere effort came from the British government in 1943 with the establishment of Bhore Committee. That was considered the first reform in the health policy of India. And Bhore Committee given due importance on integration of the preventive and curative health systems. Bhore Committee identified at that time in India 6 major killer diseases. One is diphtheria, tetanus, polio, copinka, measles, and tuberculosis. So Bhore Committee mentioned if along with the curative structure or curative health system, if we can prevent these 6 diseases, we can save the millions of Indian lives. Finally, India got freedom in 1947, and Jawaharlal Nehru, in his first speech, given due importance in curing and preventive disease along with poverty, ignorance, and inequality. So immunization process started as a part of the immunization strategy. After the Bhore Committee, so many committees established: Mukherjee Committee, Mudaliar Committee, Srivastava Committee, but every committee given importance on the expansion of the immunization. First, broad country level program was taken by the government India in 1978. That is called the expanded program on immunization, where the BCG, DPT, polio vaccine, typhoid was included. Basically, this program was taken from the jubilant Indian government when the smallpox was eradicated. But this expanded program on immunization basically was limited to the urban area. In 1985, in the name of Indira Gandhi, that time Congress government has taken the universal immunization program to expand it to cover the entire country. Along with BCG, DPT, OPV, typhoid, measles was added. But the due course, typhoid was dropped due to some other side effect issue and others endemicity of the typhoid in the local different local areas. After almost 20 years of launching of the vaccination program, 2001 National Advisory Committee on Immunization was established just to review the success of the last 20 years and to set up the future direction of the of national immunization program, whether some more vaccine to be included or some to be excluded, or what should the future direction or future goal to cover the entire population. Because till now our concentration of Indian government was basically focused on the infant children and pregnant women. That is naturally it was the most vulnerable population, and based on the data that in the pre-independent period, the almost 50% death was of the children below 10 years of age, and also the lot of pregnant women we lost. So first 50 years, independent government focused more rightly on the immunization of the infant children and pregnant women. So with this 50 years effort, the communicable disease incidence or death from the communicable disease have dropped down from 2/3 to 1/3. That means immediately after the independence, death from the infectious disease was almost 2/3 of the total death. But in 2000 to 2010, the death from communicable disease dropped to 30%, whether the death from the non-communicable disease, that is from the coronary artery disease, heart disease, stroke, non-communicable or trauma, or road traffic accident increase up to the 66%. That is a miracle achievement in controlling or preventing the communicable disease in independent India. But at the same time, there is a because 1947 with the recommendation of the Bode committee in India government, one hand taken the preventing strategy, one hand taken the curative strategy. So there is a change in the curative medical system also, and there is a simultaneous advancement of the industrialization, economic reform, and all these things has done the demographic reversal. That means population of India over the those who are above the 50 years, that has changed. That means there is a huge increase of the elderly population rather than the younger population. And life expectancy, which was around 34 in 1947, has reached near 66 to 70 in 2016. So, but at the elderly population, proportion is increasing rather than the younger population because of the longer survival due to the better socio-economic condition and better medical treatment facilities. They also suffering from the more and more communicable and non-communicable disease. And due to the changes in the lifestyle that has happened after open market policy in 1990s, there is a increase of the non-communicable disease such as hypertension, diabetes, obesity, heart disease, and this and so and so. So the non-communicable disease prevalence is increasing. At the same time, infectious disease prevalence is decreasing. But there is an interface. When a patient with non-communicable disease having such as diabetes, some acquired infectious disease, that is a communicable disease, complication due to non-communicable disease becomes 3 to 4-fold. Same way, when the patient have some communicable disease and at the same time patient have background a non-communicable disease such as heart disease or the diabetes, the condition of seriousness or the complication of the non-communicable disease increases. Such as a patient have already rheumatic heart disease or some ischemic cardiomyopathy, patient develops some influenza. So heart failure, patient is more prone to develop heart failure. So non-communicable disease and communicable disease, they are interlinked. There is a few data from the Ministry of Health and Family Welfare. In 2011, people age above 50, almost 193 million, but it is projected that 2036, almost 1/3 of the population will be aged population, that is age considered above 50. Almost 404 million people by 2036 is projected. Whereas age below 15 years in 2011 was 31%, but it can drop to 20% in 2036. That means in coming decades, the aged population's percentage will increase, but the younger population percentage will decrease. So now is the time we should give more stress or give a relook or rethink about the health condition of the aged population. Another interesting data that is also taken 2017 from Ministry of Health and Family Welfare. Death due to CVD was 36% of the people aged 45 to 54%. But if the age is above 70, death due to CVD was almost 45%. Diabetes in 1990 it was 26 million, but 2016 it has increased more than twofold, 65 million. Obesity in 1990s was 9%, while 2016 it is 20.4%. So there is a huge overburden of NCD, and if you cannot control the incidence of infectious disease, the complication due to the NCD will increase manifold. So I told communicable and non-communicable disease is not different. They are interviewing and they have an interface. So we, to control the complication of one segment, we should control the other segment also. So regarding infectious disease, though the prevalence is decreasing, but still India is harboring 30% of the total prevalence of infectious disease of the world. So vaccine, but vaccine can protect adults from the occurrence of the infectious disease, from the complication, from the hospitalization, from the CCU admission, from the mortality, and from the economic stress. So patient with NCD, which is increasing in India, if acquired the vaccine preventable diseases, complication increases. But if we can prevent the vaccine preventable disease, we can save the Indian from complication of the non-communicable disease, which we have seen given due stress by the health organization, by the pharmaceutical, by the health planner, given more stress on the non-communicable disease than the communicable diseases. So vaccine preventable disease in India, data from WHO in 2017, I told almost 30% of the total infectious disease burden lies in the India, from the WHO statistic. You see the statistic, 60% of the total diphtheria case of the world harbor in the India, 40% of the total tetanus case in India, 17% of the total pertussis and rubella case in India. So India has 2 to 4 times more vaccine preventable disease compared to the world average. But Indian reporting system is so poor, actual burden may be much more that is projected by the WHO, and it may be not only 30%, it may be 50% or more the world infectious disease in India. In last 50 years, we have also seen several outbreaks of different vaccine preventable disease in India, like the varicella, hepatitis A, influenza, measles. Even the HPV burden in India at present is 97,000 new cases per year and 60,000 HPV related cancer death in India. So there is a scope of preventing the HPV infection in Indian women. If you see the data from 2010 to 2013, the influenza-related respiratory illness is around 58 to 60%, and influenza-related circulatory death at 52.9%. And influenza vaccination, though there is a high prevalence of influenza and complication due to the influenza, but influenza vaccination unfortunately is labeled by Government of India as a desirable vaccine. There is some reason why the Government of India still now not adopting as a compulsory vaccination like the childhood vaccines. I will come later on. So, but aged population is increasing, but WHO have a slogan as healthy aging. Healthy aging means there is some ways by which you can keep a older person healthy on nutrition, on his prevention of the diseases, and in the early detection of the diseases, and different rehabilitation processes. So healthy aging is the slogan of the WHO, and healthy aging is the slogan of the every government of the globe. What happens with the aging? The immune system start declining, and the aged population, that the population above 50, which is now in India, probably has not taken the vaccination as per schedule of the EPI, because it started in 1978. So aged population, or aged, what I say, above 50 years population, what is in even India, possibly has not taken full immunization as per schedule in their childhood. And also, as the age advances, there is a inflammation, there is a immunosenescence, immune dysregulation, which makes the elderly more vulnerable to different infection. And you see the one statistic, the Streptococcus pneumoniae infection above 50 years, mortality is 2.5 times higher than the people with less than 50 years of age. Anyhow, after the child vaccination, there is a two scope. One is the adolescent vaccination, one is the elderly vaccination. In adolescent vaccination, still we have some breakthrough, particularly not in India, in different in other, particularly US and Europe, particularly for the rubella and HPV vaccination. And some of the country has renamed their program as a child and adolescent vaccination program. But unfortunately, the recommendation of the adult vaccination is not so impressive in India, and it is not till now is included in Indian immunization schedule. Though particularly the pre-exposure profile axis, except the tetanus during pregnancy and J vaccination in certain endemic area. Apart from these two vaccination, awareness of the adult vaccination or inclusion in the government schedule is not so impressive till 2021. So recommendation of the adult vaccination basically done by the different professional bodies like IMA, Association of Physicians India, RSSDI, Geriatric Society of India, Indian Nephrology Society, but basically they advocated only for the high risk group persons, and particularly they have advocated more for the pneumococcal and influenza vaccination. In from the on behalf of Association of Physicians of India, we have made a committee. That time president was Dr. A. Muruganathan. One committee was made, and that committee has recommended vaccination against the seasonal influenza in adult high risk group. So the professional body's recommendation was basically focused on the high risk group and more on influenza and pneumococcal vaccination. But other vaccinations were not so much stressed by either by the professional body or by the government. If you see the how much vaccination, how much the childhood or adult vaccination we have achieved till now through advocacy, whatever may be, maybe from professional body or personal level. One data in 2017 is 27 million newborn has been vaccinated, 100 million children has been vaccinated, 30 million pregnant women is vaccinated. The data is quite impressive. Almost we have achieved 85% of the coverage of the vaccination in the children and pregnant. But very sad statistics on the adult vaccination. In a study in the Jodhpur AIMS done by the pre-vaccination coverage for hepatitis B was only 8%, pneumococcal 7%, influenza 1%, typhoid for 3%, and post-exposure coverage also not for the 100%. Even for the rabies, where the mortality is 100%, their post-exposure adult vaccination coverage in Jodhpur study was only 20%. Even in the USA, adult vaccination coverage, you forget about the India, USA have only 2% adult vaccination coverage. So there is a lot of scope of the adult vaccination because adult population is increasing in one hand and having a non-communicable disease burden with the adult population as they are serving longer. And on the top, if there is a communicable disease, the mortality due to the non-communicable disease increases. At the same time, patient without having the non-communicable disease, death in the elderly population due to the immune dysregulation, when they acquire the communicable disease, mortality further increases compared to the population below 50. So there is enough scope to prevent the infectious disease or communicable disease, or I say vaccine preventable disease in elderly population. But there are some barriers. One is universal access, poor disease surveillance system, vaccine confidence, vaccine hesitancy in the elderly population, and ministry lacks proper. I told why government of India has not taken the when 2011 when the committee reviewed the role of adult vaccination, that time proper data they have not, the professional bodies failed to provide the proper data. What is the prevalence or actual scenario of the communicable disease or epidemic or the endemicity or different vaccine preventable disease in India, and how much the adult vaccination is the effective in preventing the propagation of the vaccine preventable disease in India. Due to the lack of proper data, Government of India 2001 has mentioned this adult vaccine is desirable but not included in the proper schedule. So we need, with the professional body, we physician, we should proceed for the more the scientific research. So National Vaccine Policy 2011 basically focus on childhood immunization and immunization on the pregnant, not on the adult, because of the lack of proper data. If we quote from the Amartya Sen, he has correctly, Nobel laureate economist, he has correctly mentioned that the health is the key issue for a sustainable development of a country. Unless you can give an educated and healthy population, sustainable growth is unthinkable even in an independent country. So the last few slides, Government India should provide recommendation for the adult vaccination. With the professional bodies, we should provide the proper data of the endemicity of the different communicable diseases and the role of adult vaccination. We with a proper scientific format. We should improve the reporting system on infectious disease so that we can provide data to the government. Public and healthcare provider education is a must. Vaccination should be on the high risk group, that is a must, should start from now onward. That also Government of India already mentioned, high risk group should take the adult vaccination, and need for the operational research, and I am giving due stress on this aspect. Otherwise, in near future, we cannot advocate the role of adult vaccination at the government level, or what I can say in a mass scale level. But it is possible. The COVID vaccination has proved that mass vaccination by a government is possible. So historically, we have focused vaccination more on a childhood and pregnancy due to that time situation in the pre-independent India. 21st century, the scenario has changed due to the advent of the socio-economic structure. So older population are challenging population. We have to save older. We have to keep a healthy aging. Young and older adults are basically economically productive. So we have to save the young and older population, even the older population. They, in many families, they are the sole earning. The pension is the sole earning of the family. So disease burden of the elderly poses the economic burden, not only to the family, also to the society. So healthy aging, as advocated by WHO, can help in economic growth of the family and society, preventing unnecessary expenditure due to the different illness. So adult immunization should be the new health priority. Vaccination against the COVID-19 proved that mass vaccination is possible if you wish. So slogan of the 21st century should be prevent death from the communicable disease, prevent complication for non-communicable disease, and healthy aging. So widespread existence of preventable disease and death is a disgrace to the society which tolerates it. So both a child and adult, both are hungry, both are diseased, both are malnourished. Both make the picture ugly. Thank you.
Thank you very much, sir, for this enlightening lecture. So we are really thankful to you for giving your valuable time. And I think we are running short of time. We need to move forward with our next topic. I think may I request our technical team to proceed further. May I request Dr. Abhinav Keshwani?
Yes, sir.
Yeah, please.
Yeah, so for the next session, I would like to request and I would like to welcome Dr. Samrat for as a chair to chair this particular session on skin prick test. Over to you, sir.
Yeah, thank you. So may I request our technical team to show the slides, CV slides of our respected faculty. So now the topic is skin prick test. I think this is a very important one. Please show the slides of Dr. Jevin Roger. So skin prick test is an immunological test, and this is one of the most important tests while we are talking about allergology. I think you please show the next slide, the Dr. Jevin Rogers CV. Yeah, so it is an immunological test, and we need to interpret it very with a very cautiously, and need to collaborate with clinical findings. And to talk on this topic, we are really honored to have Dr. Jevin Roger, who had a known face in the field of allergology in India, where he had done his MD in respiratory medicine from CMC Vellore, also done DNB in respiratory medicine, diploma in allergy and asthma from CMC Vellore. He had also done his European diploma in adult respiratory medicine. He is now the assistant professor at the Department of Pulmonary Medicine at CMC Vellore, also consultant pulmonologist and allergist at Apollo Hospitals and Apollo Allergy Clinic in Chennai. So main area of interest is allergy, and he was the faculty in several allergy CMEs, conferences. He is also a distinguished faculty in the DAA program run by CMC Vellore. and also was organizing secretary at ALLERCON 2019-2020. So it is a really honor from the team ALLERCON 2021 to have you, sir, as our speaker. Now over to you, sir.
Can you see the screen now?
Yes, sir. We can hear you and we can hear you also, sir.
Very good. Thank you. Thank you. A very good morning to everyone who is attending the conference. At the outset, I would like to thank the organizing committee of ALLERCON 2021 for this wonderful opportunity given to me to talk about allergy skin testing. I would also like to thank the panelists for their kind introduction given to me. Today, over the next 20 minutes, I will try to cover the salient points that every practicing allergist needs to know about allergy skin testing. As it was said in the introduction, allergy skin testing is one of the most important tests that every allergy specialist should know to do and should know the intricacies of this test, because it is the bread and butter of the field of allergy for every doctor who wants to practice allergy or who's already in practicing allergy. So, but the fact that we need to remember is unless it is done properly, it cannot be interpreted correctly, and if it cannot be interpreted, it becomes useless. So over the next 20 minutes, I will be going through its role in the diagnosis, the mechanism, the behind it, indications, contraindications, factors that can affect the results of the test, methods, selection of antigens, procedure, how to document the procedure, how to interpret it, and finally, how to maintain the quality of the test. As you can see, there are several things to cover, so I will try to go as fast as possible. Just a second. Yeah. So most of the clinically significant allergies to environmental agents, food and drugs, as all of us know, are IgE mediated. And skin testing is one of the most important ways of diagnosing any IgE mediated allergy. And as all of us are seeing over the past decade or so, allergic diseases are on the rise in our country. And some of the recent papers show that it could be even 25% or even more of our population could be affected with one or the other allergic disease. So what is the role of allergy skin testing in the diagnosis of IgE mediated disease? There are three components to diagnosis of any IgE mediated disease. The first of which is identification of the possible culprit allergens through a careful clinical history. As you would have been listening over and over again, history is of utmost importance in diagnosing and evaluating any allergic disease. The second component is demonstration of IgE specific to those allergens with which the patient has history to. And finally, the third component is determination of that the exposure to that particular allergen results in symptoms. This can be done either with history alone or in some cases with a challenge procedure. So the second component where we have to demonstrate an IgE specific to the particular allergen can be done with skin testing or with in vitro testing. So that is where we allergy skin testing becomes important in the diagnosis of allergic diseases. So what is the mechanism that is behind this skin testing? Well, that is the simple IgE-mediated allergic reaction that all of us, I'm sure, are very thorough with, but I'll just go through it quickly. So in the beginning, when a patient is exposed to an allergen for the first time, it is taken up by the dendritic cells and then presented to the taken to the lymph nodes, presented to the naive T cells, which get activated, and they in turn activate the B cell, causing stimulation of the IgE class switching in B cells to produce IgE. So subsequently, IgE is produced by B cells. And then these IgE molecules get attached to the Fc epsilon receptors on the mast cells. And this is when the body is ready to react on subsequent exposures. And then when there is a repeat exposure to that particular allergen, the allergen gets attached or binds to the IgE receptors which are on the mast cells, 2 or more IgE receptors. Phenomenon called cross-linking happens, which causes activation of the mast cells and degranulation of the mast cell, resulting in release of mediators and cytokines, which ultimately results in the symptoms that we see in IgE-mediated disease. So skin prick test is a bioassay that detects the presence of allergen-specific IgE on a patient's mast cell. So as we saw just in the previous slide, that is exactly what we are trying to identify with the allergy skin test. When relevant allergens are introduced into the skins, these specific IgE, which are already bound to the mast cells, degranulate and the histamine and other mediators are released. This results in a wheal and flare reaction during a skin prick test. And the presence of cutaneous reactivity after introducing an allergen is actually a surrogate marker for sensitization within the target organs, which are the eyes, the nose, the lung, the gut, and the skin. So as we saw in the flow chart of diagnosing an IgE-mediated disease, the second component, which is demonstration of IgE specific to the allergens that the patient is having symptoms to, the other test that we can do is an in vitro test or a serum-specific IgE. What are the advantages of doing a skin test over a serum-specific IgE? There are several advantages, and they are that the results are available much quicker in a few minutes. In fact, 15 to 20 minutes, you get the result. Whereas in vitro tests, it can take up to a few days. It is much less expensive, more easily available, and very important fact is that the patients actually get to see the reactions while we do the test, and this helps them to understand the disease better, the reaction that happens inside the airways and inside the other organs better, and that helps in better compliance with the treatment and so on. And finally, the solutions for skin testing can be made for a variety of air allergens, foods and medications, which is not possible with in vitro tests. What are the indications for doing an allergy skin test? As I said earlier, diagnosis of various IgE-mediated diseases, including asthma, allergic rhinitis, conjunctivitis, food allergy, drug allergy. Even though penicillin is the only standardized, validated form of drug which can be tested, you definitely can test for other drugs as well. There are several protocols and methods available for that. Venom allergy and finally latex allergy. Other than that, we can use it for screening to identify predisposition to develop allergic diseases. It can be used as a part of epidemiological studies to determine trends and sensitization rates or regional differences. It can be used for standardization in the process of standardization of allergen extracts. And finally, to even diagnose rare diseases like ABPA, eosinophilic esophagitis, and eosinophilic gastroenteritis. What are the contraindications? Any diffuse skin condition which precludes the introduction of allergen into the skin. Severe dermatographism, recent anaphylaxis within, especially when it is within the previous month, which will give a false negative reaction. If the patient is unable to stop antihistamines or other interferon drugs, again can give a false negative reaction. And patients who are symptomatic with severe uncontrolled asthma and are all contraindications, but there are some relative contraindications, namely pregnancy, doing in babies and infants, and patients with significant cardiovascular diseases, especially unstable angina and arrhythmias. In these patients, we need to take into consideration the clinical benefit that the patient will get out of the test. And if it is not significant enough, then we should avoid the test, or if we can do other tests like in vitro tests, that should be preferred over skin test. But in case it can give a definite clinical benefit, then it can be done with caution. So what are the factors? There are several factors which actually ultimately determine the result of a skin prick test and of course the interpretation of it as well. The first and the most important problem are the drugs which interfere with the results of this test. So what are the drugs we need to withhold before we do a skin prick test? The most important ones are the antihistamines, as all of us know. The first generation antihistamines need to be stopped for 3 days, second generation at least for a week. What we need to remember about antihistamines is that if we do not withhold for adequate period of time, the histamine reaction can still be positive. At the same time, there can be a much decreased reaction to the other allergen extracts. So just because histamine is positive, we cannot say that the patient is completely out of the effect of the antihistamine. So in case the histamine is not significantly positive and the reaction to the allergens are much lesser than what we expected, then it is prudent to retest the patient after stopping the medications for a few more days. So other drugs are antihistamine nasal sprays and eye drops, which can be absorbed systemically. So they have to be stopped for 3 days. Omalizumab, if the patient is on, we can't do because the reactivity might be less. And so ideally better to do after 6 months. If not, there are studies which have shown that after 4 to 8 weeks of stopping omalizumab, the skin reactivity returns. So maybe we can try after 8 weeks. H2 receptor antagonists have to be stopped for 2 days. Phenothiazine antiemetics, which are other antihistamines used for other diseases than Ig-mediated, should be stopped for 2 weeks at least. Tricyclic antidepressants again should be stopped for 2 weeks. Which are the drugs that can be continued, need not be stopped for doing an allergy skin test? Leukotriene receptor antagonists need not be stopped. Inhaled steroids need not be stopped. Short-acting and long-acting beta-agonists and theophylline need not be stopped. Systemic steroids, there have been several studies to see the effect of systemic steroids on skin reactivity, and so far there is no confirmed evidence that they do reduce the skin reactivity. However, after the test, if there is a doubt of decreased reactivity or unexpected results, then it will be good to do an alternative test like an in vitro test or to do a skin test after stopping the steroids. Topical steroids given for more than 1 week have been found to decrease the skin reactivity. And so when we do on patients who are on topical steroids, we should avoid the inflamed areas on the skin and also avoid the areas on which the topical steroids have been applied. The final group of drugs are the beta blockers, alpha blockers, and AC inhibitors. These do not interfere with the test directly, but in case the patient develops anaphylaxis, these drugs can interfere with treatment and recovery from the anaphylaxis. And so in a patient with a high risk for anaphylaxis and with comorbid cardiovascular conditions or other conditions requiring these medications, we should take extreme caution either do other tests like in vitro tests or do this test after, if at all these drugs can be stopped after stopping these drugs. The other factors that can affect the skin reactivity are age. Very young babies and infants can have less skin reactivity. Elderly above 50 or 60 years of age, again the reactivity starts reducing. But we have to remember that skin test is still useful even in this extreme age groups, and so whenever it is required, we definitely have to use it. Based on the site, again, skin reactivity can change. For example, skin over the back is supposed to be the most reactive, whereas forearm and arms are much less. But these changes in skin reactivity have not been proven to be clinically significant. So it doesn't really matter where you do it. The olar surface of the forearm is preferred site because it is easy to access. And as I said earlier, the patient can watch the response. Generally, it is advisable to avoid areas with less reactivity, which are wrist and the antecubital fossa. So there should be a distance of at least 5 centimeters from the wrist and 3 centimeters from the antecubital fossa. Finally, the technical factors. First and most important factor is the quality of the allergen extract that we use for the test. If the quality is not good, the whole test becomes useless. So it is of great importance, or the utmost importance, that we use quality standardized allergen extract for the test so that the test has some meaning. And then the device that we use, and again, there are several devices available in the market. There have been studies in Europe which have compared these different kinds of devices, and what they show is that a single head metal lancet is much better than is comparatively better than other devices, and it has the best reproducibility and the least false negative results. The multi-head devices are also available, but they can have variability in reactivity. For example, the center might show a little less reactivity than the peripheral areas. But again, we should remember that multi-head devices help to apply several different allergens very quickly. So when we are doing in young children, that might actually be helpful. But overall, the single head metal lancet has been found to be the best. And finally, the quality of the person who's doing the test is most important, again, just as the quality of the extract is important. So the skill of the technician who is doing it, or the doctor who is doing it, is also of paramount importance. So what are the methods of doing an allergy skin test? It can be done as an epicutaneous skin testing, which could be scratch, prick, or puncture test. And the second way of doing it is an intradermal test, which is more sensitive but has a much higher risk of systemic reactions. It is used mainly in evaluation of drug allergies and venom hypersensitivities. It is not commonly used for other allergic diseases. The devices that we use for a skin prick test are, as I said, metal lancet, hypodermic IV needle, plastic lancet, and multi-head devices. But compared to a metal lancet, plastic lancet has been found to be inferior in some of the studies. So the preferred choice of device would be a metal lancet. How do you select allergens? How many allergens do you test for? So there are two approaches to this question. The first one is a focused approach. When we say that when, for example, a patient has immediate reaction to a drug or to a food or to an insect bite, the history is very clear, then we do not have to test for a multiple group of allergens. We just have to test for those particular culprit allergens and decide what to do later. The second approach is a broader approach where the patient has asthma or allergic rhinitis or conjunctivitis, where we need to do a panel of tests. But this panel, again, should not include more than 15 to 20 allergens at a time. And these allergens should be the most pertinent for that particular patient. Turn on your mic. The groups of allergens that we need in the panel for a patient with asthma or allergic rhinitis are first the outdoor pollens, which should include tree, grass, and weed pollens. But the choice of the pollens should be based on the aerobiology data of that particular region, from where the patient is coming from. Molds should be there. It should at least include Alternaria, Penicillium, Cladosporium, and Aspergillus. Dust mites and cockroach should be a part of every panel, and animal danders also, if possible, cat and dog epithelium should be there. These are the basic minimum that should be there. And in general, as I said, the panel should not exceed 20 or so allergens, because the more than that actually does not add any advantage to the testing, and it will only create more confusion when we interpret the results. So how is this procedure done? What are the materials that we require to do allergy skin prick test? First, we of course need standardized allergen extracts. We need a positive histamine control and a negative glycerinated saline control solutions, sterile lancets for pricking, sharps container, marker pen for the skin, ruler for measuring the reactions, tissue wipes and spirit, recording sheets where we record the results of the test, and gloves. Let's go through the steps of the procedure. First, we clean the site with alcohol, followed by the second step is where we have to number the allergens. We have to make sure each allergen has a number, and these numbers should be marked on the skin with different positions for numbers, with adequate space in between, with at least 2 centimeters apart, so that overlapping reactions and false positive results are avoided. The fourth step is to apply a drop of allergen in the place where the number is marked with a dropper bottle. A very, very small drop should be placed on the skin. After you place all the drops, you take a single head metal lancet, as I said earlier. It is passed through the drop, penetrating the skin at an angle of 45 degrees, and then we lift the skin, creating a small break in the epidermis. It should not be deeper than that, which could cause bleeding and false positive results. So this is a picture of where we drop the allergen. And the second picture is where the metal lancet is used to prick at a 45-degree angle and lift the epidermis to create the small break in the uppermost layer of the skin. The sixth step, the lancet that is used for pricking should be changed for every allergen, ideally. If we can use the same lancet for multiple pricking, but when we wipe, there is a chance of when we wipe with spirit, still continues to be a chance of cross-contamination, as well as risk of injury to the healthcare personnel. And so ideal will be to use a new lancet for every prick. And finally, after you do all the pricking, all the excess solution that is kind of dripping from the areas where you pricked should be wiped off with a clean tissue. And then we wait for the reaction to happen. So the histamine reaction should be read at 10 minutes after you start the procedure. And for the other allergens, we should wait 15 to 20 minutes to read the reaction. The other type of skin prick test that we might need to do for certain patients who have food allergies, especially for foods which are not commercially available and with stable allergen extracts, we can use the food itself to do a skin prick test, which is called prick-on-prick method. And in this method, the food and the patient's skin are first cleaned properly, and then the test device, the lancet, in this case, is used to prick the food first and then the patient's skin, in a similar fashion as I explained to you just now. And if there is a positive result, we need to make sure it is not due to increased skin reactivity or an irritant reaction by doing it on a non-allergic individual as a control, so that to make sure that it is not due to mere skin irritation. how do you measure the reaction? So the first measurement should be done for the positive and negative controls. As I said earlier, the positive histamine control should be measured at 10 minutes and it should be more than or equal to 4 millimeters. The negative control should be less than 3 millimeters. The measurement of wheel of the other allergens should be done at 15 to 20 minutes. The measurement is done using a transparent, if possible, a flexible ruler. And there are two types of measuring the wheel. The first one you can measure as a single measurement by measuring the longest diameter and the shortest diameter, adding both of them and dividing them by 2, finally getting a mean diameter, expressing it in millimeters as a single measurement, or it can be measured as the longest diameter and the diameter perpendicular to the longest diameter and expressed as 2 measurements as millimeters into millimeters. And as I said earlier, the reaction with the allergen extracts is considered positive if the wheel is more than or equal to 3 millimeters when compared with the saline control. So this is a photo which shows the measurement of the wheel in a patient. So you use a transparent ruler and measure the longest diameter and the shortest diameter, and then express it either as a single measurement or as 2 measurements. After the test, all the numbers that were written on the screen should be removed and cleaned with the alcohol. And then the patient should be asked to wait for at least 20 minutes after the test, as there is a small risk of developing systemic reactions. And patients should also be told about the possibility of developing late phase reactions, which can happen in certain patients, which usually starts 2 to 4 hours after the test and usually resolves within 24 to 48 hours. Documentation. It's a very important part of doing a skin test, because unless we document, we will not be able to see it subsequently. So the best way to document is we have to, this is just an example of a documentation sheet. The name, the age, the sex of the patient, the hospital ID, the date, everything needs to be there. And very importantly, time in, that is when you start the calculation of time for histamine, and the time out, the time you finish do the recording of the reaction should be documented, and should be within 10 minutes for histamine and within 20 minutes for the other allergens. And then the name of the allergen should be recorded along with the diameter of the wheel size, either a single or 2 measurements, along with certain information like presence of erythema, presence of pseudopodia, and so on, and then the final report. And it has to be signed by the person who is doing it and by the doctor who is overseeing the allergy skin test. What does a positive test mean? It means, it indicates what we have to remember most definitely, that it indicates only sensitization and not allergy, until we are able to demonstrate that the symptoms are due to those allergens, either with a good history or in some cases with a challenge test. So in general, just by doing a skin test, the positive reactions are considered sensitization, unless it is demonstrated that these symptoms are due to those particular allergens. Positive test without any relevant clinical history could be due to subclinical sensitization, sometimes due to a false positive reaction, and sometimes even due to the lifestyle of the patient, where the patient is not exposed much to the allergens that he is sensitized to. The sensitivity and specificity of positive test is quite good, especially for the standardized inhalant allergens, and it has been found to be more than 85% overall. What does a negative test mean? The negative predictive accuracy of allergic skin test to rule out Ig-mediated disease is more than 95%. However, a negative skin test still cannot completely rule out an Ig-mediated allergy. We need to keep this in mind that it can still be there. and the negative skin prick test in a child cannot rule out the future possibility of development of allergy in that particular child. As I said earlier, there is a small chance of developing a systemic reaction, but the risk is very, very less. Generally, it is extremely safe and well tolerated by most patients, including children. The risk is only 0.02% to 0.05% in several studies and reviews done over the world. And usually these systemic reactions are also mild. And mostly these reactions are seen in patients who have uncontrolled asthma and in patients who have been tested for food or drugs. And it is almost never happens with air allergens or the other allergens. And as per the World Allergy Organization recommendations, skin prick tests can be done as an outpatient, provided we are able to keep them for observation for at least 20 minutes after the test. Finally, but very importantly, as I said earlier, the result of the test depends ultimately on the quality of the extract, the device that we use, and the quality of the person who is doing the test. And so this, to maintain reproducibility of the test, we need to make sure that any allergy testing lab should make sure that the staff is periodically tested for proficiency at least once in 6 months. And this testing is documented for quality purposes. So how do you do it? You use the device that you normally use and ask the person to perform skin testing with histamine and saline in an alternative pattern on the subject's back or on the forearm, and mark it as H1, S1, H2, S2, and so on, like this. This is shown over the back, but it can be done over the forearm as well. So 10 histamine and 10 saline has to be done. And then, as usual, histamine is read at 10 minutes, saline is read at 15 minutes. And then we have to calculate the mean diameter with the maximum and minimum and the perpendicular diameter divided by 2. And this mean diameter is used to calculate the mean and the standard deviation of each mean diameter, after which we need to determine the coefficient of variation, which is calculated by dividing standard deviation by mean of these mean wheel diameters. And this coefficient of variation should ideally be less than 10% or lesser. That up to 30% is acceptable, but ideally it should be 10% or lesser for that particular person to continue testing. In case it is 30% or more, the person should undergo additional training before they can start doing on a patient. In this proficiency testing, saline, that is all negative control, should have less than 3 millimeter wheels and less than 10 millimeter flares. So again, any negative control which is more than 3 millimeters or more should again be considered a negative proficiency test, and the person should again undergo training for a few weeks or so before they start doing for the patient. Thank you for listening to me.
Thank you, sir, for this wonderful deliberation, sir. So actually, we are running short of time. Will not have that opportunity to take questions. So I request all the delegates to type your question in the chat box so that we can address it later. And one thing you had beautifully mentioned, that skin test is it is an investigation, but we should interpret it carefully along with the history taking. The history taking is one of the most important part of this particular test. So with that, yes, again, I thank you once again. Now, may I request Dr. Abhinav to please go forward with our next symposium.
Thank you so much, sir. Thank you so much, Dr. Jevin, for a beautiful presentation, sir. Thank you for sharing your experience. With this, I would like to invite our esteemed chairperson for the next session on therapy for allergic disorder. So, so we have two chairpersons. First is Dr. S.P. Dhaneria, sir, who is currently Dean and Professor and Head of Department of Pharmacology at AIIMS Raipur. Sir has almost 35 years of experience after MD and multiple papers publication in national and international journals, and speaker in various forums. It is an honor to have you here, sir, with us today. And we also have our esteemed faculty, also Dr. Debashish Hota. Sir is again a professor and head Department of Pharmacology at AIIMS Bhubaneswar, and multiple presentations sir has, and sir is also a subject expert with DCGI committee, CDS CO New Delhi, and chairman of Ethics Committee and Central Ayurveda Research Institute Bhubaneswar, and independent director of Odisha State Medical Corporation Limited. It is an honor to have you, sir, here. And over to you, sir, to chair the next session on therapies for allergic disorder. Thank you so much, sir.
কি বলছিস?
Hello, requesting all other speakers to mute themselves. There is some sound is coming from the background. So may I request all the others except the speakers and the chairpersons to please mute yourselves. Sorry, sir. Sorry for this unavoidable circumstances.
Hota sir, please go ahead, Hota sir.
Right. Yeah, this is regarding the allergy, this symposium, right, that we are now in. And although various treatments, various advancements have taken place in the field of allergy and this treatment of allergic conditions, very commonly we experience allergy. It may be due to contacts, or it may be due to ingestants, or due to inhalants, and it is day-to-day life we are experiencing it. We have beautiful, which I have been listening to, and we know how to diagnose. Now it is about the management part, which is again a challenge, and we have so many drugs, but all drugs are not effective in all conditions. So there is a challenge for the prescriber and the patient, which drug suits most. So we have the presentation now. Dr. Dhaniria sir, please add anything you like to add.
I think first presentation is by Dr. Nagendra Prasad, and he will be speaking on biologics in asthma. We have been treating asthma with bronchodilators, which are including the beta-2 agonist, anticholinergics, methylxanthines, and then we have the drugs which reduce the bronchial hyperresponsiveness, steroids, mast cell stabilizers, leukotriene modifiers, and also the phosphodiesterase 4 inhibitors. But now we are getting the biologicals. For example, we have the anti-IgE drug or interleukin-5 inhibitors, antagonists. So this is a new therapeutic modality in the management of asthma. And Sir, Dr. Nagendra Prasad will be covering the biologics in asthma. So I request sir to start the presentation, sir.
Shall I share the screen?
Sure, sir.
Please.
Yeah. The screen is visible, sir?
Yeah.
Yes,
yeah.
sir.
At the onset, I thank the organizers of ALLERCON 2021 for inviting me to present this paper. And also I thank Shambhu and Dr. Aratika Das and Professor Saibal Moitran, and also respected chairmans, Dhaneria and Debashish Hota. Today I'll be covering a brief on biologics and asthma, and you'll be hearing about biologics and its mechanism and action. So today I will be discussing on what is biologic, when would you need a biologic, benefits of biologic, what biologics available for asthma, and how are biologics administered, how long the need of biologics, and we conclude. GINA guidelines specifically given a biologics a role in step 5 when step 3 and step 4 where inhaled corticosteroids, oral corticosteroids fail to act. And step 5 is very, very crucial for persistent allergic asthma management. What is that uncontrolled asthma defined as one of the poor symptom control with ACT less than 20 and also symptoms not well controlled over 3 months and a frequent severe exacerbations which may be more than 2 bursts of systemic corticosteroids and still they might have used more than 3 days in the previous year. Serious exacerbations which may be having one-time hospitalization with ICU or with a MV in a previous year. Airflow limitations, FEV1 less than 80%, predicted following a withhold of bronchodilators. What are the biomarkers? We call it as type 2 inflammation. Commonly we use blood eosinophils or sputum eosinophils, total IgE or a specific IgE and a FeNO. This is the pathway to define allergic eosinophilic airway inflammation and non-allergic eosinophilic airway inflammation, just to give you a gist of ideas how these two has to be distinguished with these pathways. And eosinophils, which you are very familiar and which is a very host protective, that is a granule protein cytokines, cytotoxicity which has been released from the granules, which is more pro-inflammatory and immunoregulatory with the T cells, B cells and anti-T cells. Coming on to the comorbidities in severe asthma, and these biologicals will be acting only on, there is chronic rhinosinusitis with or without nasal polyps, another group ABPA, and another is allergic rhinoconjunctivitis. So endotyping mechanism is, there is allergic and non-allergic, these two distinguished characters has to be understood before application of biologics. In our system, the interleukin which has been released from the bone marrow, which is responsible for inducing the eosinophils, and also another factor called cytokines, which is a serum periostin, which is also the inner layer, the bone marrow. And these two are responsible for induction of eosinophils through interleukin 5. Another cytokine called interleukin 13, which is also helping to boost the eosinophils in the circulation, and also the fractional exhaled nitric oxide, which will be more than 20 ppb, and a total IgE, total eosinophils also is seen in the systemic circulation. And also you can see that sputum eosinophil increase more than 2%. Coming on to the IgE molecule, which is commonly seen in the atopic individuals who are prone for allergies. This IgE enhances if the serum IgE more than 30 Ku per liter, and that is a significance of symptoms of allergies. So these are the 4 biomarkers which is validated in identifying the therapy for the biologics in persistent asthma. So there are types, 2 levels are there. One is low level, one is high level. And there is no, as such in allergic specific IgE, which is more than 30 is a significance, but less than 30 is not a significant for inducing the symptoms. But definitely with the blood eosinophils, a low type is less than 150, more than 300, we call it as high type 2 levels. And the sputum eosinophils is always seen only in the high level, more than 2 to 3%. And a FeNO, which is less than 25 ppb, is seen in the low type of reactions, whereas in high, it is more than 25 ppb. Now let us go with the biologics. We will define what is biologic. Biologic is a medication made from the cells of a living organisms like bacteria or mice, then modified to target specific molecules in humans. In asthma, the targets are antibodies, inflammatory molecules, or cell receptors. Biologics are monoclonal antibodies, which is abbreviated as MABs. Biologics work to disrupt the pathways that lead to the inflammation that causes asthma symptoms. So we will go with a high type of 2 asthma. So immunoglobulin E, which is binding before the mast cells, which is freely floating in the serum and which is blocked by anti-IgE. And we have a biologics called omalizumab. And another factor, which is a interleukin 5, which is the main responsible for the induction of the mediators or granules from the eosinophil, which is acting on the tissues and inducing the symptoms, or IL-5. Or the receptor which is binding, which is on the eosinophil cell wall. These are all responsible for the action of anti-IL-5. We have mepolizumab and restylizumab and bernalizumab. Bernalizumab acting as on the blocking of the 5-alpha receptors. Another biologics which is yet to introduce in our country, which is acting on interleukin 4 and 13, that is dupilumab. So the mechanism of action which will be discussed, this is a small cartoon to show how these different biologics will be acting. When you do need a biologic is used when the symptoms poorly controlled with conventional pharmacotherapy, require recurrent hospital admissions, emergency room visits, and on steroids, which are difficult to withdraw. The asthma symptoms becoming worse even on repeated use of short-acting inhibitors. Biologics are precise and personalized medicine. So the right patient of Th2I is more significant than T2 low asthmatic conditions. What are the benefits by using the biologics? The primary benefit of biologics to reduce the frequency of asthma exacerbations, including emergency room visits, hospitalization, and need for oral steroids. Biologics shown to improve the quality of life with asthma. Few biologics improve lung function. So what biologics available for asthma is US FDA approved 5 biologics. One is omalizumab, mepolizumab, restylizumab, and bernalizumab, and dupilumab. Omalizumab is a molecular and monoclonal antibodies. Antibodies is IgE, which is approved for 6 years and above. So these has different characters which act on the different levels. Only omalizumab is acting exactly on the IgE molecule, whereas the rest of the this mepolizumab, restylizumab, and bernalizumab, which act on the interleukins. So the indication for omalizumab is moderate to severe persistent asthma uncontrolled by inhaled corticosteroids in age plus or minus 6 years, positive for perennial aeroallergens, that is atopic in nature, And the dose commonly we suggest 75 to 375 milligrams subcutaneously. And dose is weight dependent and the total IgE content. It is given at an interval of 15 days to 4 weeks interval. Mepolizumab add-on maintenance for severe asthma in ages plus or minus more than 12 years with eosinophilic phenotype, 100 milligrams subcutaneously, which is given always with 4 weekly. Bernalizumab add-on maintenance for severe asthma in more than 18 years with eosinophilic phenotype, 30 milligrams subcutaneously, so which is given first 3 dose at an interval of 4 weeks, then 8 weekly. Now we will see the distinction between atopic versus eosinophilic. Atopic is IgE mediated, which is always happens in the early onset in the beginning of the life. Allergen exposure related symptoms, similarly like pollens, which is always exposed to the environment, to the outdoor, and allergic comorbidities having a rhinitis, atopic dermatitis, or food allergy, and always with a SPT, skin prick test positive, which you heard just before this lecture. And specific IgE is a specific, significant rather than total IgE, and FeNO is always higher than 20 to 25 ppb. Eosinophilic asthma is a late onset, always after the middle age, non-atopic, may have the nasal polyps or without polyps. Symptoms and exacerbations are always high, and you can see number of eosinophils in the blood significantly. One important message is both respond to inhaled corticosteroids and oral corticosteroids. Now, this is an algorithm just to give you the how we can proceed with a flow chart, which may be variable from time to time on understanding the biologics, how it acts, and combinations and other things in the future days to come. It is just a beginning era on biologics. And if the atopic asthma is responding with omalizumab for more than 4 months, if it is effective, then continue with the omalizumab. If it's not effective, then look into the eosinophils. And if it's a blood having a high eosinophils, then you start with the anti-IL-5 for 1 year, and effective continue for these are all doses which is to be adjusted according to the need of the patients. And if it's not effective, then you can withdraw. So this is a stratification for biologics. One is omalizumab and anti-IL-5. This is very crucial to understand what is the difference between omalizumab and anti-IL-5. Primary mechanism of action is anti-IgE in omalizumab, whereas in anti-IL-5 is against the interleukin-5. Other potential mechanism of action is anti-rhinovirus, especially omalizumab in children in a pediatric group, which is having a recurrent rhinovirus infections, which can be controlled by omalizumab. That's the one plus point. Biomarkers for patient selection, IgE to indoor allergens in the omalizumab, whereas in IL-5 is only eosinophils. Stratification of the patient, severe asthma plus high dose controlled, that is the inhaled corticosteroid plus oral corticosteroids. Efficacy, we have a randomized control studies, and real life is also seen because which was there from last more than 1 decade. And the other anti-IL is only randomized controlled trials, which is just having experience in the field, phase 4. Omalizumab can be treated with children with above 6 years, whereas anti-IL-5 is treated more than 12 years. Patient selection is only depending upon the total IgE and BMI, whereas in ITI, this BMI for resoluzumab and the total eosinophils. Administration is always subcutaneous, whereas mepolizumab is subcutaneous and restylizumab is intravenous. Clinical relevant outcome is a severe exacerbations always respond individually. Safety, 10 years of post-marketing surveillance safe in phase 3 studies. Biomarkers of efficacy is eosinophils. Demonstrated early stopping rule is 4 months, whereas in interleukin is unclear, but still it can be extended up to 12 months. So these are all significance between the two. How long the need for biologics? There is no fixed duration recommended. Guidelines recommended trailing the medication for at least 4 months to see it is helping to improve the asthma. How much do biological cost? Biologics at present are expensive and work out the necessity of need of the hour. And if insurance cover, use as per the guidelines. Summary is high-level evidence of comparative effectiveness of biologicals in severe asthma is lacking. There is no head-to-head randomized controlled trials comparing the anti-IgA and anti-IL-5. Comparing the pharmacological like LAMA, azithromycin, oral prostaglandin D2 antagonist, and non-pharmacological treatment like bronchial thermoplasty of monoclonal antibodies is necessary. You see, inhaled corticosteroids are the core component of asthma treatment and the only maintenance therapy known to prevent asthma death. It has to be underlined. ICS adherence must be assessed in all healthcare settings and ongoing support provided. This applies equally to patients starting biologic therapy, and once a patient is established on a biological therapy, this approach cannot be relaxed. There is currently no evidence that biologics prevent asthma death in people with asthma, and as such, biologic cannot be recommended as an alternative to ICS therapy. So, European Respiratory Biologics Forum, which always have given underlying questions, which has to be resolved. How can biomarkers and phenotypes be best identified and utilized in a daily clinical practice? Is the ACQ a right tool for monitoring response to biologics? Is a treatment response assessed using the ACQ related to the effect of treatment on exacerbations? How can awareness be raised among patients and non-specialists regarding the burden of oral corticosteroids and the potential of new treatments available? Are oral steroids effective in a patient's having exacerbations while on biological therapy? There's a question mark. When should patients start and stop taking a biologic? When should patient be switched from one biologic to another? Or a combination of 2-3 biologics can be combined and given? So these are all to be addressed. I think it is too early to give these informations. Over a period of time, we could be able to address. How it is administered? It is always administered subcutaneously or intravenously with observation of 30 minutes in the doctor's office. Earlier, omalizumab was given as an inpatient and that has to be administered. Now it is not necessarily. And dupilumab in subcutaneous injection. All biologics administered are different, ranging from every 2 weeks to 8 weeks, which I have discussed. The side effects, oral published data show biologics are very safe. Occasionally, soreness at the site of injection, headache, sore throat, and fatigue. Omalizumab has been a small risk of anaphylaxis with a certain type of parasitic infections or varicella vaccination. EACI Biologics Guides for Severe Asthma, which is also released in 2020 with having a 3-pillar points. And the term of optimization for effective therapeutic response, which holds good in overall, apart from biologics, the medicine's optimization is about ensuring that the right patients get the right choice of medicine at the right time, using the right target and selecting the right outcome. By focusing on patients and their experiences, the goal is to help patients to improve their outcome, take their medicines correctly, avoid taking unnecessary medicines, reduce wastage of medicines, and improve medicine safety. Ultimately, medicines optimization can help encourage patients to take ownership of their treatment. Take-home message: asthma is a heterogeneous disease where multiple endotypes are interacting and overlapping. The term endotype is highly complex, consisting of several mechanisms. Precision medicine is a complicated process where the focus is on identifying which approaches will be effective for which patients based on genetic, environmental, and lifestyle factors. Precision approaches are mainly based on biomarkers, but there is still many barriers. The classic Th2 response is the main mechanism that drives the use of biologics. Optimizing treatment strategies with biologics, patient endotype targets, and effective safety covering to the patient. Thank you for your patient hearing. Thank you very much. Over to the chairpersons.
Yeah, thank you, sir. Thank you for a beautiful presentation. As a pharmacologist, I really enjoyed the talk. You have added the recent advancements and developments in the drug therapy of severe asthma. However, one question comes to my mind that when to start biologics, you have given a beautiful presentation, but when to stop? Is there any stopping rule?
There's no, that is the one which is a question mark which has to be answered with a currently with a patient's physician's relationship. As long as the therapy is under control and if it's affordable in the present condition of economics, and they can continue for a couple of years, there is no restriction as such. But the physician has to take the responsibility when to stop it, when not to stop it. And secondly, if it's a reimbursed by the insurance people, definitely if you follow with the guidelines, that may be helpful.
Thank you, sir.
Yes, sir.
Sir, thank you very much, Dr. Nagin Prasad Bar, for this excellent presentation and highlighting the exact therapeutic status of these biological in the management of asthma, when to use, if IgE level is more, what is to be used, when there is a eosinophilia, what is to be used. And you have very correctly mentioned that it should not be, these should not be used as an alternative to the steroids, because still the steroid are one of the mainstay in the management. So thank you very much for excellent presentation. Biologics, we have to think a lot, because these are the long-acting parenteral and expensive drug. And as Dr. Hota has mentioned that when to stop, it is a real question. So thank you very much, sir. It's an excellent presentation. We all have enjoyed from it. Thank you, sir.
Thank you, sir. Thank you.
Yes. Sir, now our next presenter, that is chronobiology of allergic rhinitis, an emerging concept. Dr. Balchandra will speak on it. So allergic rhinitis is commonly perceived as a common condition or common cold that commonly people perceive, but there is a lot to it. Even COVID presented as allergic rhinitis. I suffered from swine flu. It initially presented as allergic rhinitis. So how we go about it and how to mitigate it, what are the drugs? So let us invite Dr. Balchandra VV from MedTrain. Dr. Balchandra, please.
Yeah, thank you, sir. And at the onset, I would like to thank the organization ALLERCON 2021 for giving me this opportunity, and also a kind of a out of the stream topic. So I hope my screen is visible. My screen is visible, sir?
Yeah.
Yeah. So out of the stream topic, that is chronobiology in allergic rhinitis, an emerging concept. Actually, an emerging concept, I don't think so, because when I looked into the data, the chronobiology concept is a very, very age-old concept. And actually, knowingly or unknowingly, most of our clinicians, we are doing a chronotherapy based on our experience. Okay, when I give an allergy medicine at this particular time, it works much better. My patient with allergy have symptoms at this particular time, so let me target that particular symptom at a particular time. So knowingly or unknowingly, we are using a chronotherapy. But in today's talk, I would like to more emphasize on what all the science behind chronobiology of allergic rhinitis or airway allergies, and what all the clinical manifestation and how to utilize this knowledge in our therapeutic practice. So now let's look at this beautiful slide. What it says is there's something called chronobiology clock. Our body runs like a clock. In the middle of the night, the epidermal mitosis is at maximum. Most of the surgical deaths happen somewhere about 1 o'clock to 2 o'clock in the middle of the night. Is there any specific reasons which could be attributed? Very difficult to tell. So usually our BP is at lowest at around 3 a.m. in the morning. And asthma attacks are more common around 3 to 4 a.m. Rhinitis attacks are more common about 5 to 6 a.m. Most of the cardiac angina happens around early morning. If you see, we have a best performance, mental performance is at somewhere around 2 o'clock, 3 o'clock. I don't know, difficulty to agree after the lunch. But best PFT, best lung function test is at 4 p.m. Now there are so many things like this, but isn't it a beautifully deposited our body, how it works in a 24-hour cycle? And the knowledge of this particular thing, if we focus on that, definitely we can make a big difference in the medical community or in the patient care. So we'll go on to the next part. So what is the outcome of today's lecture, which I want to deliver next 15 minutes? I would like to discuss briefly on chronobiology of airway allergies. I would little extend my talk from allergic rhinitis as well as asthma because of the concept of united airway. I would like to show some clinical importance of chronobiology and a treatment approach based on chronobiology. Now, what is this chronobiology? It's a study of biological rhythms. That means how our body behaves in a 24-hour cycle. It's a chain of events which happen and which recur regularly in a temporal sequence. Whether there is an environmental input or environmental input is not there, irrespective of that, our body behaves in a 24-hour cycle in a regular temporal sequence. Now, if we actually forget about medicine, forget about our patient care, if we think our own body, we do behave in a particular fashion at a particular point of time. Let it be our hunger, let it be our coffee time behavior, let it be our energy level, we do behave in a particular cycle. So that is what is chronobiology. Chronobiology is nothing but when a disease behaves in a particular fashion in 24-hour cycle, like sometimes it is more, sometimes it is less. That is what is chronobiology. Now, it's quite interesting. I would not go into the depth and details of all the physiological mechanisms, but since it's curiosity, I would like to emphasize on this particular slide. Like most of the chronobiology, how it works is based on the light signals which we get through our eyes and through the optic nerve, the suprachiasmatic nucleus, which is stimulated. And once this nucleus is stimulated, there is a role of melatonin hormone. And as well as these central stimulation result in an hormonal and a neuronal signals which happen and thus results in an effect on our kidney, on our lung, on our nerves, on our liver. So this is how a simplified concept which I have put it, though there are more complex mechanisms and cytokines or hormones or neuroreceptors are playing a role in that. Now, let me give you an example, what we generally come across in our day-to-day practice. So let's see an 8-year-old child presents with cold and cough from past 4 days, and parent complained that he gets frequent cold and cough and is very irritable in the daytime. Now this child, straightforward, when we look into that, we think it's some kind of a viral infection, and we can treat him as a viral infection and send him back home. But here what catches the point is that frequent cold and cough, and why is the child irritable in the daytime? Now let's look into asking more specific questions in this child. We just have to ask, how is the child in the day? How is the child in the night symptoms? So he regularly has got nasal discharge and sneeze in the early morning hours and has got very much disturbed sleep. He also snores and has got mouth breathing. So now our focus and our diagnosis switched from viral infection to something a chronic nasal or chronic airway condition, possibly an allergy. Possibly we are looking at this child is having an allergic rhinitis, this child is having possibly an adenoids, and this child is going through that sleepless nights, which is making him to behave in a different fashion in a daytime. So how knowing and having the knowledge about how a disease behaves in 24-hour cycle and asking a specific questions to the parent probably reveals an actual diagnosis. If not, this child would have just passed on as a viral infection, which happens most of the times, unless a person who is experienced in managing these conditions takes a detailed history and diagnoses it. Now, how does it matter? How does it really matter for us to identify the clinical condition, to understand the severity of the condition? So if we see, even if our ARIA guidelines to grade mild persistent, moderate persistent, severe persistent, we classify how the symptoms have behaved in the night times, how the child's or patient's activity has been in the daytimes. Even in our asthma scoring system or asthma control test, how many times the child had a disturbed sleep or cough or wheezing in the night times. So it's so important for us to have a specific questions at different point of time to assess how the child's severity of the condition is behaving. And it's also important that how much this health condition is having an impact on his lifestyles. It's also necessary, chronobiology is necessary for us to select the correct medication. And not only that, correct dosage. Our dosages should be in such a way that it has got a maximum therapeutic level at the time when the patient is having a maximum symptoms. And it is also important to select the correct timing of the medication. There's no point in giving a medication when the patient is not having symptom and not giving medication when the patient is having the maximum symptom. So chronobiology matters to identify the clinical condition, to know the severity of the condition, and to select the right medication and right dosage and right timing. Now let me go through this allergic rhinitis. Sneezing and runny nose, blocked nose, itchy nose exhibit circadian rhythms which are worst in the overnight and early morning. And not only this, there is an evidence that there is a circadian variation in nasal reactivity to methicillin, increased activity of eosinophils and basophils in the nasal mucosa, nasal airway resistance triples on lying down, poor sleep, of course, affects the mood, cognition, and motor performance, and definitely poor sleep. So there is not only a clinical exhibit of more symptoms in the night and early morning hours, there has been some evidence to say that the allergy activity in the nasal tissue and airway tissue and allergy cells, which we call as eosinophils, are at an higher level in the nasal tissue at that point of time. Now let's look at the circadian rhythm of an asthma. 75% of asthma patients awaken night, and the methicillin challenge test again shows a bronchial reactivity in the night. Bronchial reactivity to allergens such as dust mite is highest in the night, and the activity of alveolar eosinophils, which peaks significantly at the midnight and during the early morning hours. Then PFT is least in the early morning and best at 4 p.m. And definitely this results in poor sleep, and poor cognition, and more asthma morbidity and mortality in the early morning hours. So this not only clinically, again to re-emphasize, there has been an evidence of PFT or an eosinophil level or a methacholine challenge test saying that early morning hours have a worse symptoms for an airway allergies. Now, let's try to see if we can correlate our allergic airway allergy symptoms to the hormonal imbalance which happens, or rather hormonal circadian rhythm which goes through. Now, glucocorticoid production is under the control of circadian rhythms. Blood glucocorticoids have a peak at morning 8 a.m. and have a lowest in the midnight and are about 3 o'clock, 4 o'clock. This is seen in humans. Now, if you see this graph, somewhere midnight 12 o'clock to about 4 o'clock, 5 o'clock, the level of ACTH and cortisol is at the lowest level. And this starts peaking at around morning 8 a.m. Okay, that's the reason why we do cortisol tests at morning 8 a.m. So this is lowest at about 3 o'clock, 4 o'clock, and we know that cortisol is a natural protector for airway allergies. And let's see the bronchodilators. Again, at midnight, 12 o'clock, 1 o'clock, 2 o'clock, 3 o'clock, 4 o'clock, the level of cortisol is less, the level of epinephrine is less, the level of norepinephrine is less. However, they all start peaking at around morning 8 o'clock, 9 o'clock, 10 o'clock onwards. So this straight away correlates why there is a bronchoconstriction for an asthma in the middle of the night and early morning, why there is a nasal symptoms in the early morning hours for an allergic rhinitis patients. Now let's look at how we apply this knowledge in our therapeutic process. Timing of the medicine is more important than dosing alone. A same dose can be given at different time to have a better effectiveness. Some of the medications used may have to be dosed differently. Evening or night dose is more effective, and giving the medication so that the serum level peaks at around 3 to 5 a.m. when the disease process is at maximal. Now, let's see some of the evidences which is present for this particular concept. Now, pharmacological approaches to daytime and nighttime symptoms of allergic rhinitis. Antihistamine, meclizine has been shown to have improved efficacy when given in the evening hours compared to morning dose. Leukotriene receptor antagonist, which we commonly use in our practice, is again indicated for evening administration. They have significantly improved nighttime rhinitis symptoms. Intranasal corticosteroids administered in morning have demonstrated efficacy in improving the nighttime symptoms. We all know that steroids usually shows effect after 6 to 8 hours after being given. They don't work immediately, and they work on a nuclear receptors. So their effect is seen about 6 to 8 hours after giving the spray. However, there is some research also to tell that the night dose, evening dose may also have a better nocturnal rhinitis symptoms. Now, probably based on this knowledge, we should titrate the timing of our medication to have a better relief. Now, the same concept for asthma. Using a long-acting theophylline is more effective in the late evening, because when you use a long-acting theophylline, we know that theophylline is outdated medication in asthma, but long-acting theophylline has got a better therapeutic level in the early morning. And long-acting bronchodilator along with ICS is more effective when given in night. Now, long-acting bronchodilator like salmeterol or formoterol given in the night has got a best effect in the early morning hours. Antileukotrienes again have a best effect in the evening, and high dose of inhaled steroids at 3 p.m. what we generally use is shown to have a best effect in controlling the early morning symptoms. And 3 p.m. dose of oral prednisolone is not only effective, more effective than 8 a.m. or 8 p.m. Now, the dosage of oral prednisolone can be reduced significantly given at 3 p.m. in comparison to given at 8 a.m. and 8 p.m. And maybe we can titrate it at a lower dose eventually and then maintain that patient whenever required. So now all these things conclude that selecting the right dose and the right timing is so important in management of airway allergies. So I would conclude my talk by again summarizing few points which I want to know is our body, not only our body, our diseases have got a biological or chronobiological clock, and our disease symptoms goes through chronobiology, and our therapeutic approach needs a chronobiological approach to have a lowest dose at the correct timing to have the best effect on the patient's health condition. So I will be concluding this talk. I will be putting this. We do have an allergy asthma specialist course we run, and the next batch starts from January 2, 2022. People who are interested can look into this website. Thank you.
Thank you, Dr. Palchandra. This is a wonderful talk, and I am really impressed with the chronobiology cycle that you have presented in 24-hour and the levels of which endogenous mediator changing with time. And definitely it is very important to take medication depending upon the need rather than prescribing at any time. And unfortunately, during the COVID time, you might have also seen in your center that steroids have been used rampantly and probably purposelessly to a certain extent. So these drugs, particularly this cortisol in the body and ACTH, they follow the circadian rhythm very meticulously. So anytime administration, there is always a risk of therapeutic failure or there is a HPA axis suppression. That is very true. And regarding this allergic rhinitis, and this is you have also combined with bronchial asthma, so they are related areas. So in your experience, what did you find? What is the best option to treat? Because we have a lecture just finished about the biologics. So what kind of cases you have seen in last few months and common type of cases, and which drugs do they respond most?
Sir, not only last few weeks, it's been a standard practice. Let it be an allergic rhinitis or allergic asthma. So the standard approach has been an identifying the patient, identifying the right diagnosis, identifying the right severity of the condition, impact of the condition on the lifestyle of the patient, and deciding the right medication based on the disease condition, severity, and impact on the lifestyle. And if we see, let it be ARIA guidelines or let it be an GINA guidelines, more or less, they all follow through the same pathway. And the selection of medicine has been standard based on the particular condition. However, this timing of this medication has been, before even having a knowledge of chronobiology, I must admit that I was using most of my medication in the evening hours, let it say even an antihistamine giving at late evening, and let it be a leukotriene receptor giving in the late evening, and intranasal steroids or bronchodilators or intranasal corticosteroids. The most important part which is needed for the patient management is demonstrating how to use the medication in the correct method and the correct timing. And in fact, that solves 99% of the failure of asthma patients. It is only about less than 5 to 10%, less than 5% of patients. When a person uses correct medicine and the correct method and correct timing, where he needs an out-of-the-box treatment and then goes for a higher level of biologics or next level of treatment. And I don't think that, and from my experience, you asked me from my experience, COVID did not make any big difference. And very rarely, except acute severe asthma, I've never used the oral steroids, that too for a very short period of time.
Right. Thank you, sir.
Thank you, sir.
Thank you, Dr. Balachandra, for a very good presentation. And we have actually enjoyed your presentation, because in chronopharmacology, now we have the very clear concept that some drugs are to be given at a particular time in order to achieve the optimum therapeutic effect with low toxicity. And you have very clearly mentioned about the acute rhinitis and the significance of medication to be given in evening hours. at one point of time, you mentioned about the prednisolone. It will be best to be given at 3 p.m. Routinely, we always say that steroids are given in morning hours, so the suppression of HPX should be minimum. So your comments on this, prednisolone at 3 p.m. Please, sir.
Sir, most of the steroids have got a mechanism of action. Their receptors are at the nuclear level, and they have to work on the nuclear receptors and then modify certain inhibitors to have the effect of, like we say, steroid has got an effect of modifying the cytokines, modifying the eosinophils, modifying the mast cell activity level. Most of the steroids starts working more effectively after about 8 to 10 hours after giving the therapeutic dose.
Yes, correct.
So now 3 p.m. maximum symptoms or allergy symptoms are present at about 1 a.m., 2 a.m., 3 a.m., 4 a.m., where when we give it a 3 p.m. dose, the effect of the steroid given is max, can actually reduce the dosage of steroid one. Maybe prednisolone, instead of giving 2 mg, we can start giving at 1 mg per kg per dose. This would be the more ideal way. However, when a patient is going to take a medication on a long term, which we generally don't advise it for our allergic rhinitis or allergic asthma patients. Whenever we advise a patient like say nephrotic syndrome, or whenever we are using other autoimmune conditions, at that point of time, our purpose of intention of them using the medication is totally different. We are not looking at immune suppression. That's the time where we use early morning 8 a.m. dose to avoid the long-term HP axis suppression.
Okay.
So I think this is the reason why 3 p.m. dose in asthma would be more appropriate.
Yes. Thank you very much, sir.
Thank you.
Thank you very much. Thank you. Sir, Hota
Now,
sir, please go ahead, sir.
Now our next presentation is on insect allergy and therapeutics. And it is needless to say that we all have experienced these insect bites since our childhood, very common conditions. Many times without bite also we get otherwise unknown. And finally it was unknown bite, and finally it was realized to be insect bite. So insect bite can be, it can be mild, it can be moderate, sometimes it can be life-threatening, especially in case where there is an anaphylaxis type of reaction. Now we have the presenter, Dr. Namrata Ashok, and we'll see what his her experience about this insect bite and what she is actually, her experience says, and we must learn from her. And she says she has 18 years of experience. That means almost 19 years of experience. She's from CMC Vellore. So welcome, Dr. Narmada.
Thank you,
and
sir.
Let us start your presentation.
Thank you, at the outset, thank you for those kind words, and as well as the organizer Aratika Das and Professor Soival for giving me the opportunity to speak about, of course, the insect bite allergy. As sir said, every one of us are suffering from it, even had a bite. So, but is it really the insect bite, insect venom which we really had, or it was just a normal bite we had? So we will just see about it, sir.
Right.
Yeah. So coming to the topic,
please go
basically,
to full screen.
even if you have been talking about it a lot, I will be giving you the general intro and epidemiology about the insect venom in India, the characteristics of insect bite, because we talk about so many insects, but I will mention about the few insects that are medically significant, about the therapeutics and immunotherapy and conclusions. So as we have the 30 orders of insect, but only very few have clinical significance. And among this, there is only one insect order called as the Hymenoptera, which consists of ant, bees, and wasp, which is so very important to us. Of course, we are infested with lice, flies, mosquitoes, this bed bugs, as well as the butterflies and moths. But basically, they are more of a nuisance kind and not really life-threatening. So this lecture, I will be concentrating on the insects which are really life-threatening and is capable of producing clinical symptoms for us. So coming to the Hymenoptera order, if you see, there are actually 3 families of Hymenoptera, which is very important medically. One is the Apidae family, the honeybees and bumblebees. We all have heard how much the bees affect our routine lives of, especially some of the people who go for trekking also. The Vespidae, the yellow jackets, hornets, and paper wasps, and the fire ants. What is very significant is the fire ant is one thing which they commonly come to us with a big swelling, especially in children also. So these are the 3 species we are going to be concentrating on. So and India has actually revealed a predominance of Apidae, and as I said, the ants is in South India, whereas the western in Vespidae, carpenter bees and honeybees and cutter bees and ants in South India, and Apidae in Western India. Coming to the epidemiology, though, as Sir said, we have been dealing with insect bites, even ourselves bitten by it. We really don't have the proper epidemiology in India. Why? Because people who do have who are bitten by insects do not come and report to the emergency room. Those who come and report to the emergency room are those people who have a very significant swelling. So we really do not know the prevalence, but there has been a paper from JIPMER Pondicherry that has reported about 5.27% of insect bites is there in South India. And in Sumit Kaur et al. Has reported in Central India about 10.21%. However, we have a very accurate data from Western studies, which has quoted about 9.3 million people who are annually bitten by these medically important insects, and about among them 1 million are by Hymenoptera stings, and in that they have also documented the anaphylactic death due to Hymenoptera stings. Coming to the epidemiology of reactions, still the incident, we do not have a proper report at all. Only one paper has reported that the large local reaction are to the tune of 17 to 56%. This might be huge because we do not know about the small reactions at all. And systemic reaction among the large local reaction only, we know it to be at 10%. Most of it that pass off as an anaphylaxis, we really do not know how much of them had been due to Hymenoptera. And the systemic reactions are more in adults compared to that of the children. Now, coming to the family of the Apidae, I just want to go brief about the insects because, as I said, we need to medically identify the insects for us to plan our therapy. So, Bombus Apidae is a bumblebees. This is usually found in our stones and bricks, and it has got it's in the underground, and they tend to avoid humans. But we humans do not avoid them. We try to go and meddle around with this, and we repeatedly can get sting by that and by the bumblebees, and they do not have the barbs, and it is not a very aggressive bee. This carpenter bees is also found in dead woods, and it stings only while provoked and no barb stings. But what is very medically significant is the honeybee. It is found worldwide, and it is found in hives, but if it is threatened, they can come in large numbers and bite us, and this can cause another severe type of non-IgE mediated reactions too. The Vespidae family or the yellow jackets, hornet, and paper wasp. What makes it more interesting is nowadays we are all taking on to tourism and to resorts. This yellow jackets, hornets, and paper wasp are more found in resorts. Now you have these children who play around in the beaches around the dustbin area. This is the wasp, and it is very aggressive. So even if the child is not going to provoke them, it can come and easily bite us. So it is also very near the picnic areas and trash containers. So this is the yellow jacket we would have all seen, and it is a very painful sting we will have, and it is usually in the grounds and cracks in building. This polistus again, which is paper wasp, and this is not a very aggressive one compared to that of the yellow jacket, but the only point is it can sting repeatedly. This hornet is very painful. It has got a large venom sac, and also it's a neurotoxin. Sometimes when we get stung by this, we will feel numbness in the limbs, and that is because of the hornet sting. So Formicidae family is the fire ants. There are several species, and the another thing is it can cause severe allergic reaction, and just like honeybee, it can also attack in masses. So it is very important for us to know this 3 medically important family of the Hymenoptera. So identification of the insect is very important for us to diagnose, prescribe treatment, as well as for therapeutic point of view, and then for the educating the patients. So when we come to the therapeutics, we are basically concentrating on venom immunotherapy. For that, we have to know what is the venom basically has. The venom usually has a phospholipase, hyaluronidase, and vasoactive amines, and that is more in the redans too. And it has it can actually cross react among the families. So that is why for us, when we do the allergy skin testing, that particular insect could not have bitten us, but when we have cross reactivity, then we may develop anaphylactic reaction. Suppose some person has been bitten by the bumblebee, he may develop a severe cross reaction to the honeybees too. So there are cross reactivity becomes yellow jackets and hornets between the Polystyrenae and the spinae. And however, the Apidae has got a less cross reactivity. The standardization of the venom extract becomes essential when there is a cross reactivity, and the dose of venom per sting can be about 50 to 140 microgram. Why I'm concentrating on this is this will actually help us to know how much of dose we should use when we give the venom immunotherapy. And the imported firearms contains piperidine alkaloids and aquagenic allergenic proteins. One of the differential factors in the fire venom is in all these things we have been using proteins, whereas in fire venom we will be using the whole body extract both for testing as well as for the immunotherapy. As I said, that whenever we are been bitten by the insect, we have both IgE mediated and non-IgE mediated. It is essential for us to know about the non-IgE mediated reactions too. Why? Because one is the therapeutic point of view. They are not going to respond to your routine drugs, which antihistamines or your steroids. And the other thing, it's a late phase reaction. It will take about 72 hours and the symptoms are quite severe and it is multisystemic in nature. So this is the IgE mediated local reactions with our small reactions. And if it is more than 10 millimeter, we call it as a large local reaction. And for children, we usually say if it crosses 2 joints, then we call it as a large local reaction. Why this is important from the treatment point of view? We do not treat a local reaction or large local reaction. We give more importance to the systemic reaction, and predominantly it is cutaneous in nature, like pruritus or urticaria. But we can get gastrointestinal symptoms like vomiting, diarrhea. There can be hypotensive symptoms due to anaphylaxis, lightheadedness, and tingling and numbness, neurological signs, as well as respiratory problem. The systemic reactions it can follow following a sting, and the more so that is they are getting bitten by the sting, and then the anaphylaxis reaction is within 20 minutes. That is very severe reaction, and predominantly the adults usually present with the cutaneous symptoms, and then they go on, and usually systemic reactions follows later on. And however, in 15% of them, we will just have anaphylaxis, and these are just passed on as an anaphylactic due to unknown reasons. So probably there we are missing out on the insect bites here, and children tend to usually have a benign course in adult, luckily, because they tend to explore more. So there is a possibility that they get bitten more, and luckily they have a benign course. So the risk of systemic reactions varies with the incidence of the previous reaction, whether we have a cross reactivity, whether the age matters, and what is the profession due to. Now with everybody taking on to trekking, and there is an exponential increase in the traveling to the wilds, the incidence of insect hypersensitivity can actually increase. And we need to also look at, when we do not know the reason for anaphylaxis, we also need to look at elevated plasma tryptase level. There is a system of classification. However, most of it is centered around the fact that if there is an anaphylaxis, it is a very severe reaction. Mild and moderate, we just classify them more for the clinical purpose, and also when a severe reaction is there, we need to decide on the immunotherapy. As I said, the non-IgE mediated reactions are very, very important, especially the renal. They can produce interstitial nephritis and acute renal failure, and we can have DICs also with hematological manifestation. Guillain-Barré-like syndrome in neurological, and in respiratory we can have alveolar hemorrhage. Now we would think that it is not very important, but there is a study that has come up from Kashmir that has shown that massive envenomation among the bees producing renal failure is one of it's a rising cause of concern. And African bees, which are also known as the killer bees, is very common in the Kashmir region, and death resulting in the 4-year duration when the study was happening, it was around 1,500 to 150 to 1,500 bee stings they had taken. So it is not, when it is in North India, I'm very sure it will be the same throughout the India, and we have to concentrate on this massive envenomation. So the management, coming to the therapeutics, basically, as we said, most of them do not require medical attention. We are concentrating only on those people who will have systemic reaction and who will definitely need evaluation and treatment. And we need a detailed history too. Why we need the factors that will help in the identification is, as I said, the pictures will really help. We can show the pictures and ask them what is the type of the insect which is bitten, where was the person located. Like the person is in the home and has been working with the wood, then there's a possibility it is more of a Apidae. Whereas if the person has gone to a picnic area, it is more of the Vespidae family. What kind of insects are usually found? And when there is a stinger, we know it is a honeybee. And it is very important for us to take this stinger out, because there will be venom sac attached to it and it will keep releasing the venoms here. And details into the patient's occupation is also very important, because they do not want to change it. They had an anaphylactic reaction, or they had a massive envenomation. If they want to continue their profession, then the venom immunotherapy has to be given in a very fast phase. Hobbies like trekking, bird watching, and beekeeping also should be kept in mind, and comorbid conditions are also very important. Coming to the point of management, we all know investigations is very essential. And there was a beautiful talk by Dr. Jabin sir about allergy skin test. Nowhere it is more important than the insect venom hypersensitivity, because the skin prick test is a gold standard and it has got more clinical correlation compared to serum specific IgE levels. But unfortunately, we are yet to have the venom extract in India. But of course, we can import it from Western nations. And the only modification here is we go with increasing concentration. There, sir was saying we use only one concentration. Here in SPT, we might start somewhere from about 1:100 dilutions and then keep increasing. And we do up to 1:1 till we say it is negative. Why it is very important is SPT has got a very good correlation. So we have to try to prove that it is due to that insect. And once the SPT is negative, then we again make one more attempt with the intradermal test. Here again, we go with increasing dosage. But the point why we don't rely on intradermal test initially is the systemic reactions are quite severe with intradermal. So we have to rely only on the SPTs. With the advances in the serum specific IgE and the 4th generation immunocap, which is being used, definitely serum specific IgE can be used. And even in India, where we are not having the skin prick test, right now I think serum specific IgE and component testing can help us, where we can almost see about 112 proteins in a single test. So that could be used now because SPT is not. But if you are comparing skin prick test and the immunocap, skin prick test has got more clinical correlation. And even if you're getting the serum specific IgE, before you want to start immunotherapy, you have to prove by the SPT test. And the total serum IgE is a very non-specific marker. And this I just included because people have to know that just doing a serum specific IgE will not help. Total serum IgE will not help. Baseline tryptase is also very important, because if you are going to have a very high tryptase level, especially in those people who need a targeting for this, either for the honeybee keeping or gardening, if they're going to have an increased tryptase level, we have to tell them that they have to avoid the profession. As I said, the skin testing and the timing of events testing is also very important. So because we need to wait for 4 weeks after stinging event. So the type of extract used is it is only the protein component, except for the fire ant, where we are using the whole body extract. The pitfalls they have discussed, because of the extract only we are having the problem. And one more thing is we cannot find out the non-IgE mediated reaction. So that requires a higher index of clinical suspicion. So especially when a person has underwent anaphylaxis and he is admitted in the hospital for 24 hours, it is wise that we don't discharge him for 72 hours, because to prove that there is no non-IgE mediated reactions. So the management of venom allergy basically involves not only treatment, it avoids avoidance also. And we should also use preventive measure for the frequent cleaning, sealing of cracks, and wearing protective gears, especially when we are outside, as well as we have those people who have an elevated baseline tryptase and who have had an anaphylactic reaction. It is better to carry epinephrine auto-injectors. So the treatment is acute. We don't treat the mild reaction. They don't even come to us. So only when the large local reactions, we treat with ice cold packs or oral antihistamines and try to give the steroids too if it is required. And if that is infected, we use antibiotics. All these the main treatment is with relieving the itch and local pain. So those who are having a severe systemic reaction will require ABC management along with the administration of epinephrine. Here, the main crux of the management is the epinephrine injection, which has to be given as an IM injection. Here, we are it's insisting on epinephrine because the vascular supply is so less during a shock that IM injections are more effective taken up immediately, and even before shifting the patient from the place where they are infected, the epinephrine is the main. It has to be administered at that site itself. We don't have acute auto injectors. However, in India, we can still get away with carrying the small epinephrine with a 1 cc syringe in a box that has got this black covering, because the spectacle box, such as the black covering, is very, very safe because epinephrine is very photosensitive. So that has to be told to all the patients that they'll have to use it in a box that is not exposed to sunlight, and they keep changing it every 4 months. So this is what we can use as a makeshift arrangement in India. And when do we refer to an allergist for evaluation, because it's an ALLERCON, we are going to be the people who are going to deal with it whenever an adult has got a systemic reaction. We don't deal with children less than 16 years. We don't give immunotherapy to them. Mostly it is for adults. In children, we concentrate only when they have a large local reaction. Yeah, just evaluate and keep, and then have an idea about they might develop an anaphylaxis reaction, educate them about epinephrine. But this immunotherapy is given for the adults, as well as we also need to know the comorbid treatment. The venom immunotherapy is the only specific treatment which is available, and it is only demonstrated in those people who have the clinical sign, who have serum a specific IgE level, and who have a history of anaphylaxis. So the goal is to reduce the further episodes of anaphylaxis, as well as if there is a person who want to pursue their habits or who want to pursue their occupation and who are prone to get anaphylaxis, we'll have to teach them, we have to give the immunotherapy. It is very, very extremely efficacious. This is one of the conditions in immunotherapy where we can get about 98% effectiveness, and to that we have a maintenance dose of 300 microgram. This is where the dosage of what is the dosage in the per sting comes very important, and so we titrate our dosage according to that. The indications, as I said, on severe systemic reaction, but if they have a mild reaction and there is a rise in the baseline plasma tryptase, or there is a remoteness from emergency medical help, like the beekeepers are usually in the hilly areas and they don't have access to the medical help, and this is the exact people who require immunotherapy, as we said, who have an effect on quality of life, like he's a marathon runner or who constantly go into the woods, we'll have to offer them that. So there are a lot of types of immunotherapy. If there's a person who is into an occupation which requires him to go back immediately to the occupation and he has an anaphylactic reaction, we wait for the 4 weeks, confirm what is the insect, and maybe give an ultra rush therapy. So rush and ultra rush are probably avoided in the situations where they did not go back to the profession. But if they need to go back to the profession immediately or for a major trekking, we go for ultra rush therapy. The rush and ultra rush the patient has to be hospitalized, whereas in a conventional or a cluster therapy can be given in our clinics itself, but we should have the essential equipments to manage any complication. But this the point comes is, where do we stop it? The therapy will usually complete it in 3 months or so, but the maintenance has to be completed for about 2 to 5 years. The most difficult part is maintaining the patient on this dosage. They have to take the regular injections. So we'll have to tell them. And even at the end of 5 years, we'll have to tell that they are more prone for anaphylaxis when it is stopped. So we'll have to discuss with them about the possibilities, and if they are okay and if they're going for a high risk profession, it is better that we continue the immunotherapy for a little longer times also. So the take-home messages are the anaphylaxis to insect stings occurs mostly in 3% of adults and 1% in children. Though the cutaneous systemic reactions are more common, still the hypotensive shock can come in adults, and it is very life-threatening in people who are living in distant areas or who are having a risky profession. The non-IgE mediated reaction can also create problems. We need to be aware of it. Venom skin tests are most accurate for diagnosis, and serum IgE level is just complementary. Degree of sensitivity of skin on serum test does not predict the reaction. It just tells definitely there is a IgE mediated reaction here. The patient discharged from emergency care, even on immunotherapy, should be educated about epinephrine kit and need for immediate medical care. The consultation and allergy consultation and preventive care needs to be arranged for those who have had an anaphylactic reaction, and venom immunotherapy is 98% effective. We are getting better tests. We need better tests for markers of susceptibility, because we need to tell them if they are more prone for anaphylaxis. Like tryptase is one biomarker. Like that, we might have biomarkers which predict anaphylaxis. We can advise them before it's in. Thank you for the opportunity to talk on the less known topic of insect hypersensitivity and the therapeutics.
Thank you, Dr. Narmada. This is something literally unknown to most of us, that yes, there is a possibility of death is also there, and there is a good news you have said that there is also therapy, immunotherapy, that is 98% successful. Yes, what is the worst kind of insect bite you have experienced in your practice?
Fire ant and bee stings, sir.
Bee stings.
Massive envenomation with bee stings we have I live in Vellore, there we have this hills where we have many people who keep the beekeeping as their profession. There are remote hills surrounding these places, which is about 4 hours from here. But still, their medical help is the nearest place is Vellore only, and they keep coming here. So that is bee stings is one we had. And last week, I had one adult who had fire ant anaphylaxis due to fire ant bite. He had a massive stings due to ant working in his farm. He was admitted with severe anaphylaxis here, and further on we actually asked him to wait for 72 hours. His urea and creates were on the higher side, but luckily at the end of 72 hours he was mostly asymptomatic and we discharged him. So fire ants and bee stings are the most commonest complaints. What we get on the other side is the urticarial symptoms, which children come to after this yellow jack, and though it is vespids, and though it is very not very life threatening, it is a very morbid condition. They are going on a holiday.
Mothers are more worried.
Yeah, mothers are more worried. And they're gone on a holiday and they were in a jolly mood, and suddenly, with urticarial symptoms makes them very panicky. And even a bit of numbness in the fingers of the child makes the parents very panicky, sir.
Right. Thank you, ma'am.
Thank you, sir. Thank you so much.
Thank you very much, Dr. Narmada, for a very lucid presentation on the insect allergy and its management. You have very correctly mentioned in your presentation that those who are on long-term beta blocker therapy, say for example, ischemic heart disease, they are very prone to develop the severe allergic reaction. And another issue is that in those cases, the epinephrine may not be a very good choice, and that dose may not be very effective in managing the condition.
Yes,
so
sir.
in that situation, a lot of challenges are there in the management. You have very correctly mentioned about it.
The morbidity is mostly in those with comorbid condition and less delayed access to the epinephrine in normal people, and insensitivity to epinephrine. They do not respond to epinephrine here.
Yes, that is it. And what is your opinion of adjuvant medication of steroid parenteral and the antihistaminic in those cases?
Most of the supportive, it is used, sir, in steroids and antihistamines. It's only the other medicines we have. In certain people, just like what we discussed, it depends on their genetic profile. If they are responding to steroids, we have to give them anyway. And steroids is more for preventing the late reactions which are going to come. The acute reaction with antihistamine and the late reactions with the steroids for about this one. So that can be used. But using steroid, as sir was speaking about it in the left and right for every cases, we get one small urticaria and then we see the prescription of steroids for 3 days. That should actually not be there. We should be using it in case where there is a large local reaction or in cases of a systemic reaction where the patient has been on given adrenaline and all that, only in that condition. No, it is not a drug which has to be used by office practitioners for a simple urticarial reaction.
But the unfortunate thing is steroids are available in the chemist shop and anybody can buy. And the chemist himself prescribes steroids. Oh, you have this condition, take this and you will be all right. So that needs to be stopped, and people must be educated not to take medicine from anywhere. Go to a specialist.
Two things, sir. Epinephrine has to be advocated for everybody, and that will be
Yes.
a drug which is available in the primary health center, because
Right.
the remote places are the places where they get bitten by these insects, like especially the massive envenomation happens. And anaphylaxis is also very common there. And it has to be available in all the resorts also. The resorts, the staff has to be told about this condition, because we tend to experiment on all these different the foods, and these insects are also quite common in that area. The second thing is the knowledge awareness about where to use steroids exactly. So these are the two things that will be the takeaway point in this entire lecture, if not
Right.
about immunotherapy.
Right.
Thank you very much.
Thank you.
With your permission, sir, may I ask one question or one comment, sir?
Yes,
Yeah,
sir.
sure. Please go
Sir,
ahead.
one thing is that very recently we had a meeting, and some pharmaceutical industry is trying to bring the sublingual form of epinephrine. And I think this is available in different parts of world, and they are asking the possibility of this molecule in India. But as there is very less indication, because this is one classical indication where we can tell our patient to keep it with them, the sublingual form of epinephrine. But the other cases, the indication is very less. The marketing things, they will not most probably get benefit from this area. So I don't know whether they will bring this molecule or not, but this is an important issue, and our regulators also should consider this.
Increased awareness of this condition, even one life is very important. So saving that, all these organizations which we are presently good, but when we are doing a conference like this, we might pass a resolution and pass it on to the government. Continuous representation from organization like ours can definitely make the difference, and government can give it at a subsidized rate. When they are giving the cancer drugs and all the important drugs at a subsidized rate, they can take it up and make it available free of cost also, because it's not very costly drug when that can be made available. So I think continuous awareness and talk about this anaphylactic episodes in conferences will make it easily available.
Right, ma'am.
Thank you so much.
Thank you.
Yeah, Dr. Sambhav, you requested for another topic to be included here.
Yes, sir.
Like aspirin-induced asthma.
Yes, sir.
May I know the presenter and timing for that?
Dr. Saurabh Sarkar.
Yes, sir. So actually, we have a topic on aspirin-induced asthma, and to present that, we have Dr. Saurav Sarkar, who had done his DM in clinical pharmacology from School of Tropical Medicine. So actually, this is a very important topic, I think, and we are really fortunate to have two doyen in the field of clinical pharmacology as chair to this session, Dr. Debashish Hota and Dr. S.P. Dhaneria, sir. So may I request our chairperson, sir, to allow this topic also to present here? And
Allowed. Please go ahead.
Okay, thank you, sir. So please, our technical team, please start the presentation. Yeah.
Good afternoon, respected delegates. I would like to thank organizer and especially Dr. Sambhav for providing me such a nice opportunity to present in this session, ALLERCON. Today, my presenting topic is aspirin-induced asthma approach consideration. We all know aspirin is a well-known drug. Now, the use of aspirin is mostly related to the cardiovascular event for primary prophylaxis or secondary prophylaxis or treatment, and to prevent the stroke or after stroke. So, as the aspirin is used for such patient for a long time, if the patient is suffering from the asthma and aspirin exacerbate the symptom of asthma, we should be cautious to use the aspirin or to choose another antiplatelet, or we should take such a protocol that we can use aspirin in those patients without any problem. Now, as aspirin-induced asthma is also related to the NSAIDs-induced asthma. Those NSAIDs and aspirin that inhibit the COX-1 enzyme more produce the symptom of asthma more. Now for the pain, there are different type of NSAIDs like preferentially or selective COX-2 inhibitor that have a very lower chance for asthma exacerbation than that of aspirin, that is COX-1 inhibitor, does. In another way, in situation when the NSAIDs, that is pain reliever medicine, are used, this is used for a short term. But for those cardiovascular diseases, aspirin is used for a long-term purpose. So we are focusing now in this presentation the use of aspirin in the cardiovascular disease and what we have to do when a patient is suffering from aspirin-induced asthma. So this is a case one. I will give here three different cases that will ultimately at the end of this presentation will be addressed. Mr. Saha, 52 years age, a gentleman suffering from diabetes, hypertension, and dyslipidemia. He also has asthma, and he had history of asthma exacerbation, for which he visited hospital emergency after taking diclofenac for his back pain. His resting ECG is normal. Calculated ASCVD risk factor, that is 10 years risk for CV event, is 18. Now, treating physician wants to add antiplatelet along with statin. Now, what next? So this particular patient, Mr. Saha, is suffering from diabetes, hypertension, and dyslipidemia with ASCVD is 18, and he has also asthma and a history of asthma exacerbation after taking diclofenac. Now case 2, 45 years old female patient with the history of mild asthma and allergic rhinitis with history of ASA sensitivity, that is aspirin sensitivity, that is she have aspirin induced asthma. She has now hospitalized for myocardial infarction and treated with the coronary stenting. Now during discharge, treating physician wants to put her with DAPT, that is dual antiplatelet drug. We all know after coronary stenting, for first few years, that is 2 years or maximum 3 years, DAPT is used depending on the type of stent. Now, what next? Mr. Das, 48 years aged gentleman suffering from diabetes, hypertension, and dyslipidemia, complaining of shortness of breath and retrosternal discomfort on exertion. He is non-smoker and suffering from rhinitis and recurrent episode of sneezing. On chest auscultation, no abnormality detected. His resting ECG and spirometry report are normal. His calculated ASCVD risk is now 12. Treating physician provisionally diagnosed as a stable angina and advised for TMT and add aspirin statin combination from that day. After a week, patient come with more severe symptom of rhinitis and shortness of breath along with which in chest finding. So what next? What should a physician do? Before going to that particular question or cases, now I will want to discuss about the aspirin-induced asthma in a brief. This is also called as aspirin-exacerbated respiratory disease, AERD. This is the most preferred term used nowadays. We all know, as we discussed previously, aspirin is used for prophylaxis and treatment for ischemic heart disease and stroke. Hypersensitivity to aspirin and other ADR may limit its use. The association of aspirin sensitivity, asthma, and nasal polyposis was first described in 1922 by Whittle et al. And after that, Smarter and Beer in 1968 proposed the clinical symptom that is composed of bronchial asthma, nasal polyposis, and aspirin hypersensitivity. These are the triad called as Smarter's triad. And a fourth hallmark of this particular disease has been added now, that is chronic eosinophilic rhinosinusitis. Aspirin-induced asthma are called as different names. There's aspirin triad, ASA sensitivity, ASA intolerant asthma, Whittle syndrome, but most preferred term is ASA or NSAID, exacerbated respiratory disease. Now come to epidemiology. The prevalence of this aspirin-induced asthma in general population is very less. It is even less than 3%. Prevalence increased significantly in asthmatic population. We should remember that. In general population, the prevalence is low, but in asthmatic population, the prevalence rate is high, and up to 15% for those patients suffering from the severe asthma. So, if a patient with an indication or have an indication that we should use aspirin like antiplatelet, and the patient giving the history of asthma or severe asthma, we should be very cautious before using such aspirin. The onset of symptom may appear from the teenage to 40 years of age, and the median age group is 30 years. Aspirin-induced asthma is often reported in women than that men. Most patients have a negative family history. Only 1 to 6% patients have a positive family history. The relative is suffering from the same condition. There is no ethical or ethnic predilection. Anaphylaxis or anaphylactic reaction to the aspirin are seen, though it is very rare. Now, the aspirin-induced asthma pathophysiology is not well understood, but it is proposed that it is due to the imbalance between the pro-inflammatory and anti-inflammatory mediators. Here, the pro-inflammatory is the leukotrienes, the cystine leukotrienes, and anti-inflammatory mediator is prostaglandin E2, PGE2. Now, this dysregulation of arachidic acid metabolism, we all know this pro-inflammatory as well as this anti-inflammatory part come from the metabolism of the arachidic acid. And this arachidic acid is metabolized by the two pathways. One is the LOX pathway, that is the lipo-oxygenase pathway, and is the cyclooxygenase pathway, that is COX pathway. Now, through this COX pathway, the prostaglandin E2 is synthesized. Now, if a drug like aspirin blocks this part, then whole this arachidic acid metabolism goes towards the LOX pathway, that is lipo-oxygenase pathway, and produce leukotrienes, that is overproduction of the leukotrienes. In another fact is prostaglandin E2 inhibit the LOX pathway. Now, if prostaglandin E2 synthesis is less due to COX-1 inhibition, the inhibition of this LOX pathway is reduced. So ultimately, there is an overproduction of the leukotrienes. This is the picture that depicts very well, that is aspirin and other NSAIDs that particularly inhibit the cyclooxygenase 1 reduce the production of the prostaglandin G2 and then its structural isomers like all this prostaglandin including prostaglandin E2. Prostaglandin E2 reduce the histamine release, that's the anti-inflammatory part, reduce the activation of the lipo-oxygenase pathway. So this production of the cystine leukotrienes is less. But when the COX-1 is inhibited, the things goes in opposite direction. That is, there is more production of the leukotrienes and lesser production of the prostaglandin E2. So there is an imbalance between the pro-inflammatory and inflammatory mediator with the overproduction of the pro-inflammatory part. Now, what are the clinical presentation? This syndrome is first clinically manifested as a rhinitis. Then it progressed to the hyperplastic eosinophilic rhinosinusitis that is actually produced the nasal polyp. The first manifestation of the asthma appeared at the age of the 2 years after the onset of the rhinitis. That means first rhinitis, then polyp, and after 2 years, there is appearance of the asthma. And aspirin NSAID intolerance usually appears later, that is 4 hours later, 4 years later. But we should remember that this is the usual presentation. But aspirin NSAID hypersensitivity may appear at any time of the course of the particular disease. That is, in between 0 to 4 years, it can happen. This is the pictorial depiction of this previous slide. This is first rhinitis, then rhinosinusitis along with nasal polyp, then asthma, then NSAID intolerance. Diagnosis. How we diagnose a aspirin-induced asthma. Now, history taking and clinical examination, obviously for all disease, this is the first and foremost part to diagnose. Proper history taking may evaluate the patient is suffering from asthma or severe asthma, and clinical examination definitely can suggest about this asthma symptoms. Provocation test, this is the gold standard. Here, the provocation tests are used by aspirin with different route of administration, oral, bronchial. This is the most two methods are used, and another two is nasal and intravenous. Now, in oral challenge, it is the most commonly performed, and usually 30 to 150 mg aspirin is enough to evoke the positive reaction. For inhalation test, lysine acetyl salicylic acid is administered through nebulization, and test is completed in 4 hours. And it is the adverse reaction is only mild bronchospasm here that can be easily reversed by the LABA. So, inhalation test is easily performed with less time consuming, and there is a lesser adverse reaction. A positive reaction is considered when FEV1 decreased 20% or more from its baseline value, and if there is other extrabronchial symptom, that is rhinitis, sneezing, etc. Negative symptom is when this cumulative dose of lysine aspirin that is given inhalation method, there is without presence of any adverse reaction. That is, there is no decrease of the FEV1 or there is no extrabronchial manifestation. Now, this provocation test with aspirin is the gold standard, as we have discussed in earlier slide. Now, this should be performed in outpatient or inpatient department with the constant vigilance of a skilled person. And here, the patient should be in the stable condition with FEV value at least 60% of the predicted. Emergency resuscitative equipment should be readily available for any mishap, and antihistaminic short-acting beta-2 agonist and anticholinergic should be discontinued 24 hours before the challenge. But those patients on the oral corticosteroid of the dose less than 10 mg of prednisolone or topical corticosteroid, that is inhalational or nasal corticosteroid or liquid modified drug or long-acting bronchodilator should be continued. Otherwise, there may be more hyperactivity by aspirin and may produce a adverse event in serious condition. Now, what are the treatment? Elimination of the diet that contains salicylate, like different type of diets are there. There are a big chart, but I'm just giving some example. This is almond, apple, blueberry, and different oils contain salicylate. and if this patient avoid this type of foods, they will be in better condition. Patient with aspirin-induced asthma should avoid NSAID and COX-1 inhibitor drugs. Inhalational, intranasal, and oral corticosteroid are one of the mainstay of therapy, and the leukotriene modifier like montelukast, that is leukotriene receptor antagonist, or 5-lipoxygen inhibitor like Gilutone are very good drug for treating this particular patient. Nasal decongestant and antihistaminic can be used for rhinosinusitis. Nasal polypectomy can be done or may be needed in repeated part when there is a recurrent nasal polyp. And the new biologics, that is dupilumab, omalizumab, and mepolizumab can be used nowadays. Now, what is aspirin desensitization? We know the desensitization is defined as the induction of temporary clinical unresponsiveness to drug antigen, or the elimination of pharmacological and immunological reaction by slowly increasing exposure to the drug. So drug is given slowly with incremental dose in successive short duration of the time that eliminate the pharmacological and immunological reaction and produce temporary clinical unresponsiveness in terms of adverse drug reaction by the drug. The mechanism of aspirin desensitization is not fully understood, but the proposed mechanism that is given, first one, the decreased leukotrienes production, then downregulation of the leukotrienes receptor, decreased histamine and tryptase release from the mast cell. Now, desensitization should be considered if patient is undergoing repeated nasal polyp and surgery, and there is a indication, specific indication for aspirin or NSAID use, like coronary artery disease, arthritis, or thromboembolism, or those patients on aspirin and asthma is required with the high dose of systemic corticosteroid. That is, corticosteroid is needed in those patients who are getting aspirin. So, to avoid this use of long-term systemic corticosteroid and their successive adverse drug reaction due to that, aspirin can be used after desensitization. Aspirin desensitization should be performed in a facility with advanced cardiac care, ventilatory support, and constant observation by qualified person. I just want to mention one thing. I have told in earlier slide about the aspirin provocation, and here it is aspirin desensitization. Desensitization is a therapeutic option, while provocation is a diagnostic tool. That is gold standard part. But we should remember that the provocation test should only be performed if we plan for desensitization. Otherwise, for diagnosis, provocation test better not to perform. Now, the first reaction that is happening by a drug in any dose is most severe and it is unpredictable. So should be managed accordingly, and the qualified person, this doctor, should be vigilant enough. Pre-treatment with the leukotriene modifier, and if it is started 1 week prior, it enhances the safety when we are doing aspirin challenge or desensitization. The desensitized state can be maintained with a little dose of 81 mg aspirin for the cardiovascular prophylaxis. But the different survey shows if the use of the aspirin dose is less than 325 mg twice daily, there may be chance of return of the symptoms. That is, aspirin-induced asthma can return if the aspirin dose is used less than 325 twice daily. This particular part is seen in different surveys. A brief interruption can possible that should be less than 48 hours. But if this pause is more than 48 hours and that is patient is not taking aspirin for consecutive 2 days, more than 2 days, then it is better to repeat that desensitization protocol once again. Otherwise, the chance of aspirin-induced asthma is there. The aspirin desensitization treatment have a responding rate of 87%. So 87% response is quite good enough. Now, the candidate that is good for aspirin desensitization and when the desensitization is contraindicated. We have discussed about this desensitization candidate, and contraindication are pregnancy, unstable angina, unstable asthma, gastrointestinal ulcer, and there is a bleeding disorder. Now, this protocol, this aspirin desensitization protocol, is given by the aspirin desensitization joint task force. They given this protocol at it need consecutive 2 days for desensitization. They use a low dose 20 milligram and then it increase up to 325 milligram in day 2. And it is given at 0 hour, then after 1.5 to 3 hours, and then after 3 to 6 hours for day 1 and day 2. The day 1 is completed after 28 mg dose, and day 2 is begin with this 28 mg dose. Now, vital signs should be measured, and if there is a FEV1 decrease more than 20%, we should start nebulization with LABA. And if the systolic BP become falling, that is less than 90 milligram of Hg, then epinephrine should be given in the standard dose. Now, if the patient have only rhinorrhea and nasal congestion, we can use only the antihistamine, that is diphenhydramine, 50 mg IV, and if there is a decrease in the systolic BP less than 90, then we should start epinephrine. And this protocol, this is given by the multi-center adapted registry, that is aspirin desensitization in patient with coronary artery disease. This is the most well evaluated protocol for patient undergoing coronary artery angiography or PTCA or CABG. Here, the dose is started from the 1 mg and increase up to 100 mg. And this test is completed in only 330 minutes, that is in 5.5 hours only. This type of protocol usually done, those patient is undergoing cardiac catheterization or just after urgent coronary angiography or procedure. After desensitization, they are instructed to continue 75 mg daily without any miss. So in this protocol time duration is short, only 5.5 hours with a less dose, and even it can be done for those patients is waiting for the cardiac catheterization or even after catheterization, cardiac catheterization. So how should we approach for aspirin sensitivity patient if those patient is suffering from the cardiovascular disease? So first, history should be taken. If there is a indication for aspirin due to cardiovascular cause, history should be taken for asthma. Then examination should be performed accordingly. And appropriate investigation like spirometry ECG should be done. And if the diagnosis is not confirmed that patient have cardiovascular disease or cerebrovascular disease, and we should put him aspirin or dual antiplatelet drug, then we should choose appropriate drug here. When this indication is a single antiplatelet, we can choose here clopidogrel or prasugrel or ticagrelor. But if there is need of dual antiplatelet, we should use this desensitization protocol, and we can use aspirin here. Now, deprescribing. If the patient is receiving aspirin and produce aspirin induce asthma, we should deprescribe it. That is, we should stop the aspirin and reconcile. That is, we should add the clopidogrel in place of the aspirin for his prophylaxis. Now, desensitization protocol, I have told you earlier, by this desensitization protocol, we can use aspirin in this cardiovascular or cerebrovascular indication. We should reevaluate the patient for any type of asthma attack when after desensitization patient is on aspirin. If we done all these steps, it will give the optimum outcome, that is benefit from the aspirin without any aspirin-induced ATR, mostly the asthma. This is same we have discussed in earlier. I am just want to highlight this particular slide. If there is a positive challenge test, that means there is a decrease in FEV1 more than 20 or 20% of its baseline value, then we should treat the symptom and we should assess the need of aspirin. Now, is it for primary or secondary prevention? If for primary prevention, we should use clopidogrel-like drug. But if it is for secondary prevention, that is dual antiplatelet is needed, or patient is undergoing stent depletion, that is post-PTCA patient or CABG patient, and recurrent event with the single antiplatelet, that is compelling indication for the dual antiplatelet use. We should treat the symptoms that is happening during desensitization promptly and resume the protocol again. Once desensitized properly, we can add aspirin. And if the challenge is negative, then there is nothing to worry about. We can use aspirin from the beginning. So in this case one, this patient is suffering from diabetes, hypertension, and dyslipidemia. He also has asthma and asthma exacerbation when he took diclofenac. So in spite of having asthma, when he used diclofenac, there is exacerbation. And this patient is just the physician want to put him with the antiplatelet. So in these cases, we can use here clopidogrel or ticagrelor-like drug, because here the intention is primary prevention that can be given with a single antiplatelet drug. Here DAPT, that is indication is dual antiplatelet, so we should undergo here desensitization protocol. That is the short-term protocol, that is 5.5 hours only. That is for from the adapted trial, and aspirin can be added with this clopidogrel here. And this case 3, after starting of the aspirin, patient came with the more severe symptom. Actually, here the aspirin produce asthma. Now, in this patient, we should deprescribe the aspirin and reconcile the patient, and we should change the aspirin and start the clopidogrel. So his aspirin-induced asthma will be goes off, and the patient will be on the single antiplatelet drug till the patient is undergoing TMT. And now epilogue. Asthma and chronic rhinosinusitis with nasal polyposis. These are the triad for aspirin-induced asthma. And these patients experience a acute upper and lower respiratory symptom from the beginning of the rhinorrhea to asthma after ingestion of the NSAID. This is due to the imbalance between the pro-inflammatory and anti-inflammatory mediators. Clinical examination and aspirin challenge tests can definitely diagnose this aspirin-induced asthma patient. Treatment with liquid-tense receptor antagonists, corticosteroid, and biological agents are the now different cornerstone of therapy. Aspirin desensitization followed by daily aspirin therapy may be beneficial in carefully selected patients. and it is as much as 87% patient is benefited from the desensitization protocol. So thank you for your kind attention.
Thank you so much, Dr. Sharkar, for your excellent presentation. Now, I would love to welcome our chairpersons, Dr. Dhaneria and Dr. Hota, for their valuable comments.
Good afternoon, respected delegates.
Yeah. This is a very lesser known topic, although aspirin is one of the oldest drugs, modern drugs in our armamentarium. And it has been used in almost all patients having cardiovascular or cerebrovascular primary prevention or secondary prevention condition. So we have a need to understand that aspirin is not entirely safe. Long back when aspirin was used for analgesic purpose, people were more concerned about the GI ulcer and bleed. Now, that time allergy was considered as a minor side effect, but now we are using a low dose aspirin, mostly it is 75 to 325, less than that. So the other side effects like this, we are into allergy topic. So aspirin induced asthma is a very well-known entity. And when the patient requires desensitization, this is very important to know, and you have presented very nicely. And this must be passed on. I think it should be taught in undergraduates also or postgraduate, because this is very important to learn. And when to start aspirin, when to stop aspirin, and when to avoid aspirin. So these things must be learned in details. And you have given 3 beautiful examples, and when to start monotherapy, when to start dual therapy, if there is an allergy, how to mitigate that. So this is very nice presentation. Only thing I can suggest that you should be little faster. You are little slow to my view, because we are very, short of time, and in a very competitive scenario, your timing must be very, very, adjustable.
Sorry, sir.
Right. So that's okay. So there's nothing to sorry. You are just, into the topic. And Dr. Dhaneria, sir.
Thank you, Dr. Sarkar, for a very nice presentation. Because when we talk of the dual antiplatelet therapy, then there will be a very significance of the aspirin desensitization protocol. So you have nicely covered, as Hota sir has mentioned, that it is a very new thing, desensitization protocol. It is really very important, and you have nicely elaborated. Thank you very much for presentation. Thank you.
Dr.
Over to
Sarkar.
organizers.
Thank you, sir. It's a great pleasure to have you in my presenting part as a chairperson. Thank you, sir.
Thank you all.
Thank you. Thanks.
Yeah. Dear organizers, should we call it off right now?
Thank you so much, sirs. Yes, for now, there is this session, there is a break. Everyone, all the delegates are requested to join at our other hall, Hall A. But for now, this session continues. Thank you.
Thank you very much.
Thank you so much, sir. Thank you so much, sir, for being
Thank you. Thank you.
Thank you, sir. Thank you, sir.
Thank you. Thank you very much.
Have a good day. Bye.
All the attendees are requested to enter Hall A or the Sachin Chaudhary Hall. Thank you.
Hello, can anybody hear me? Hello? Hello? Hello?
স্যার ভালো আছেন?
হ্যাঁ, আমি তো কাকে দেখছি আমি জানি না, তো কাউকে
আমি
দেখছি না
কৌশিক বলছি স্যার।
কৌশিক,
হ্যাঁ স্যার।
তো আমি কি ঠিক জায়গায় এসেছি?
হ্যাঁ স্যার,
আমি কি ঠিক জায়গায় এসেছি?
একদম ঠিক জায়গায় এসেছেন স্যার।
আমার প্রোগ্রামটা কটা থেকে?
স্যার আর আপনার তো 4:20 থেকে।
হ্যাঁ, সেটা আমি জেনে নিচ্ছি, 4:20।
হ্যাঁ স্যার।
ক মিনিটের আছে ওটা, কত মিনিট?
স্যার এটা হচ্ছে মোস্ট প্রবাবলি 20 মিনিট বোধ হয়।
তো আমি তাহলে 4:20, এখন তোমার ঘড়িতে কটা বাজে?
স্যার এখন 4টে বাজতে 5 মিনিট বাকি,
মানে 3:55। ঠিক আছে, ওকে,
ঠিক স্যার।
এখন আমি এখানেই রইলাম।
ঠিক আছে স্যার, ওকে স্যার। স্যার একদম পরিষ্কার দেখা যাচ্ছে।
Good afternoon, sir. Dr. Ghoshal, good afternoon.
Am I audible now?
Yes, sir. Yes, sir. Good evening, sir.
Good evening. So,
Sir, are we on time or are we late, sir?
I think I am before time.
Okay, okay.
They have given my time at 4:20. The
Okay.
number may not be sounding very good, 4:20, but
That's okay, sir. Okay. Because my talk was at 4 o'clock. I don't know. I don't know if everything is delayed.
Great to talk after. What's your topic, sir?
Sir, on air pollution and asthma.
You are the right person to talk about it. Very good. So now I am going incognito, and then
Yes,
I'll surface in time. Okay.
Yes, sir. Okay, sir. Okay.
But I am here.
Yes, sir. Yes, sir.
Sir, our keynote address is ongoing in the hall A. So after it will finish, we will start hall B, in the hall B, sir.
Are we late with the timings? Hello? Are we late with the timings?
স্যার গুড ইভিনিং স্যার স্যার আমাদের এটা শুরু হবে স্যার কিছুক্ষণের মধ্যে আমাদের ওই হল এ তে চলছে ওটা শেষ হয়ে এসেছে স্যার এক্ষুনি আমাদের এখানে তো টাইম রয়েছে হল গুড ইভিনিং স্যার সো উই উইল স্টার্ট হিয়ার from the scheduled time itself but as our other hall A program in hall A the keynote address is ongoing so we are waiting to maybe for 10 minutes then we will move to hall B also, sir.
May I know the schedule, if you don't mind? First speaker is Dr. Salvi and then me?
No, first speaker is you, sir.
Me?
Yes, sir. If the session will be started from 4:20. The first.
And I am the first speaker.
You are the first speaker, sir.
Okay, because the timing that I had got was my talk was at 4 o'clock. So has everything changed in this?
Sir, actually in the schedule, I don't know, there may be some mistake in this means in the mail maybe because in the schedule, sir, it will be started from 4:20 and the first talk is on by Dr. A.G. Ghoshal, sir.
And when is my talk?
It will be the fourth talk, sir.
Oh, okay.
Fourth talk.
Okay, I'll be in time. I'm here and I'll be in time. Okay, 4:20. Okay, I'll be reappearing at 4:15. Fine.
Yes, sir. Yes, sir. Yes, sir.
Thank you. Thank you, Dr. Salvi.
Yes, sir. Yes, sir. Okay. Hello.
Yes, sir.
I had another meeting at 4:30. My talk was supposed to be at 4 o'clock, 4 to 4:15. So maybe then I'll join in after the meeting. My meeting will get over at 5 o'clock.
Yes, sir. No problem, sir.
5:15 I'll join.
Okay, sir. Okay, sir.
But I wish I was told about this because
I don't know, sir. I'm very sorry, sir, because maybe there are some mistakes. I don't printing mistake or like that. But the session will be started from 4:20 as per our schedule, sir. Maybe some miscommunication, sir. Very sorry, sir.
শৈবাল দা
হ্যাঁ অঙ্গিরা এমনি অন টাইমেই আছে, এটা 4:20-তেই শুরু হবে এটা, ঠিক আছে? ঠিক আছে, ওকে চলো।
শৈবাল দা হ্যালো,
বলো।
বলছি কতক্ষণ টাইম? একটা টপিক তো টাইম লেখা নেই, 4:20 লেখা আছে।
4:20 থেকে তো এটা এক একটা টকেই হচ্ছে 15 মিনিটের টক।
15 মিনিট 20 মিনিট?
হ্যাঁ 15 to 20 minutes
15 মিনিটে ইয়ে হয়ে যাবে আর কি, গড়বড় হয়ে যাবে।
ঠিক আছে, তুমি 20 মিনিটে করে দিও। ঠিক আছে।
ওটা ইনফ্লামেটরি মানে প্রচুর কথা বলা। আমি অনেকটা
ঠিক 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 আছে, আমি তাহলে 4:20-তে জয়েন করি অঙ্গিরা।
হ্যাঁ ঠিক আছে, তাহলে আমিও তাই করছি।
ঠিক আছে, ওকে, হ্যাঁ হ্যাঁ হ্যাঁ।
মোবাইলটা তো বলেছে রাখো বাজলে।
So good evening, everyone. So we are welcoming Dr. Shoibal Moitro to chair the next session, that is on lungs and allergy. So may I request Dr. Shoibal Moitro to chair the session?
Yes, good evening, everyone. So I welcome you all in our ongoing 10th National Conference on Allergy 2021. So this is a very interesting session we'll be having with the eminent speakers who will be talking about various topics. First, I would request Professor A.G. Ghoshal. Professor A.G. Ghoshal, as we all know, he is a very eminent pulmonologist and a clinician known all over the country. And currently, he is the director of National Allergy, Asthma and Bronchitis Institute. And Professor Ghoshal has a vast experience of treating patients of the respiratory diseases and also the allergic diseases. So I would now request Professor Ghoshal to start his deliberation to enlighten the delegates who are attending this conference. So over to you, Professor. Thank you.
So, am I audible?
Yes, you are audible.
Okay, and visible as well?
As well visible.
And my slide is also being visible?
Yeah, slide is visible too.
Okay, thanks, because I'm not very good at this technology, but still, good afternoon, everybody. And my topic, as has been conveyed to me today's afternoon, is anti-inflammatory therapy in obstructive airway diseases. I see Susmita there. I probably saw Angira, and I don't know whether she has vanished. And
good evening.
Very good evening, everybody.
And good evening.
So whenever we are talking about this anti-inflammatory therapy in obstructive airway disease, it's a very vast spectrum, the obstructive airway diseases. We take the two most prominent members, asthma, COPD, but also cystic fibrosis, bronchiectasis, and of course, post-tubercular lung disease, TOPD, or tubercular-associated obstructive lung disease. So it's a vast spectrum actually. So we have to take some representative from them to discuss the nature of inflammation so that then we can proceed to anti-inflammatory therapy in obstructive airway diseases. Now, this dilemma was there since the beginning. What to treat? What do we treat in obstructive airway diseases? The cause or the effect? And intuition is we always treat the effect first. If there is fever, give paracetamol. If there is obstruction, give bronchodilator. So at the initial stages of asthma, we were there giving bronchodilator, treating the effect. Then we understood it is no use treating the effect. It is something like the water leaking from a reservoir. So we have to treat the primary cause, the inflammation, and it got established that treatment of asthma is anti-inflammatory, and the best anti-inflammatory in the history of civilization is corticosteroids, and best eosinopenic drug is also corticosteroids. So we got there that asthma, bronchodilators only SOS, but the persistent treatment will be with anti-inflammatory in the name of inhaled corticosteroids. And then in a small subset, the biologics. What happened in COPD? COPD is more complex, and so we started, and probably we are still there, that treat the obstructive part, the bronchodilators. So COPD has two parts, particularly if we take this small airway disease and emphysema, treat with bronchodilators. And if we go for inflammation, we don't know exactly what is the nature of the inflammation. So anti-inflammatory therapy in COPD is still probably a distant dream. So present treatment of COPD is still primarily bronchodilator, LAMA-LABA combination with or without a sprinkle of anti-inflammatory therapy at times. Now about this general inflammatory response in airway diseases. what happens? There is a pattern there. The pathogens, toxins, pollutants, irritants, allergens, they all first come into the airway epithelial cells as the inflammatory stimuli. And there is a pattern among them. The pattern is sometimes known as pathogen-associated molecular pattern, damage-associated molecular pattern, because the toll-like receptors, the next century who are standing there, they recognize these patterns and they activate the inflammatory cells, and it's a downstream. And then ultimately, inflammation followed by resolution, followed by repair and tissue remodeling. This is the general part. What happens particularly in asthma? So amid the general inflammatory response, there are small subsets, there are dichotomies. So toll-like receptors recognize patterns of allergens, pattern recognition. Myeloid tissue process allergens and release CCL17 and CCL22. Ultimately, the eosinophils, and then the damage release SCF activate myofibroblasts, and this goes on. So ultimately, the problem is, in one way, we are here, CCL17, CCL22, and then release all the IL-4, IL-13, IL-5, so these are all known as Th2 type of responses. The question is, how does it initiate? And we have known probably in many of the cases there is initially a viral respiratory infection. Probably the genetic component is there, the seed and soil theory, the soil is there, the seed goes in time, it's probably a viral infection, but the time is very important. At an early critically important developmental stage, when the immune system remains plastic, that means that time the immune system can be trained in any way. And then communication between the cells in the airway epithelium, then cells in the underlying mesenchyme and submucosa, and then the downward cascade and excess of type 2 cytokines in the lower airway. This is the initiation of the inflammation in asthma. The question is, why does it persist? Again, the answer is not yet clear, but probably the time is important. There is a critical time window in early life when the immune system is plastic. In this window, it may be that epithelial cells are particularly susceptible to epigenetic changes, because epigenetic changes persist in dividing cells. They provide a mechanism by which environmental factors can cause stable alterations in phenotype without changes in genotype. So the initiation is there, and there is the persistent, and probably here epigenetic changes play a role because they cause stable alterations in phenotype without necessarily changes in genotype. Here, it's my very favorite. I am not seeing it here. A patient with asthma seeks medical advice in 1828, 1928 at 21-2. What happened to asthma? Our understanding of inflammation and inflammatory therapy over 100 years. So we have seen it all. In 1970s, we were doing our practically, no, then we are just medical students. There were oral bronchodilators. And then I am keeping a gap here. In 1980s, inhaled bronchodilator were there all over the world. We also got it, and we are very glad about it. That just get 2 puffs, the patient gets relief. Then what happened? 1986 to 1989, increased asthma mortality reported worldwide, all over the world, but particularly from certain countries of the Scandinavian countries. Asthma mortality comparison between New Zealand and England. This is M.R. Sears, who almost lost his registration due to this publication, because that time it was not believed. And then now the gap is filled up. This is Ikeda fiber optic bronchoscopy. You can see here. So 1966, Ikeda invented the fiber optic bronchoscope, was there before. From 1970, bronchoscopy, because it was very easy, everybody started his hand on bronchoscopy, and bronchoscopy was done in all cases of asthma, anything. And so some asthma was intermittent, some controlled, some persistent, some uncontrolled. The common factor, it came ultimately, persistence of inflammation. So at any stage of asthma, intermittent, persistent, episodic, there was persistent inflammation. So we understood that asthma is basically inflammation of the airways. And that information, the new king was eosinophil. Previously, it was mast cell. So asthma got almost a term, eosinophilic bronchitis. And the best drug for eosinophilic bronchitis in the history of civilization again was inhaled corticosteroids. So from 1992, inhaled corticosteroids got firm grip in the management of asthma, anti-inflammatory. And then fortunately, our understanding of molecular biology was also proceeding fast. We knew corticosteroid suppression of activated inflammatory genes. And looking back, now we see clinically this understanding was there. You can see even in 1951 it was there. Administration, administration of cortisone by the aerosol method in the treatment of bronchial asthma. So practically from 1950 we all knew that steroid aerosol is dramatic improvement in cases of asthma. So it was there, but again molecular biology helped us in attaining the enlightened level. But again, then after a few years, we started understanding again, all cases are not responding to inhaled corticosteroids. What to do? Should we double the dose or should we add one bronchodilator to it? So ICS versus ICS LAVA. Because again, molecular biology knew, the chemistry also, that when the corticosteroid effect, you increase the dose, there is a plateau there of the effect, but the adverse effects go up. So it is better not to double the dose, better to combine it with a long-acting bronchodilator. ICS LAVA combination again became the next king. Facet study actually tilted the favor in favor of budesonide. Even today we are following that. So 1995 onwards, it was ICS LAVA. This is my favorite picture because it stalled the discovery of further molecules for quite some time. Like everybody almost started stopping writing poetry after Rabindranath Tagore. ICS LAVA was highly effective, inexpensive, apparently safe, till after some time we again understood that 38% of severe asthma were not controlled despite salmeterol-fluticasone combination therapy. And 38% did not achieve complete asthma control despite optimized therapy. Only 7% more patients had well-controlled asthma following a trial of add-on OCS. So everybody was not responsive to inhaled or again oral corticosteroid therapy. And just see those times, what we thought as anti-inflammatory and long-term control medications. This is 1997. So we started everything, cromolyn sodium, long-acting beta-2, methyl xanthine, leukotriene pathway modifiers, and then see again. We even tried, we ourselves did try a paper, methotrexate in asthma, and also cyclosporin A. These were the anti-inflammatories we thought in 2001. Everything there, even dapsone, toluene, everything. Fortunately, molecular biology was advancing further, and we started to understand the complexity and heterogeneity of asthma. Heterogeneous is, that means asthma is not a single disease. It is made up of several subtypes, subphenotypes. Complex means the inflammatory cascade that produces the ultimate effects of asthma are very complex. So this is from Ongira. So diagnosing the different components of asthma, airflow obstruction, airway hyperresponsiveness, and airway inflammation. And how do we detect them? Airflow obstruction can be detected by spirometry. Airway hyperresponsiveness by bronchopropagation test. Airway inflammation, we got a particular name from Hargreaves, Nair, and then Ongira, that inflammatory. And then so we got to biomarkers of inflammation. So these are the biomarkers that you knew now: blood sputum eosinophil, but also neutrophil, FeNO, IgE, periostin. This is all because we thought we have to get a particular pathway of inflammation. We have to know which is represented by the biomarker. So according to the biomarker, we will decide the anti-inflammatory. It is type of designer treatment, and we'll stop the process. Unfortunately, it didn't work. It didn't work because redundancy of pathways. Many pathways control one and one controls many. So probably just stopping at one point, one hit anti-inflammatory does not achieve the desired result. Still now, we are there. So we came to this. This is very easy for the clinicians. Look for the blood eosinophils. If it is very high, then it should be eosinophilic asthma. Look for the IgE. If it is very high, it should be allergic asthma. Something in between, both low eosinophil, low IgE, probably type 2 low asthma, and both high. Again, it can be a combination of asthma, allergy, and eosinophilia. Okay. So, grossly speaking, we started thinking like this. There's a Th2 asthma, early onset, allergic, responsive to steroids, and non-Th2 asthma, late onset, obesity, smoking, poor response to steroids. But again, this is not a clear-cut watershed compartment. This is a continuum. So it is from the less to more, area obstruction, remodeling, and a response to ICS. And frequently, we are confused in the real clinical picture, which group it should be. So the endotype allergic asthma, early disease onset, symptoms related to allergen exposure, total IgE, and treatment response to glucocorticoids and the newer biologics, omalizumab. The eosinophilic asthma, late onset, more symptoms, more exacerbations, no clinically relevant allergy, but the eosinophil must be there, sputum, blood, and both, and response to glucocorticoids and the anti-IL-5s. Now, everybody is using mepolizumab. Non-eosinophilic asthma, this is a difficult area, no clinically relevant allergy, no sputum eosinophil, no blood eosinophil, low FeNO, what to do with them? So, the picture is getting complex every day, the inflammatory cascade in asthma, and we thought we'll hit particular pathways with particular anti-inflammatories. So this is known as targets of therapy, different area and different targets, whether you eosinophil, you get omalizumab, anti-IgE, and then you go for others, and then cytokines, chemokines, you go accordingly. And what looks like is this, targeted therapy means I look for a biomarker, I decide the predominant mode of inflammation, and I decide the anti-inflammatory nature. So we need better clinical and biological characterization of the patients, probably with the hope this may have an impact on the natural history of the disease. So if it is eosinophilic asthma, we'll go for anti-IL-5. Omalizumab may be tried. If there is allergic asthma, we'll go for omalizumab. Again, others may be tried, because nowadays we know probably switching of therapy may work in some patients, which means the phenotypes that we are discussing here are not as clear-cut, watertight as we thought it would be, and probably the phenotypic classification is incomplete, which will be revealed more in future. So a combination of all. These are the present biologics anti-inflammatory in our hand in asthma: anti-IgE omalizumab, anti-IL-5, mepolizumab, reslizumab, prenalizumab, that is anti-IL-5 receptor, and then other IL-13, IL-4, and the latest hope is pinned on this anti-TSLP, that tezepelumab. So basically what we know about asthma at present, the anti-inflammatory therapy, we decide particularly if it is a T2 asthma or low T2 type asthma, then you go for the biomarker, the allergic type, the eosinophilic type, and the non-allergic, non-eosinophilic type, and we decide the anti-inflammatory accordingly. But considerations before anti-inflammatory therapy, excepting steroids in asthma, very few patients are completely resistant to corticosteroid. ICS still remains the mainstay of therapy for any asthma, including difficult to asthma. Some have not come to our desired wish. One is fevipiprant. We are very elated about it. There's an oral DP2 receptor, but ultimately the present trials do not support, again, because the pathway is immensely complex with a lot of redundancy. Just checking one point, like say checkpoint inhibitor in cancer, does not work in asthma. So fevipiprant has not fulfilled our dream. We are very ecstatic now about TSLP. Again, we have to see whether tezepelumab can fulfill our wish in coming days. And then future targeted therapies, newer pathways and newer anti-inflammatory will be coming. A little about the COPD. It's a vast spectrum, will not complete on. We are taking two representative. One you have taken asthma, another is COPD, anti-inflammatory therapy in COPD. And again, this paper is there, almost same, 100 years of COPD, Alfred Fisman. And then, if we see carefully, it was the way around. Practically, histology was known of COPD, so-called chronic bronchitis, since 1950. Physiology was known since 1954. And Ori's hypothesis was in 1961. And the famed Shiva Symposium, we all read about it since our student days in 1959. And also the concept of phenotypes was there. Since you can see in 1955, the pink puffers and the blue blotters were phenotypes actually. And the Venn diagram that was done by 1989 Snyder GL. And practically this is also different phenotypes, making one single cluster known as COPD. So the concept was there. And now we know, after molecular biology added its insight to this clinical part, this was basically clinical and histological, the inflammatory response in COPD involves both innate and adaptive immunity, with neutrophilic inflammation the commonest inflammatory phenotype. So predominantly it's a neutrophilic inflammation in COPD. Because cigarette smoke is the most disastrous assault to the respiratory system in the history of mankind. So again, this is toll-like receptors there, the cigarette smoke, exposure, release of pro-inflammatory mediators, and it disrupts the barrier. So altered barrier function, it goes down below, triggering of an IL-33 dependent exaggerated pro-inflammatory cascade, and recruitment of everything, epithelial cell, macrophage, neutrophils. So practically the inflammation in COPD is much more devastating than what is in asthma. So first, the abnormal inflammatory response, tobacco smoke, air pollution, occupational exposure, and the inflammation starts within minutes of exposure. And all smokers develop lung infection, but in some smoker, it proceeds to structural abnormalities. And definitely it involves the genetic and the epigenetic factors, the altered immune regulation, impaired resolution of inflammatory and abnormal repair mechanism. So where is the pathology in COPD? Everywhere. Proximal airway, peripheral airway, lung parenchyma, pulmonary vasculature, total disaster. Why? And everything involved, cellular inflammatory resources, cytokines, chemokines, particularly the protease and antiprotease imbalance. There is a notion now that probably there is a PWD in lungs. That means they do the maintenance work. And cigarette smoking particularly destroys this PWD department. There is a concept of an alveolar maintenance program required for structural preservation of lung. Cigarette smoke causes destruction of this maintenance program. Total breakdown. And then why does it persist? We have seen in asthma, initiation then persistent. Same thing COPD. Why does it persist after the initiation? Because the inflammatory response by triggering an auto-inflammatory response with intrinsic production of pro-inflammatory mediators independent of exogenous stimuli. Once the damage is done, it is a vicious cycle going on. And so even without further stimulus, it can do the damage. And also, in addition, what happens is an autoimmune response, auto-inflammatory and autoimmune response without further stimulus, persistence. And then anti-inflammatories in COPD, the first anti-inflammatory COPD we used is inhaled corticosteroid without knowing. We didn't know why we used it. Statistics was in its infancy. There was nothing to do. Actually, we called COPD those times irreversible airway obstruction. Irreversible in clinician's mind was interpreted as untreatable. So try anything, let us try ICS, some results, followed by 4 big, so-called big projects, ISOLD, Euroscope, Copenhagen lung study, lung health study. Questionable results, whether ICS works or not. Do not have much effect, honestly. But probably there is a small area. ISOLD study showed fewer exacerbations. Somebody argued that ISOLD study itself had many asthma cases in the case of COPD. Whatever it is, TORCH was actually molded on post-hoc analysis of ISOLD data with a positive survival trend for critical and preponderant. So TORCH And Todd showed actually 2.6% absolute reduction in mortality, not statistically significant, but we held it because we couldn't do anything else. Again, question whether double bronchodilator is good enough to take that. That the reduction in mortality was entirely explained by the salmeterol component and none could be attributed to ICS. So probably bronchodilator itself is the thing and combination inhalers consistently reduce exacerbation. So now, looking back, we understand all COPD do not need ICS and all COPD do not need double bronchodilator. Maybe there is something in between. What is that? Then we understood the role of eosinophils in COPD. And elevated sputum eosinophil count associated with a greater response to both inhaled and oral corticosteroids, while blood eosinophil count can be used to predict response to corticosteroids when stable. That means some COPD are responsive to steroids. How do you know that COPD? It is the eosinophils. Came the term of precision medicine in COPD, the case of inhaled corticosteroids, blood eosinophil count as a guide for COPD treatment. And then the molecular biology explanation that basically here, again, it is not the eutrophil, it is the eosinophil, and they're producing the different IL-33, IL-5, IL-4, and others. Taken together, about a quarter of the patients have persistent eosinophilic inflammation, increased upregulation and expression of pro-inflammatory gene-driven type 2 inflammation. They produce interleukin 4, 5, 13, and eosinophilic inflammation can also occur by, as I said, redundancy of pathways. They can also occur by activation of ILC2 cells. This is eosinophilic inflammation. So what did we do? Best anti-eosinophilic in the world, steroids. We started ICS. We even given oral corticosteroids. But again, the biologics are already there. So we tried biologics as well. So targeting T2 inflammation in COPD, we tried everything. These are the most famed actually, Matrix and Metrio, use of mepolizumab in COPD, but also benralizumab has been used. And lo and behold, we did not fulfill our expectations, this T2 anti-inflammatories in COPD. Both the mepolizumab and benralizumab studies showed that the magnitude of benefit is directly related to the intensity of eosinophilic inflammation accepted, but the effect size is smaller than that seen in severe asthma. So what remains? The big chunk, the neutrophilic inflammation. Why don't we try biologics there, anti-inflammatory? Neutrophil associated COPD, activation of the inflammasome, T1 and T7 immunity is the most common phenotype in COPD. We started, so we tried again. And again, the most famed was anti-CXCR2, but we tried even infliximab, etanercept, and others. Anti-IL-8, what happened? Targeting anti-inflammatory therapy has not achieved desired result in neutrophil-associated COPD as well. And so anti-CXCR2, which we hoped much, demonstrated small improvement in lung function, particularly in those who are current smokers, but led to increased infection rates in longer-term follow-up. So neither T2 biologics, neither specific pro-inflammatory anti-cytokines did have desired effect in COPD. Taken together, corticosteroids are most effective in COPD with evidence of eosinophilic inflammation accepted. But eosinophilic associated T2 mediated immunity is observed in a minority. And in contrast to asthma response to anti-IL-5, biologics in COPD has been disappointing with smaller benefits for the same intensity of eosinophilic inflammation, question its role in COPD. And beyond T2 mediated inflammation, as I said, they have not demonstrated benefit, the pro-inflammatory cytokine anti, and in some cases, increased risk of infection as in anti-CXCR2. Where do we stand? Again, science is progressive. There are emerging anti-inflammatory therapy on COPD. Everything will be tried. We have already in our hand PDE4 inhibitors. We have already inhibitors in mediators. We are using macrolides, statins, and drugs that may have indirect anti-inflammatory action. So these are on cards. Again, the COPD part is much more complex than in asthma. Targeting neutrophilic inflammation, the inflammasome, TNF, and IL-17 have been ineffective in COPD and in some cases have increased risk of infection. This suggests that intrinsic activation of these pathways driving an autoinflammatory process is probably less important than their activation secondary to persistent airway colonization and infection. What means probably it is not the intrinsic part that is more important in asthma, but it is probably the extrinsic part that is more important in COPD. We have to control the extrinsic part, targeting bacterial dysbiosis in stable state and infection and exacerbation events will be more efficacious in targeting anti-inflammatory in COPD. Does it ring a bell somewhere? Do you think that we have seen this before? You have heard this before? This was there. The biological clustering, the orithesis, that probably both were correct, the Dutch hypothesis and the British hypothesis. British hypothesis actually focused more on the external element, the infection part. Dutch hypothesis probably tried more on the intrinsic element, the diathesis part. So if we see together, biologic clustering, my goodness, I'm not getting it. Okay. What happened? Okay, we'll get to that. Let me move. So going here. So understanding the role of airway microbiome in COPD, chronic inflammatory phenotype. So probably the airway microbiome becomes more important in thinking of anti-inflammatory therapy in COPD. The airway microbiome is differentially implicated in neutrophilic and eosinophilic COPD. The microbiome can stratify neutrophilic COPD into subgroups that justify different therapies. That means in asthma, the biologics have come to some rescue. But again, in COPD, they have been ineffective till date. Probably they will be better stratifying the inflammatory pathways and antibiotics in future. At present, the focus is on the microbiome and the nature of external infection and colonization by microbes, the airways in COPD. So taken together, anti-inflammatory therapy in obstructive airway diseases. First, we have to understand the nature of inflammation. The first thing is initiation. How do they start? Probably the theory will be coming that the inflammation starts and then the combination of both, the genetic part is there and then the epigenetic part at a particular point of development when the immune system is plastic and it changes the whole way. And so this part next becomes very important, the polarization of response, whether it will go the TH1 pathway or TH2 pathway. And probably molecules are coming. TSLP is important because it may have some function in polarization of response, either to the TH2 pathway, will go the TH2 downstream, or the TH1 pathway and will go for pro-inflammatory cytokines. And then why does it persist? Again, different theories, but probably again, asthma persistence is for different reason, different action mechanism, and COPD persistence is different action. Taken together, cigarette smoke is such a disastrous thing. It can change the whole immune response from TH2 to the TH1 and to the autoimmune segment. And so the response, it depends on relative contribution of intrinsic versus extrinsic factors. Probably intrinsic factors are more important in deciding the anti-inflammatory therapy in asthma. Probably extrinsic factors are more important. We have to think of the bacterial colonization and their nature, the nature of the microbes and the microbiome in patients with COPD. I think I have stopped. Okay, I'll stop here. Thank you all for your kind hearing.
Thank you, sir. Thank you very much, sir, for this wonderful deliberation. So may I request, because as there is a shortage of time, we cannot afford to take question now. So may I request our next speaker, Dr. Sushmita Rai Chaudhary, madam, to please present on the topic of allergic bronchopulmonary aspergillosis.
Shambho, the problem is that the link that you have sent me does not show screen share.
Let me talk with our... Hello, the technical persons, are you there? Hello?
This does not allow me to screen share.
Yeah, madam, we are trying that. I'm talking with our technical.
Kake. Hello.
হ্যাঁ
Yes.
একটু দেখো যে শেয়ার করতে পারছেন না ম্যাডাম, স্ক্রিন
না
শেয়ার করতে পারছেন।
আমাকে যেটা পাঠিয়েছে সেটাতে স্ক্রিন শেয়ারটা নেই।
ম্যাডাম সকলের একই লিংক কিন্তু স্ক্রিন শেয়ার আছে,
আমারটাই নেই, 100% নেই।
আপনি তাহলে আরেকবার সাইন আউট করে বেরিয়ে আরেকবার সাইন ইন করে নিন।
আচ্ছা, maybe you can Shambhu go ahead and let Dr. Ongira do her talk.
Okay madam, okay madam. So may I request Dr. Ongira Dasgupta madam? Madam, are you there madam?
Yes, I am.
Okay. So may I request our technical team to project please the CVs? Yeah. So we are really fortunate to have Dr. Ongira Dasgupta madam. She had done her MD in pulmonary medicine, then DNB in respiratory disease, and also she had done MRCP. So may I request madam to tell us about role of sputum inflammometry in the treatment of allergic airway disorder. So madam, please.
So here again a problem with screen sharing. Do you want to continue? Yes.
Yes, madam, we can see yours.
Let me put it on slideshow and then we get going. Okay. And good evening, everyone. And thank you all the organizers for inviting me to this symposium today. It's indeed a great honor to be speaking on sputum inflammometry in treatment of allergic airway diseases, and especially after Dr. Ghoshal. The way I have structured my talk today is I would be talking about who needs inflammometry in the beginning, sputum versus other samples, which one's better, for what reason, and etc. I will be talking about sputum inflammometry in particular as compared to other types of samples. I would cover cells and fluid phase measurements, and I'll try and give this a clinical perspective. So we just saw this figure in Dr. Ghoshal's presentation. Components of airway diseases can be imagined as consisting of 3 such components. And the central component here is airway inflammation. And from here, the term inflammometry has been coined. So what is inflammometry? It's the art or science of assessing airway inflammation in a patient who has airway disease. Now, who needs this inflammometry? 5 to 10% of asthmatics remain symptomatic despite best available therapies, and people who practice respiratory medicine would know this very well. Some patients are on long-term oral corticosteroids with its side effects, and they just would not put up with these side effects. So we have to use biologics to taper the dose of the OCS, and this is one of the situations where inflammometry comes into play. How do we understand who these people are? These people are usually the step 5 GINA guideline people, where all the other options and using very high doses of inhaled corticosteroids do not work. So these are the people whom we would like to have a phenotype or an endotype in order to decide what treatment to go ahead with. Is it a biologic, or is it steroid? Is it an antibiotic? So we'll see how we can do that. Now, airway inflammation can be measured in various ways. You could do it from blood and see what the blood eosinophils look like, whether or not they're raised or lowered. Respiratory secretions like sputum can be used, and this is what is going to be the main focus of today's talk. Bronchoalveolar lavage, yes, but again, it's very difficult to do a bronchoalveolar lavage in patients who are severe asthmatics because of the fact that they might become hypoxic if we put in a scope in their already narrowed airways. Tissue biopsy, yes, but again, you cannot do a bronchoscopy or lung resection just for the purpose of getting a tissue inflammatory cells. So we put that away. And exhaled air analysis is something which is being worked upon And in the future, we might see a lot of papers and a lot of understanding of the composition of the exhaled air. So why sputum? Why are we so worried about sputum? Look at this picture. I do not know whether people understand where this picture is from, but I'll tell you the answer. This is from Howrah Bridge, our very own city, Kolkata. And can you read that? Do not spit. So what are the advantages of sputum? It can be easily collected. The samples, the diseased organ directly. The sputum comes from the organ of disease, that's the lung. Like I said, the ease of collection. This procedure has got a high sensitivity and specificity. It has a good responsiveness, meaning that when you give steroids to a person who has symptomatic or has one of the eosinophilic phenotypes, if you treat them correctly and accurately, the responsiveness to therapy can be measured. And this sputum inflammetry has been tested in clinical trials for a long, long time now. So what is the composition of sputum, from where we can understand measuring of proteins, cells? Which one is it that we want to sample and understand the underlying inflammation nature? Cells is what we do it most of the time, but proteins, glycoproteins have also been tried, and I'll just put in a few words of proteins and glycoproteins in sputum right at the end. This is what I discussed. Cellular counts can be done by sputum quantitative assay. Fluid phase measurements can be done for proteins, glycoproteins, and some people are going ahead with doing a lipidomic study to understand if there was a difference in the lipid measures when an airway disease patient is seen as compared to a normal person. So if we look at this case scenario, so SN was a 60-year-old female who started having symptoms at 45 years of age, so an elderly female. She is an ex-smoker. These days we get a lot of female smokers. She was atopic on salmeterol, fluticasone, very high dose, and even tiotropium. If we look at the FEV1, it's an obstructive pattern. Radiology was normal. Echo showed only mild pulmonary arterial hypertension. The patient continued to be symptomatic on minimal exertion despite being on such high doses of inhaled corticosteroids, bronchodilators. When we checked for the compliance of the patient, it was good. No ongoing allergen exposure, and comorbidity is well controlled. So the next step would be to identify the nature of the inflammation, which we are calling inflammometry. So how do we do that? A blood eosinophil count of 210 cells is what the patient had, and we usually take a count of 500 cells in the absolute eosinophil count to consider that there is an eosinophilia going on in the patient. Serum IgE of 220 in this patient is not that much raised, and FeNO is 27 part, that is again not very much raised. So we are left with sputum measurements and to have quantify and to try and quantify biomarkers in order to understand the type of inflammation that is going on in the patient. So this was the man whom Dr. Ghoshal even spoke about. This man, Freddie Hargreave, is the pioneer of this method of assessing cellular counts in sputum. He, after around more than 100 methodology papers, came up with this methodology where we take a sputum of the sample of the patient whom we want to understand the inflammation nature in a Petri dish. We looked into this Petri dish with the help of an inverted microscope to try and separate out those areas of the sputum where the inflammatory cells may be clustered. We add sputolysin to that, which breaks these disulfide bonds and lets free the inflammatory cells. Filter through a nylon mesh and then divide that filtrate into two parts. One part goes for the total cell count after being mixed with trypan blue, while the other part goes up for the cellular count, which we do with the help of cytocentrifuge and get a monolayer slide in order to get a differential from 400 cells. This is how a slide of the single cellular layer slide looks like. That is a monolayer cell. So when we get the results of airway inflammation, it is found that there are 4 main types of airway inflammation. Eosinophilia in sputum is defined as more than 3% eosinophils in the sample with a normal total cell count, whereas the neutrophilic inflammation is defined as more than 65% with or without an increased total cell count. Now, if we have an increased total cell count with a neutrophilia, we are going to treat the patient, and then it is norm to retest the sample to see whether the neutrophils were actually camouflaging the eosinophilic numbers. We could also have combined airway inflammation where we use antibiotics first and then test again to see what type of inflammation is really going on. And post-granulocytic ones are those which have normal counts. And in such situations, we have to look for other reasons where the patient's airway symptoms are getting more and more uncontrolled. So what is the strategy of treating eosinophilic bronchitis? We simply increase the inhaled corticosteroids or the oral corticosteroids. And when we look at the slide, if it's 1 to 3%, we do not decrease ICS. That's very important because there is a tendency, if we are doing a guided therapy in these patients, there is a tendency to consider decreasing ICS whenever the eosinophil numbers go down in the sputum. Neutrophilic bronchitis, no need of adding ICS, simply add antibiotics if the total cell count is high and recheck after 2 to 3 weeks. So every time you get a neutrophilic bronchitis and every time you have a exacerbation, we have to do a count and check and recheck to see what type of inflammation is going on, because there is a lot of longitudinal difference in the airway inflammation. So if you have a neutrophilic inflammatory bronchitis, we do not increase ICS, just add antibiotics, recheck after 2 to 3 weeks. If there is no inflammation, we just simply add a bronchodilator and do not decrease the ICS without getting a recheck. So when we did counts in our patient, there were 100 patients whom we did this inflammatory endotyping. When we did it by blood eosinophil count, considering an acute and absolute eosinophil count of more than 300 to be the number that we were looking for, we found that the eosinophilic types of airway diseases were as great as 64%, whereas the non-eosinophilic ones were just 36. But when we did it in sputum, you can see that the number of eosinophils samples have come down to 26% from 64, and the neutrophilic ones have gone up. Now, how do we explain that in biology? It is because we think that the eosinophils, once in the sputum, it does not mean that they are causing disease. They can be present in anywhere in the human body, but they need to be activated before they can actually degranulate and cause different types of damage to the organ where it is present. We have now understood that there is a disconnect between sputum and blood eosinophils. So blood is not a surrogate of sputum and sputum is not a surrogate of blood. So when we look at this figure, we find that you could have very low eosinophil counts in the sputum, at the same time having a lot of blood eosinophils and vice versa. So going back to our patient, the investigations showed that the spirometry results, I think we have discussed this earlier, but let me go through it once more. The pre-bronchodilated FEV1 was 1.6, whereas the post was 1.9. So 300 ml of improvement. Percentage-wise also, it's reversible. The HRCT scan is normal. The IgE level in the blood is 220. Absolute eosinophil count was 210. And we can simply understand that going through these values and numbers, we cannot understand what the phenotype of the patient is. So going from here, we should do a sputum quantitative assay in this patient, and the results showed that the total cell count of 9 million cells with 60% neutrophils and 10% eosinophils and an exhaled NO of 45. So now we know that this patient has a 10% eosinophils and belongs to the eosinophilic phenotype. But again, just a single value of 10% may not be sufficient to call this patient an eosinophilic asthmatic, for the simple reason that a single count is not what we can accept, like I described earlier, we need at least 2 or a recurrent analysis of the eosinophil count in sputum just to catch the very, very accurate analysis of the eosinophilic severe asthma. And all this is because once the patient does not respond to steroids or responds to steroid and has a lot of side effects, we can then prescribe biologics for this patient. Dr. Ghoshal has already shown us good figures from which we understand that anti-IL-5 mepolizumab, which is available in India now and is being used for quite some time, anti-IL-5 receptor antagonist, that's benralizumab, again for the eosinophilic phenotype. Anti-IL-13, lebrikizumab is not available but in India, but it's being used in the other European countries. Anti-IL-4 or dupilumab again is in marketing. Anti-IgE is omalizumab that we've been using for a long, long time. And now all the companies are fighting amongst themselves to establish their own brand. So is it omalizumab? Is it mepolizumab? Is it benralizumab? The answer lies here. So we need to get hold of the clinical picture of the patient and match the biomarker, which is going to tell us what type of asthma it is. Is it a neutrophilic asthma? It could be COPD as well. Is it neutrophilic? Is it allergy driven? Is it asthma? What is it? So we can see here that if the patient has severe asthma with a lot of exacerbations, sputum eosinophils are useful to phenotype and prescribe anti-IL-5 therapies, which would be targeting the eosinophils in the sputum as well as the blood. If you have atopy, rhinosinusitis, and aspirin-sensitive patient who also has an hyper-responsive response, sputum eosinophils again are very good biomarkers to predict a good outcome with anti-LRTA, that is leukotriene receptor antagonists. If the sputum is normal, like I said, the postgranulocytic patients, but they have a history of severe asthma and airway hyperresponsiveness, then possibly anti-TNF-alpha might work, but all the trials as of now have failed to get a good response with an anti-TNF-alpha in the patients. Bronchial thermoplasty has been proved to be successful to a larger extent because it has to be used only after we have excluded an eosinophilic inflammation or a neutrophilic inflammation. If the sputum is normal and only the twitchiness is persisting, then we can go ahead and do a bronchial thermoplasty, which is quite expensive. And if there are sputum neutrophils which are high, we could use an anti-CXCR2 antagonist, but again, this is not marketed these days because of its non-response clinically. Indeed, mepolizumab did show a reduction in exacerbation rates. Now, what are the disadvantages of sputum quantitative assay? So it has been grossly criticized for several decades. People have only started to understand their needs once the GINA has included the test in their stepwise treatment of asthma. The disadvantages are that you require training, a lot of training to do the test, need wet lab facilities, but again, the availability is restricted. People, for unknown reasons, have not yet established that many labs who would do a sputum quantitative assay. And sometimes there are no sputum despite induction, which is very, very true. So sputum consisted of cells, if you remember the slide there, and then the fluid phase has proteins, glycoproteins, lipids, etc. So once we have done these sputum cellular counts, sometimes we can find that it is not possible to do a cellular counts in a particular patient because every time you do it, you find degenerated cells, and that's quite possible. So if you get degenerated cells in a sample, we wouldn't know how to go ahead and treat the patient. Pre-processing is less laborious, but the disadvantage is you have to have an instrument which is very, very expensive, a mass spectrometer through which you would be able to understand the fluid phase proteins. So I'll end by sharing our experience in trying to profile the proteins between patients of airway diseases who had frequent exacerbations versus those who did not have exacerbations. So we subjected to mass spec sputum from patients of various airway diseases, that is patients with chronic bronchitis, COPD, and asthma. And once that was done, we selected only those proteins which were raised or decreased by more than 2 folds among these 2 groups of phenotypes, exacerbators and non-exacerbators. So they could be from any of the airway disease compartments, but they were to have an early recurrent exacerbators, which we defined as more than 2 exacerbations in the past 1 month, in the past 3 months, versus non-exacerbators who did not exacerbate in the 3 months. So we could identify 21 proteins. You can see the list, and I'm sure we do not understand what's going on. So when we clustered, a functional classification was done and clustered the proteins, we found that the important proteins were in the inflammatory related proteins, calcium related proteins, mucin related proteins, cytoskeleton related proteins, and oxidative stress related proteins. From these, if we could do an inflammometry with the help of the inflammation related proteins, that would be an excellent step to go ahead and do sputum inflammometry. So if you, and this is just part of the results that I will be showing you, you could have one of these proteins. It's very clear from the diagram that if you were an exacerbator, that is an E which is following the name of the protein, the non-exacerbator went into the other side. So a positive response from some of the proteins and a negative for some. But this was what we were looking for, the response of the mucin-related proteins, because mucin is one of those proteins which we have a targeted therapy already available over the counter. So the mucins were MUC5B, MUC5AC, and a BPI fold-containing family protein. So all these were, again, it's very visible that the non-exacerbators have a decreased level, whereas the exacerbators have an increased level. So this is what we should be looking ahead in for the future therapy of airway diseases. Summing up, sputum inflammometry is the art of measuring airway inflammation from sputum. Patients with severe uncontrolled asthma or steroid-dependent asthma need inflammometry. Biologics need accurate inflammometry to identify responders to all these various biologics, which are soon going to flood the market of airway disease patients. Sputum quantitative assay has the ability to phenoendotype even in the clinical practice, and fluid phase measurements is what the future of sputum inflammometry and treatment of airway diseases is looking at. Thank you very much.
Yes, thank you, Ongira. So it was really an excellent talk, and we all have really learned from your talk.
Thank you.
So now we move on to our next speaker. Our next speaker is who doesn't need any introduction, but still for the brevity of the conference, I am welcoming Dr. Sushmita Roy Choudhury. She is the Director of Pulmonology of Fortis Hospital, Kolkata, and one of the eminent, dedicated, and finest pulmonologists of our country. So I request Dr. Sushmita Roy Choudhury to deliver her talk on the approach to allergic bronchopulmonary aspergillosis. Thank you, Dr. Roy Choudhury.
Thank you, Shoibal. For some reason, there is a problem and I just cannot show my slides. If Kaushik can please project my slide from your technical team, that will be very helpful. Somehow it's just not happening from my end.
Okay, let's see.
Sorry about.
Kaushik, are you there? Can you just help us out in this?
Yeah, yes, that's great.
Yes.
Okay, so without further ado, again, sorry about the delay. Let me start. I've been asked to talk about approach to ABPA, and I'll just quickly go through the basics. We all know that it's an immunological pulmonary disease, which is related to hypersensitivity to Aspergillus fumigatus and is characterized by asthma, recurrent pulmonary infiltrates, and bronchiectasis. Next slide. Next slide. Yeah. So it is Aspergillus fumigatus, we know, is the most common ubiquitous mold, and the conidia of which are only 2 to 3 microns and hence can reach distal airways and alveoli and deposit themselves there. It doesn't affect everyone, but what has been seen is that people who have asthma, cystic fibrosis, or are allergic to Aspergillus, they are affected. And how does that happen? Because of inflammation, there is thick mucus, which then again aids the persistence of spores. And it has been shown that people who are susceptible to who have HLA-DR2 and 5 actually contribute to susceptibility to development of hypersensitivity to it. And HLA-DQ2 has been shown to contribute to resistance to developing hypersensitivity to these molds. Combination of both may actually determine outcome of ABPA in asthma, depending on susceptible versus resistant HLAs in the patient's body. And this is found to be quite disbalanced in those who have asthma, cystic fibrosis, or are allergic to the mold. Next, please. So epidemiologically, those with severe asthma, usually in their 3rd decade, may present with these symptoms. And estimated prevalence actually, in spite of 25% of asthmatics and 50% of cystic fibrotics showing skin sensitivity to Aspergillus, the estimated prevalence is about 13% in asthma and 9% in cystic fibrosis, although this might be grossly underestimated. Worldwide, it is estimated that about 4 million people are affected, and the highest incidence is usually seen in winters, which people think is because of fallen leaves and they rot and could lead to increased amount of mold in the environment. Next, please. So the pathophysiology is quite incompletely understood, but the spores likely behave as allergens in atopic individuals, resulting in the formation of IgE and IgG antibody. And this is again a Th2 cell mediated role, which is manifested as IgE production, eosinophilia, mast cell degranulation, and ultimately bronchiectasis. Next, please. Next slide. If you were to see the histopathology, it is characterized by chronic bronchial inflammation, eosinophilia, airway remodeling, and finally bronchiectasis. And these bronchi are shown to be impacted with mucus plug, which can contain the fungal hyphae, fibrin, Charcot-laden crystals, and Kirschmann spirals, as you would see in chronic bronchitis, but usually you would find fungal hyphae in this. Next. And this is what it would look, Aspergillus fumigatus would look under the microscope with the conidia, as you can see, beautifully displayed. Next. So clinical features wise, it is no different to that of uncontrolled asthma, but with increased frequency and severity, is in spite of optimum asthma medications, there may be a history of cystic fibrosis, and there are non-specific complaints apart from cough, dyspnea, pleuritic chest pain, as anorexia, fatigue, etc. And ABPA may occur with allergic fungal sinusitis, where there may be symptoms of chronic sinusitis and purulent sinus discharge, in addition to uncontrolled asthmatic symptoms. Next. Next slide. Evaluation wise, Aspergillus skin test is the most commonly used one for diagnosing sensitization, which reveals immediate cutaneous hypersensitivity and a positive type 1 hypersensitivity rep2 Aspergillus fumigatus in the presence of Aspergillus fumigatus specific IgE antibodies. Blood abnormality wise, usually the IgE levels are raised to the tune of over 1000, but there may be, in naive patients, there could even be more than 500 with all the symptoms presenting, which I'll be talking to you in a little bit. Elevated specific IgE to Aspergillus fumigatus, serum precipitants or raised specific IgG to Aspergillus fumigatus may be present, and peripheral blood eosinophilia. Next. Radiology wise, chest X-ray has only 50% sensitivity, but the main thing is that there are parenchymal infiltrates which are fleeting in nature over a period of time. In diagnosing ABPA, HRCT is the investigation of choice because they usually may present with cystic bronchiectasis, with central bronchiectasis, which are undetectable on chest X-ray. And I will discuss the radiological staging in a bit. The shadows that may present radiologically is finger and glove opacity, which is suggestive of mucoid impaction, tramline shadows due to parallel linear shadows from the hilum in bronchial distribution, in longitudinal ways due to inflamed edematous bronchi with the secretions inside it. Toothpaste shadows again represent mucoid impaction of the bronchi, and ring shadows which can reflect dilated bronchi with inflamed bronchial walls. Next. So if you look at the chest x-rays that are being shown over a period of time, there are fleeting opacities and can also sometimes present with subsegmental or segmental or a lobar collapse because of mucus impaction. Next slide. So if you look at the CT, there's finger and gloves very nicely depicted, and central bronchiectasis and tramline shadows, as you can see on the CT here. Next slide. So radiologic staging of allergic ABPA is very important. It can be ABPA-S, which is ABPA serology, where the serology is positive, but there is no central bronchiectasis seen. The severity of these are mild to moderate airflow obstruction, and precipitants are positive in more than 90% of these patients. ABPA-CB is those where there's serology plus central bronchiectasis. Here, patients will present with high IgE, moderate to severe airflow obstruction, and aspergillus precipitants will be present in more than 1/3 of the patients. ABPA-CB ORF are the ones that have central bronchiectasis plus other things such as fibrosis, bully, pneumothorax, all the complications of persistent ABPA. And here the patients usually have severe airflow obstruction, and IgG precipitants are positive in 100% of these patients with very high eosinophil counts and total IgE levels. Next. Next slide. So ancillary testing that may be important is bronchoscopy, which may show mucoid impaction in almost all the lobes or in most segments, and bronchial brushings will reveal what we discussed in histopathology. Sputum cultures is not diagnostic, but if it is present, then it helps in drug susceptibility testing only, but is not important for diagnosis of ABPA. Next, please. Criteria for diagnosis was first proposed by Rosenberg in 1977, which comprised of seven components of asthma, peripheral blood eosinophilia, positive immediate cutaneous hypersensitivity to aspergillus, precipitating antibody presence, total serum IgE levels being high, transient or fixed pulmonary opacities, and central bronchiectasis, and minor components, which is isolation of fumigatus in sputum, history of expectoration of brownish plug or flex, and arthus type reactivity to aspergillus antigen. But it was found that in physician diagnosed cases, only 39% of patients actually fulfilled the criteria. Next slide, please. And over a period of time, the criteria have changed from Rosenberg to Greenberger's ABPA-CB, ABPS, as we discussed the radiologic staging. And then finally in 2010, Agarwal et al. Said there should be major and minor criteria. This is the PGI group, where they said the major criteria should be total IgE more than 1,000 and aspergillus specific IgE more than 0.35, with any two of the following other criteria, which is precipitants should be present, or radiologic opacity, pulmonary opacities which are fixed or transient, absolute blood count of eosinophil count of more than 1,000, and central bronchiectasis. Next, in 2013 came the Isham group, where they said those patients they must have one of the following, which is asthma or cystic fibrosis, and the rest is as the same as the Agarwal criteria in 2010. Next, recently, a Japanese group have proposed that aspergillus bronchopulmonary mycosis should be considered in patients where fumigatus is not found, and this should have at least 10 criteria, where all the criteria that we have discussed before exist. In addition to that, they say that peripheral blood eosinophilia of more than 500, but with a current history of asthma or asthmatic symptoms, raised IgE levels, total IgE levels of more than 400, immediate hypercutaneous hypersensitivity for filamentous fungi, not just Aspergillus fumigatus, presence of precipitants or specific IgG for filamentous fungi. The important thing is that both fungi should be same in both these. which is the precipitants as well as the cutaneous hypersensitivity should be to the same fungus. In addition to that, central bronchiectasis, mucus plug signs, and high attenuation mucus on bronchi on CT, they should be diagnostic criteria for ABPM in patients without cystic fibrosis. Next again. Next slide. In cystic fibrosis patients, the diagnostic criteria in addition says that the SPT should be more than 3 millimeters for the presence of Aspergillus fumigator specific IgE in patients who present with more than 500 total IgE. And precipitating antibody should be present. New or recent abnormalities on chest radiography should be present. And these will actually classify for ABPA in addition to the previous criteria that we have spoken about. Next slide. Now, stage-wise, it may be acute ABPA, stage 1, to those in remission, those in exacerbation, corticosteroid-dependent asthma, and quite advanced ABPA, stage 5 or fibrotic end-stage ABPA. Next slide. So, stage 0 is asymptomatic, where the patient has controlled asthma, on investigation fulfills the diagnostic criteria of ABPA, and has not been previously diagnosed to have ABPA. Acute one is those who have uncontrolled asthma in spite of appropriate therapy for asthma and fulfill diagnostic criteria, but not diagnosed to have ABPA. And they have again divided it into 1A and 1B. 1A meets all the criteria depicted, and there is no documented mucoid impaction on chest radiography, CT, or bronchoscopy. But if there is but meets all the criteria, but there is mucoid impaction, with or without mucoid impaction, are 1A and 1B. So with response, clinical improvement should be there, major radiological improvement should be there, and IgE decline has to be 25% or more at 2 months from treatment. Exacerbation, again, as you know, clinical or radiological deterioration with increase in IgE at least by 50% of what it was before. And remission is when there is sustained clinical radiological improvement with IgE levels remaining at or below baseline. Next slide. Pulmonary function usually in stage 1, 3, 4, and often 5 will be obstructive and may not correlate with the duration of ABPA or asthma. But stage 5 usually has a restrictive ventilatory defect or a mixed ventilatory defect with reduced diffusion capacity due to the presence of fibrosis. Next. So how do we manage it? The goals of management are control the symptoms, preserve exacerbations, and preserve lung function. Prevent exacerbation, sorry, that should be, and preserve lung functions. Next. So the drugs that we have to achieve that goal are corticosteroids or anti-inflammatory drugs are the prime treatment used for ABPA. Antifungal drugs may be used, anti-IgE therapy, and antibiotics. I will discuss that in a bit again. Next. So prednisolone is the most commonly used drug. Every 2 months. Escalation of steroid therapy should be an option if IgE levels rise more than 100%. And inhaled corticosteroids may help to control bronchospasm. Next slide. Regarding antifungals, itraconazole is the most common one used as 200 milligrams twice daily for 16 weeks, which may help reduce significant reductions in those who are on corticosteroid, can help decrease IgE levels and resolve pulmonary infiltrates, improving exercise tolerance and pulmonary function. 200 milligram every other day is recommended in those patients who are steroid dependent, have frequent relapses, and where benefit of treatment outweighs the risk. Newer antifungals, as we know, voriconazole in the dose of 300 to 600 a day, or posaconazole 800 milligram per day, shows clinical improvement, but these are more costly medicines compared to itraconazole. Next. Omalizumab per se does not have any effect over ABPA, but is mainly used to control uncontrolled asthma in step 4 GINA treatment guideline. As indicated, it is very expensive It's a good alternative option in patients with ABPA with cystic fibrosis in whom steroid dependency and with contraindications to steroids. It also has a steroid sparing effect and decreases systemic inflammatory markers, usually given as 375 milligrams subcutaneously every 2 weeks for at least 4 to 6 months. Next. Supportive treatment is in the way of antibiotics if there is associated bacterial infection, especially in patients with cystic fibrosis, where you may need long-term antibiotic prophylaxis as well. Airway clearance is of paramount importance by way of postural drainage, and you can use vibration techniques such as a cappella use, hypertonic saline and salbutamol nebulization in very, very tenacious sputums. Avoid exposure to high mold environments, and all these patients should be recommended vaccination with pneumococcal and influenza vaccines. Next. The prognosis with appropriate treatment, long-term control is feasible and durable remissions are common, but progression to stage 5 pulmonary fibrosis may be preventable by maintaining patients on therapy on low-dose steroids where there is continued progression. Usually those with FEV1 of less than 0.8 liters have a worse prognosis. Next. Complications are multiple, which can be recurrent asthma exacerbations, aspergilloma, developing invasive aspergillosis, chronic pulmonary aspergillosis, cavitation of disease, local emphysema, honeycombing, lobar atelectasis, as we discussed, and those related to bronchiectasis such as hemoptysis and recurrent pulmonary infections. So in trying to conclude all that we have discussed, all patients with asthma and cystic fibrosis, regardless of severity of level of control, should routinely have screening for ABPA using aspergillus fumigator. So definitely check their IgE, and if it is more than 1000 and asthma not very well controlled, definitely screen them for ABPA. Glucocorticoids should be the first line of therapy in ABPA, and itraconazole reserved for those with exacerbations and steroid-dependent disease. Establishing IgE sensitization to aspergillus through either skin prick test or measurement of specific serum IgE is a reasonable first step in an asthmatic being evaluated for ABPA. And if there is no IgE sensitization to aspergillus, it virtually excludes ABPA from consideration. If skin testing and or IgE are positive, then a total serum IgE, precipitants to aspergillus and eosinophil count should be assayed. And HRCT is vital and very important for staging of disease, and early detection and treatment can prevent the development of bronchiectasis or pulmonary fibrosis that otherwise occurs in later stages of the disease. And with that, I would like to end my talk. Thank you very much.
Okay, thank you, Dr. Roy Chaudhary. I see in this session there's lots of questions coming up, so maybe we'll be able to take only a few of the questions at the end of the session. So we move on to our next speaker. Our next speaker is Dr. Sandeep Salvi. Dr. Sandeep Salvi is the director of the Pulmocare Research and Education at Pure Foundation in Pune. He's a very eminent clinician researcher of our country and has quite a number of laurels in his hands. So this topic is air pollution's effect on asthma. So I request Dr. Salvi to deliver this.
Thank you, Dr. Thank you, Dr. Moitra, for those kind words of introduction. Wish you all a very good evening. I hope you all can hear me, Dr. Moitra.
Yes, we can hear you clearly.
Okay, okay. So wish you all a very good evening and welcome to this wonderful conference that has been organized on allergy. And I feel very honored and privileged to be a part of this. Over the next 15 minutes or so, I'm going to share with you some exciting work about the role of air pollution in asthma, and primarily going to focus on in the pediatric age group, because I believe that's something that is very, very important for us. Well, life, as we know, starts with the first breath and ends with the last breath. And the period between the first breath and the last breath is what we call as life. Isn't it interesting that life is equated to breathing? You stop breathing and you're not alive. That's how important breathing is for our survival. We all know that we breathe about 6 million times a year, and this nourishes the body with oxygen and gets rid of a very important waste product called carbon dioxide. On a daily basis, each one of us breathes about 10,000 liters of air, of which 1,000 liters of oxygen is extracted by the lung and delivered to the circulation, and about 350 liters of carbon dioxide is excreted through the lungs. 90% of the energy that the human body generates comes from the oxygen that we breathe. Only 10% comes from the food that we eat and the water that we drink. That is how important is breathing and oxygen for all of us. All of us need to breathe pure air, and all of us need to breathe pure air. But surprisingly, if you ask anybody, what do you mean by pure air? Very few people actually know what pure air comprises of. So this is what pure air comprises of: 78% nitrogen, 20.9% oxygen, 0.93% argon, and 0.04% carbon dioxide. If this is what you breathe, this is pure air. However, because of industrialization, urbanization, a lot of industrialization and growth in the number of motor vehicles, the quality of air that we breathe has deteriorated significantly. We now breathe air that is polluted not only by the various gaseous air pollutants, but also by various particulate matter air pollutants. And this is what has been responsible for a significant impact on the human health. This is a very nice slide that talks about the particle size and the deposition in the respiratory tract. So particles which are more than 10 microns in diameter are the ones that are filtered in the nose. Particles up to 10 microns, they only reach up to the upper respiratory tract. If you look at PM 2.5, or particles which are less than 2.5 microns in diameter, they reach up to the lung, right up to the lung parenchyma. Particulate matter of 1 micron, they not only reach up to the lung and the distal portions of the lung, but they also start entering into the blood circulation. And particulate matter of 0.1 microns actually enter everywhere. I mean, every single organ, they enter through the lungs. So it's important to for us to at least appreciate and understand that when we talk about PM 2.5 levels or PM 10 levels, why is PM 2.5 important? Why is PM 10 important? And so on. The harmful effects of air pollution start even before we are born. And this is a very old study that looked at the circulating pollutants in babies who were just recently born in the city of New York. So 10 randomly selected newborn babies were taken, and then as soon as the umbilical cord was cut, they put in a needle into the umbilical cord circulation and withdrew some blood, and then sent it to the laboratory to look for presence of circulating pollutants. And this is what they found. 287 different types of air pollutants were circulating in the umbilical cord of these babies who were born in New York. Most of these were from indoor air pollutant sources. So the message is the placenta does not offer any barrier for preventing the passage of these harmful substances into the growing fetus. So whatever pollutants the mother inhales goes through the fetal circulation into the fetus, and the fetus then becomes exposed to pollutants even before it is born. Children seem to be the most vulnerable population to the harmful effects of air pollution. And here's a very interesting graph that I wanted to show you. How much air does a child breathe as compared to an adult? So the adult over here is, say, this is the purple bar over here is 15 to 18 years, and beyond that would be an adult. So an adult roughly breathes about 0.2 cubic meters of air per kilogram per day. Compare that with a newborn child, less than 1 year, a neonate, and then those who are between 1 to 2 years and so on. The message is children breathe more air than what adults do. And this is important because they breathe so much more air than what adults do, more pollutants enter inside their lungs, and that makes them more vulnerable to the harmful effects of these air pollutants. The green line over here suggests the growth in your lung function from the day you're born. It reaches a peak by around 20 years, 25 years, and then it slowly declines as you become old. This green bar represents people who live in the cleaner areas. The red line over here represents people who live in polluted environments. So you can see that there is a significant decrement in the achievement of the maximum lung function that you can get if you live in a polluted environment, and that remains for a lifetime. So if you are exposed to air pollution from early childhood, you will have small lungs, and these small lungs will remain for the rest of your life. This is an electron microscopic picture on the left-hand side, the brown one, of a grass pollen. And we all know that people who are allergic to grass pollen, when the grass pollen enters inside the respiratory tract, the IgE levels get increased, and these IgE then combine with the mast cells to produce histamine and all the classical symptoms of what we call as allergic rhinitis. Now, if the same grass pollen is mixed with these yellow circles over here called diesel exhaust particles, this is just a graphical representation. So when the same allergen is mixed with a diesel exhaust particle, the allergenicity of the allergen increases by around 50 times. It means that the quantum of IgE that is produced in the respiratory tract, if you inhale the same amount of allergen but mixed with diesel exhaust particles, your body produces 50 times more IgE, and that makes you more allergenic. In fact, diesel exhaust particles are very notorious to even make people develop new allergies. So, for example, you're not sensitive, you're not allergic to a particular grass pollen or any environmental allergen. If you keep on breathing diesel exhaust particles, the black smoke that comes from these vehicles, you will start getting sensitized to many of these allergens. So that has been known for quite some time. I was fortunate enough to pursue a PhD program at the University of Southampton in UK. And this was a collaborative study that I did with the University of Umeå in northern part of Sweden. This was the exposure chamber that they had built. And we then invited these college-going students called healthy volunteers to sit inside this chamber. And if you can see this wall, on the other side of the wall was a Volvo truck engine. And then the exhaust of that was fed into this, this exposure chamber from the base after diluting it about 90 times, simulating levels that you would encounter when you're walking on the streets of Bombay or Kolkata or Delhi. Those are the levels that we produced artificially for PM 2.5 in this exposure chamber. We exposed them only for 1 hour to these diesel exhaust particles. And then 6 hours later, we did a bronchoscopy to take bronchoalveolar lavage samples and bronchial biopsies to see what has happened inside the airways of people who are exposed to diesel exhaust for 1 hour. In the bronchial tissue, as you can see, there was a huge increase in the numbers of neutrophils, in the numbers of mast cells increased, the number of eosinophils increased, and so on. We were also able to show that the histamine levels in the airways was significantly higher after exposure to 1 hour of the diesel exhaust. And when we did the bronchial biopsy, looked for protein staining, you can see that the allergenic cytokines, such as interleukin 5 or interleukin 4 or interleukin 13, those levels, in addition to interleukin 8, was significantly higher, suggesting that 1 hour of exposure to diesel exhaust produces an intense inflammatory response in the airways, just like what you get in acute bronchitis, but no symptoms. These healthy individuals had no symptoms at all. It's a silent type of an inflammation that happens after exposure to diesel exhaust. Now, this is a heat map of India on the left-hand side. The brown and the red colors over here represent those states where pollution levels are high. And you can see relatively, southern states of India have relatively lower levels of air pollution. We wanted to understand what is the impact of air pollution in children, adolescent children, living in the city of Delhi, which we all know is an extremely polluted place, perhaps one of the most polluted cities in the world. So we wanted to see what happens to adolescent children living in Delhi versus those living in Kottayam and those living in Mysuru. So Kottayam and Kerala and Mysuru in Karnataka. relatively cleaner air in the southern parts of India, very high polluted air in Delhi. So we took, this was a study that was done in partnership with Dr. Arvind Kumar, who is a thoracic surgeon based in Delhi. 3,157 children from the 3 cities were selected. We did a detailed questionnaire examination, and we also did spirometry. So this was an extremely challenging study to do because we wanted to understand what is the lung function of children living in Delhi versus children living in cleaner areas of Kottayam and Mysore. So we did 3,157 quality spirometries. And what we found was something very interesting. So the blue bar over here represents Delhi, and the orange bar represents Kottayam and Mysore. Polluted versus relatively less polluted cities. Adolescent school children. Look at the prevalence of sneezing. Look at the difference between Delhi and Kottayam, Mysore. Itchy, watery eyes, cough, itchy rash, shortness of breath, chest tightness, and eczema. Significantly higher in adolescent children living in Delhi. Much, much, much higher. This paper has just been published in Lung India about a month ago. So the previous issue of Lung India has all the details of this study. We then looked at spirometry defined airflow obstruction. And you can see that close to 30% of the children living in Delhi showed evidence of airflow obstruction. And we all know that the commonest cause of airway obstruction in children at that age is asthma. So clearly implying that asthma defined by spirometry is to the tune of 30% in Delhi, but not very different in Kottayam and Mysuru as well. So 22% in Kottayam and Mysuru. So there is, well, not much difference, but clearly much higher among children living in Delhi. So air pollution causing asthma seems to be a very important observation that we made, both through the questionnaire as well as through spirometry. One of the other things that we were looking for was presence of overweight and obesity amongst the two populations. And clearly children living in Delhi, 40% of them showed presence of either being obese or being overweight, compared to 16% of the children living in Kottayam and Mysuru. And then I happened to get this very interesting time trend graph of prevalence of obesity amongst adolescent children in Delhi. So it has been rising from 7.9% to 29% in 2015 or 2016. And now in 2020, when we did the study, the prevalence of being overweight or obese is almost 40% in Delhi children. The reason why I'm telling you this observation is we made this very interesting observation that children who were obese, they had an 80% greater odds of having asthma as compared to children who were not overweight or obese. Obesity or overweight associated asthma was a very strong association that we found in this study that we reported. And the odds of having asthma amongst obese children was much higher among children from Delhi. Now, this is an interesting observation. We all knew that obesity causes asthma, but here is a very interesting diagram that I hope you will be able to appreciate. Air pollution, we know that air pollution can give rise to asthma because of the pollution, impact of pollution itself on the airways. However, air pollution giving rise to obesity, and this obesity contributing to asthma is something that we have not known much for in the past, but the last 5 years, 5 to 8 years, there has been a flurry of publications suggesting that air pollution is associated with obesity. And if you look at the number of publications that are there in PubMed, as you can see here, the growing number of publications, almost about 100 publications, 100 papers published every year showing the impact of air pollution on obesity. So air pollution, so you become obese not only because of the type of food that you eat or the lack of exercise, but you become obese because of the quality of air that you breathe. And that obesity then makes you more vulnerable to develop asthma. So this is a very nice picture that I found. A child living in a clean city, a child living in a polluted city, obese, and air pollution is very strongly associated with all these obese characteristics. So I wanted to focus more on this observation because this is something novel and doctors need to be aware about it. Let's end the presentation with what are the solutions. It's the moment you talk about harmful effects of air pollution giving rise to asthma in children, what needs to be done? Obviously, the first thing that needs to be done is to reduce the emissions from sources through the political media, through, there has to be a political will to reduce the levels of ambient air pollution. But did you know that we produce a lot of air pollutants inside our house as well? One mosquito coil is equal to 100 cigarettes. One dhoop agarbatti, small, just 4 centimeters dhoop agarbatti, 4 inches dhoop agarbatti, produces as much amount of PM 2.5 pollution that is equivalent to smoking 500 cigarettes. One mosquito coil, 100 cigarettes. One dhoop agarbatti burns only for 15 minutes. The mosquito coil burns for 6 to 7 hours. But that dhoop agarbatti produces as much amount of pollution that is equal to smoking 500 cigarettes. So our house is a source of air pollution, whether it be the mosquito repellents that we use, the deodorants that we use, the perfumes, the scents, the house dust, and so on. A lot of pollution itself is being produced inside a house, and we need to be aware about that. How can you protect yourself from the exposure to different air pollutants? The mask, I believe, is a very important solution for this pollution. People have started wearing masks all over the world to protect themselves from the COVID infection. The same mask can protect you from air pollution. In fact, the masks were developed in the olden days to prevent yourself from inhaling all the pollutants. And I think it's time to make this a culture in our country where whenever you go out, you should wear a mask, not only to protect yourself from the COVID infection, but also to protect yourself from the harmful effects of air pollution. So it's a very, very useful solution for pollution. Nose shields is this, some people are trying to develop a nose shield, something that you just plug in, acts as a filter, prevents the pollutants from entering inside your respiratory tract. Cleaning your nose on a regular basis, as you can see here, Jalaneti, an ancient Indian tradition of washing your nose on a daily basis. Just like how we brush our teeth every day, people in the ancient days used to wash their nose every day, so that whatever pollutants have gone in, they're flushed out. Other than that, promoting health and increasing the resistance to the harmful effects of air pollution by improving ventilation, closed spaces, pollution levels become more dense. Regular exercise, you want to increase the activity of your lungs. So regular exercise is going to protect your lungs. And then a healthy diet comprising of adequate amount of antioxidants, especially fruits and green leafy vegetables, is something that can be done. Simple solutions to improve your resistance to the harmful effects of these air pollutants. So I'm going to stop over here, and if there are any questions, I would be happy to take. Dr. Moitra.
Thank you, Dr. Thank you so much. It was really a very interesting talk that you have given. So I'll just quickly go through this. There are quite a number of questions, but I don't think we have time for all. So our first question, this is for Dr. Shushmita Roy-Choudhury, that, Madam, does COVID-19 has any impact on the ABPA like mucormycosis?
Now that's a very interesting one. I think it's only time that is going to tell if ABPM is going to rise. What we know for sure is that asthma exacerbations are usually due to viral infections mostly. COVID is a viral infection, and we have seen that our patients who have had asthma have had an exacerbation or persistent symptoms for a slightly longer time. Having said that, mucormycosis is because of the immunocompromised status, but ABPA gets better with oral steroids. So it's very difficult for me at this point, without any evidence, to say whether it is going to increase or decrease. We will just have to retrospectively come and see it back. But you would treat any existing patient of ABPA just the same as you would treat a patient with ABPA with an exacerbation if they had COVID.
Thank you. Next question has asked to Dr. Sanjeev Salvi from our aerobiology group. They have asked, sir, since the pollutants increase the allergenicity of the pollens, do you think that the impact will have an enormously impact the patient's health? in the times to come if the pollutant level in the cities are not controlled?
Absolutely, very good question. If you look at the prevalence of allergic symptoms and asthma in areas where the pollution levels are high and the pollen levels are also this level, the prevalence is very high. If you go to other areas where the pollen levels concentration is exactly the same, but the pollution levels are low, the prevalence of allergic symptoms is much lesser in those areas. So clearly, I think air pollution is driving the current allergic epidemic that we are seeing. Simple observation during the COVID pandemic, look at the number of children who visited the doctor for an asthma exacerbation or for allergic symptoms. Extremely low, because because everything was shut down. The levels of air pollution came down significantly, and a significant impact on the allergic symptoms and asthma, especially in children. So I think the point that the delegate has made is very valid and very important.
Thank you, Dr. Salvi. Next question is from Dr. Srivastava, a postdoctoral fellow from University of Delhi, to Dr. A.G. Ghoshal. Dr. Ghoshal, is he there? Sir, are you there? Well, then I think that I'll forward this question to Dr. Ongira Dasgupta. Ongira, are you there? Ongira?
Yes, I am.
Oh, yeah. So I'm just forwarding this question to you. So this gentleman has asked that the COPD is actually a Th1, Th17, and also to some extent Th2 modulated inflammatory response. And so in which the extrinsic triggers are important to elicit the response. Do you think there can be innate immune system modulators which can have a better impact on the COPD management rather than going into the blanket therapy of the bronchodilators and steroids?
Okay, so the essential. So you have to answer the innate immunity portion.
What is asking that COPD is a Th1, Th17, and the Th2 pathway mediated responses, which occurs to extrinsic stimuli. So the innate immune system drives the adaptive immune system. So do you think there are some, nowadays we have many innate immunity modulators, which is coming up. So do you think they have a role in the COPD management? Well, this is I think, very futuristic.
Absolutely. Hello.
Hello.
Now I can hear you.
Hello.
For some reason, it got stalled. So basically, what this question means is that how do we personalize treatment? Because COPD patients may not be only Th1 and Th17. They might be having a Th2 component to it as well. So the challenge for us clinicians, I'm talking from a completely clinical point of view, is to find out whether the type of COPD or the phenoendotype of the disease is either a Th1 driven or a Th2 driven. Most of the times there can be a lot of overlap. We wouldn't be able to understand what it is, but the predominant nature we can support, or we can estimate if we do the correct tests for the phenotyping, the ones that we discussed in the talk today. And about innate immunity modulators, I would forward that to you, Shoivalda.
The innate immunity modulators are really coming up and is the next thing by which we can modulate the response. But they are in the research basis. We don't have very clear-cut molecules nowadays, except the BCG vaccination. But that too, we have seen that it has lots of other shortcomings, which can modulate the innate immune system and can change the activity of the adaptive system. So that's the more researchers are needed in this field for specific diseases like COPD. So shall we go on to the last question? This last question is directed to Ongira, to you. Mm-hmm. So this doctor has asked that, Madam, this sputum inflammometry, since it is not available in most of the centers, in clinical centers, so how do we have an access to it it by creating one in our centers? I think that's a question which is more of needs. Yeah.
Some
so what do we
logistic
do?
problems.
He actually has a logistic issues. Yeah.
So if you asked me, I would say build up your own garden. So open your own lab, get some training, get some laboratory technicians, and get going. And if you're unable to find funds, I'm almost sure that if you wrote the correct proposal to one of the funding agencies, you would get through. This is because I know ICMR projects have gone through based on sputum inflammatometry. So the correct proposal has to go through if you don't have funds. And if you have funds, I would recommend that just get going. It's high time.
Okay, I think that answers your question. So anyway, so there are, I think 20 questions has come up, which is not possible for me to take up. I think I can share the consultant's mail ID. So you can, if you want anything, if the consultant speakers allow, then if you can share their mail IDs with the delegates, they can ask this, email the questions to you if they have. There are some many questions that come up. Anyway, I must thank all the speakers. This was a wonderful session and which was made successful by all the delegates and the speakers, all the faculty members who have joined this. I thank you all and I thank you once again. Have a great evening. Thank you so much.
Thank you for having us.
Bye.
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 Bye.